Welcome everyone. Happy World Sight Day. Renowned American author Helen Keller once said, and I quote, "The only thing worse than being blind is having sight, but no vision. There's no better way to thank God for your sight than by giving a helping hand to someone in the dark."
Good evening, everyone. I am Sarna Kamal, working as senior optometrist in Jayad Military Hospital.
Good evening, everyone. I am Palniyappan Lakshmanan, working as a senior optometrist in Al Zahra Hospital, Dubai.
It's a great pleasure to welcome you all to this Knowledge Fest, OPTOVERSE 2, on this occasion of World Sight Day. Representing optometry all over the globe, so we call it as OPTOVERSE, and this is our second version. We are happy to collaborating with United Society of Ophthalmology for this event. A special thanks to Dr. Omnia Hammam for enormous support.
As we all know, World Sight Day is observed annually on the second Thursday of October month since the year 2000. The aim of this day is to draw attention on blindness and vision impairment.
Myopia prevalence predicted by World Health Organization will be 50% of the world population by 2050, where 10% will fall under high myopic category. At least 2.2 billion people live with vision impairment. In that, 1 billion cases could have been prevented. In order to prevent, we need awareness. And to spread the awareness, we are here today. As we all know, prevention is better than cure.
Let's move on to today's scientific session, and our first session will be the opticals. As an eye care professional, every day we are measuring pupillary distance. But do you know what is the terminology used to mention the distance between the eyebrows? It's called glabella. By saying that, I would like to call Optum Sana Merchant to moderate our first session. Any questions, please put it in the chat box. After each session, there will be a panel discussion to answer the queries. Over to you, Ms. Sana.
Thank you, everyone, and good evening to all. Let us start our session by welcoming our first speaker for the day, Mr. Murtaza Ibrahim. He is currently working as a senior manager and trainer with Rivoli Vision Academy and has previously headed professional services in Lenskart. He is going to be sharing his experience today on progressive troubleshooting like an expert. Over to you, Mr. Murtaza. The podium is yours.
Thank you, Sana, for that introduction, and happy World Sight Day to everyone connected. I'll quickly share my screen. Can I get a quick confirmation if my screen is visible?
Yes, it is visible, Mr. Murtaza. You can proceed.
Yeah, thank you. Okay, so it gives me an immense pleasure to be a part of this forum, and progressive is always close to heart, a topic which is always considered to be unique when it comes to dispensing. And today I'm just going to cover on progressive troubleshoot, though the time slot given to me is quite cramped, it's just 15 minutes, but then I'll try to cover as much as possible. So just going along. To keep it simple, basically, I would always suggest to follow your own abbreviation. Here, I have taken a very simple abbreviation, which is lens model. This is something which we follow, and it gives us enormous result. So whenever there is a troubleshoot, basically, it is important for us to understand from the customer shoes or the patient's shoes what actually they are feeling. So it's a stepwise process, and to remember what exactly we have to do when a customer or a patient visits your clinic with a complaint. So basically, I just follow this lens, which says lens L stands for listen, E stands for empathize, N stands for note, and S stands for solve. So it is important for us to, even before stepping into troubleshoot, at the first place, we should always ensure that we take the best possible care so that the customer not fall into that troubleshoot category. But if they still fall in that category, then it is important for us to take the stepwise approach so we don't miss on important areas. The first thing is, no matter how expert you are with your progressive troubleshoot, it is important that you listen carefully to what customer is complaining about. Make sure that you empathize with the customer. Empathize, which is the second step, is important because there can be the effect of bad optics, which customer has faced over a period of time. And it is important for us to make sure that we empathize. We apologize if there is any problem from our end because of any mistakes that is there. Then we have to get into a stage which is like noting down why a particular complaint occurred, and make sure that we go into the final step, which is solve. But before getting into solving the case, it is important that first three steps are clearly documented and we don't leave any stone unturned before suggesting a final solution. Now, solution, once you arrive at the solution, the only stage that is left over is the follow-up. That is something which we need to add here, which is like for customer experience and engagement, it becomes very important. Now, going ahead, I'll just quickly share how the dispensing happens in any given dispensing setup, any given optical setup. The very first step, which plays a major role, is the prescription of the customer. Based on the prescription, we get on with the frame selection, and then we go for the design recommendation, and then finally we take the measurements and we get into QC and the delivery stage. So this is something which goes stage wise, and this is absolutely okay. But when we come for troubleshoot, basically any customer walks in for troubleshoot, the first intention is be it a store staff, be it a support staff who is helping with the dispensing, or be it optometrist. The first mistake that we do is we directly jump on with the prescription, which is which actually has to be the last stage when it comes to troubleshoot. So basically, my approach, or a simple way, or say if you want to be expert with troubleshooting, you go in the reverse stage. So I would start with the QC and delivery process, then on to measurement segment, then I'll go with the design segment, then with the frame selection segment, and finally I'll think about the prescription. I'll not straight away go to the prescription check unless and until there is a complaint from the customer which directly shows that the prescription is majorly at fault. So prescription will always come at the final stage for me to check if there is anything wrong. But then I'll go stage wise on first confirming the QC and delivery process was clearly explained. Then it will be checking the measurements, then whether the design recommended to the customer was correct, then the frame selection, and finally prescription. Though few steps will interlink and you may have a frame and a design coming front and back, but always ensure that prescription is the final one which you will be considering for a double check before providing any solution. Now, let me just quickly speak on the delivery process. Basically, when we are doing a delivery, it is important that for the first time user, you dispense them inside the clinic. Now, when I say dispense them inside the clinic, it is important we give all the proper tips on how to use the lens, where they will find the distance zone, where they will have the near zone, make them also feel the distortion zone. And it is important that you go stage wise, wherein you show them distance, show them near, and then make them feel the intermediate, and finally the distortion areas. For existing user, make sure that you allow time for them to get used to the design, allow some time for them to, feel the lens and then wait for the queries. Explain about the adaptation time. Now, when I say delivery process, this happens at the first stage, but many a times because of the busy schedule, or if the customer drops in the shoot for delivery, or sometimes customer will get it collected from some friends and relative, we may actually not be able to will not be in a position to actually go through all this step. And then when they come in for the first troubleshoot, it is important that you follow the step. Also, give assurance of timely assistance, just in case when we're talking about adaptation, always ensure that we should be available to customers. So the follow-up has to happen from our end if the delivery process was not explained properly. Now, coming to QC measurement, basically on a progressive, this is very important. Every progressive lens is going to have micro etchings. So make sure that you are actually marking the micro etchings. You are using the layout chart, and you are checking for the fitting cross, which is this, and then you will be checking for PD. So the moment you take the frame here and put it on this scale, you'll be able to check for PD, and you can check the fitting height here, right from the fitting cross to the bottom of the frame for the fitting height. So this is going to help you understand if the measurements that you have taken during the ordering process and the final measurement which you have done. If QC was all okay, then this step will help you understand if the fitting was okay. And then it will also help you understand if there is any problem at this stage. Then if majorly the fitting height and the PDs are not in place, then you will have to take a call wherein you will have to replace the lenses to fix the issue. Going forward, let me just share a few important terminologies that will be required when you are trying to troubleshoot a progressive. Now, when we talk about troubleshooting a progressive design, there are few adjustments and alignments which can happen on the frame surface, on spectacle frame, and this is going to help solve many conflicts. So the first one is the vertex distance. Now, when I say vertex distance, is the distance between the back of the lens to the front of the cornea. Very simple one. Basically, the vertex distance can be adjusted using the nose pad. You open the nose pad and the vertex distance actually goes closer. You close the nose pad, it increases. Also, vertex distance can be adjusted by end piece. So you have temple and the end piece can be adjusted in such a way. If you are keeping it tighter, the vertex distance is going to reduce. If the temple end is going to be loose, then the vertex distance increases. So this actually helps you. This will give you a clear understanding on how you can play around with the vertex distance. Moreover, to use as a golden rule, you should have an optimum vertex distance or try to maintain the vertex as close to the eye as possible, because every change in the vertex distance is going to give you an angular change in the field of vision. So this is very important that you keep the
Excuse me, Mr. Murtaza.
Yeah.
Your voice is cracking in between. It's not clear. So if we can look at that, and then you can continue.
Am I okay now?
Yeah, that's better now.
Better? Okay.
Yeah, better. Continue. Sorry.
Yeah. So the first thing which we discussed was vertex distance. Now let me go on with the other term. Basically, this is a very famous term when it comes to a progressive dispensing. So we have something called as pantoscopic tilt, which is very famous, and any troubleshoot that we get, the first thing we jump is into looking at the pantoscopic tilt. So let us understand what is this pantoscopic tilt. Basically, the frame that you see at the top, this is orthoscopic. So in relation to the ground, it is like exactly 90 degrees. It is not towards the cheek or away from the cheek. So this we call it as orthoscopic. So the frame which has an orthoscopic tilt will require some pantoscopic to make sure that the progressive adaptation is better. The one which you see here, second one is your pantoscopic tilt. So it is the frame angle towards the cheek. So the plane of the frame at the bottom is angled towards the cheek. This is something which is acceptable for any frame, particularly when it comes to progressive design. So if it is orthoscopic, we should ensure that we actually try to.
Murtaza, your voice is cracking. Your voice is breaking in between.
Just a second, let me check mine. Is it better?
Yes. I will interrupt you again once it is.
Yeah, just let me just hold on and I'll just change my setup. So
sure. Now it is better. You can continue.
Better? Okay,
I
I think there's some
Mr. Murtaza, you are using the Bluetooth headset or a wired one?
No, I'm actually on my regular this thing. Let me just raise my speaker and let me try.
You can, if you have any headset, you can use better, or otherwise you can just continue. Okay, thank you.
Okay, yeah. Is it better?
Yes, it is.
Okay, fine. Thank you. Sorry. So let me continue. Now, once you are ensuring the parameters is adequate, this will ensure that the adaptation is faster. And then you have finally the retroscopic tilt, which is like the frame moving away from the face, and this will actually make the thing worse. Why I say worse is because the reading area goes way too far away from the eye, and the zone that we are going to feel in the progressive is going to be very minimized if we're going to be a retroscopic tilt. So ideally, a panoscopic tilt is required. So this is panoscopic tilt. Now the third one, which is going to have an impact when you are actually going to make any adjustment on the progressive. So this is your facial wrap, this wrap on the frame, which is actually going to make an impact. So as you increase the wrap, this is going to make sure that the peripheral disturbances are going more closer to the frame will go closer to the eye, and the peripheral disturbance are minimized. And finally, whenever we think about progressive lens,
Mr. Murtaza, do you have a headset that you can use? Because it is on off clear. Audience are not able to understand since your voice is breaking. Then it's clear, then again. Audience, please hold on while we try to fix the issue. So if anybody has a question while the session goes on, please type the questions in your comment box so that we can take it up after the session is over. During the panel discussion, we will like to discuss with our speakers and we will take the questions forward. And we'll help you all to understand and clear your doubts. While we fix the issue, you all can type in your questions and we will be able to solve your doubts after the session is over.
Okay. Am I audible now?
Yes, you're audible now.
Okay, just a second. I'll just switch on my camera. I'll just share my screen. Okay, is it good now?
It is much better. We can
Much
continue.
better. Okay, thank you.
Welcome.
I'm sorry for those break. Actually did not recognize it when it was coming in messages. Okay, so let's continue going forward. Now, I just have a case, and then I'll just want all of you to just respond on the chat box here. Not want people to be unmuting yourself. So I'll just present a case here, and I just want you to just think of the approach which I was talking about. I was talking about a step down approach, which is think from the delivery perspective, then the QC and measurement perspective, then your lens design, frame design, and finally refraction. Okay, So this is a case wherein a 43 years old female, existing progressive wearer, she has a complaint of, on reading newspaper, books, or looking at Android phone, the image appears to get narrow. Okay, narrow in the sense to just like to keep it more specific. When she looks at the top of the book, it looks to be broader, but the bottom of the book seems to be narrower comparatively. So this is the complaint. Now, by profession, she is a librarian, and this happens to be her old RX. Just for discussion sake, I've kept very simple. Right eye is 2.25 spherical, left eye is plus 250, addition 1. And we have A size of the frame, which is 52, B size 30, DBL 16. The frame is rectangular metal full frame with nose pads, right? PD for both the eye happens to be 32, and fitting height for the frame is 21. Now, the design that this particular customer was using, it was a basic progressive design. Now, new RX for this customer was 225 for the right eye, which is same. Left eye it was 250, and addition was 125. A size for if you compare it with the old glasses, it is 53. B size was 31. The DBL was 17, and with regular rectangular metal full frame with nose pad. So the frame was almost similar to what she was using earlier. PD again was 32 in both eyes. So this is the case, and this time around, the second new pair was a wider design. So I just want the participants to just respond to the chat. What do you think could have been wrong here? What went wrong? The new glasses were received as per the parameters were ordered, but what do you think? What could be the cause, and how would you rectify the same? The case is just in front of you. Just for the want of time, I'll just keep this case on for another 30-35 seconds. Just in the meantime, I'll just check if my voice is clear.
Yes, you're clear and it's
Okay.
clearly audible.
Thank you. Thank you. Okay, so I've seen like there are some responses coming in. I'll just some says we can adjust the nose pad. Frame size should be same. Nose pad adjustable. Add pantoscopic tilt. Okay. We can adjust the nose pad. Fine. Good. So responses are coming in. Keep them coming. So what I'll do is like as you are thinking about the case, I'll just get into the next slide, which will talk about what all observations or what all note or analysis that we should be making from this case. So first thing is like we evaluate the fit. So when I say we evaluate the fit, please consider the fit which might be one of the major cause. When I say fit, this is like how the frame is sitting on the face. Okay, that is one area. Next, when we talk about design, if you see the previous case, I'll just go back one slide. You can see the design. It was basic design earlier, and now it is a wider design. So definitely the design is taken care because there's some increase in addition power. So if you understand the basics of progressive, as the addition power increases, the distortion may increase on the lens, and that is why the customer is already upgraded to a wider design. But still, she is complaining of a narrow image when she looks at the near objects. So here, customer is already upgraded, okay, and addition has slightly increased. Now, frame selection, if you go with the frame selection, there's not a major change except for 1 mm in the A size, 1 mm in the B size, and overall 1 mm in the DBL. Okay, so there's not a major change in terms of frame. Now, evaluating the prescription, if you see overall the prescription, the only difference that you have is, for reading, but for distance, there is no change, right? So distance remains same, only reading 0.25 changes there. So now overall, when you see the other three areas are not majorly getting impacted, but you have this fit, which is one area which needs consideration. So from the solution perspective, if you look at it, then the first thing, there were some answers coming up on the chat box which was talking about pantoscopic tilt. So here, yeah, definitely when we think about giving a solution, if you want the impact to be really good, then club it on with the vertex distance. And that is why in the previous slide I was talking about those terminologies. You can increase the pantoscopic tilt and decrease the vertex distance. So if both are done together, it is going to improve the overall optics with the lenses. Now that can also be a possibility that you check and verify the fitting height and PD. Okay, if this is not working, but the primary solution can be here. And finally, you can also verify the ad power once again, because not necessarily that the customer would need the ad which is mentioned. The customer may need a lower ad as well. So first solution which would be coming for this particular case would be trying to do the adjustment on the frame. If it is still not working, then you go for fitting height and PD measurements. And finally, verify the ad power once again. So that should be the sequence. I would just request the moderator to just let me know how much time I am left with.
You've actually exceeded the time, so
Okay,
you
so
can quickly wrap up.
Yeah, so I'll just stop here. Basically, I just wanted to quickly move ahead and just share the last two slides. Basically, this is a grid which is there, which talks about two stage of troubleshooting. Stage one is going to be like if you consider your prescription PD and fitting height to be accurate, then based on what customer is complaining, which is in the first column, you can do these adjustments to ensure that the progressive these lenses can be saved. All you have to do is you have to wisely choose what kind of adjustment you are going to make on the frame so that it gets adapted to your customer. So one is first stage troubleshooting, wherein you need not replace the lenses for customer. All you have to understand is what kind of complaint they are highlighting and what adjustments you will do on the nose pad, vertex distance, wrap angle, and pantoscopic tilt. Right? And then you have a second stage troubleshooting, wherein here your prescription PD or fitting height actually is that question mark. Right? Now, for this, the customer complaint is going to be something like this, wherein they say they have to move the reading material, or the distance vision is blurry, near vision is blurry, intermediate vision not clear at one side, and close an object appearing oblique. It's not straight throughout. So this will actually give you a heads up that there is some error which has happened on the prescription or pupillary distance or the fitting height. So there are two stages. Stage one, which talks about you can actually make adjustments and alignments on the frame and still save your progressive lens. Make sure that your customer is happy, but you should be wise on what kind of adjustments and alignments you will do. And stage two, which talks about error which would have happened during measurement or error which can happen because of prescription. So with that, I'll just wrap up. Thank you. Over to you.
Thank you, Mr. Murtaza. It was indeed an insightful session to understand when a customer comes to us with a complaint, how do we resolve the issues? So let's move forward with our next speaker. Our next speaker is Professor Ramchandra V. Sheth, who is currently the HOD of AJ Allied Health Institute, and he is the Joint Secretary of ESCO in India. Welcome you, Mr. Ramchandra. You can take the session forward. He will be discussing with us today on artificial intelligence in ophthalmic field. Over to you, Mr. Ramchandra.
Thank you, Sana, for that lovely introduction. I'll just share my screen first. My voice is clear?
Yes, your voice is clear.
Are you able to see my slide?
Your slide is also clear.
Okay, thank you.
Welcome.
So, good afternoon, all who are participating in Dubai. I thank UAE Indian Optometry Forum on behalf of ASCO India for giving opportunity to talk on this virtual international webinar. So before I want to start this talk, I just quote myself to Peter F., who has said that if you want something new, you have to stop doing something old. So innovation starts with the creativity and imagining new things and exploring the idea into the real world. Education system, being a creative, has explored into many paths and now has taken the stage of virtual e-learning. So this COVID era has got a lot of opportunity for the mankind to think innovation in the healthcare sector. However, this technology is changing the way diagnostic methods are likely to be carried out in future. However, this not replace traditional methods, but to add the alma mater of our optometrists or ophthalmologists. So this is the reason I was made to take this talk, artificial intelligence in ophthalmic or optometric field. My voice is clear, right? If any interpretation is there, kindly stop me.
Sure.
Yeah.
Your voice is clear.
Okay, thank you. So let me start with the asking question, and at the end, you may get the answer for you. Are you ready for future? The question, you can answer it in the chat box. Okay, some questions are answering it. Some yes, we have to be in future. We have to think about future. So that is the reason I'm taking this talk. Next slide, please. Not moving. Yeah. So this is the objective of my today's talk. I'm going to briefly talk about this because of the time constraint, which is given only for 10 minutes. So I'll just try to finish as much as possible with this objective. So we all know that future is AI, artificial intelligence. There is a study which is done by Jan, artificial intelligence in healthcare, past, present, and future. So according to his study, what he has seen that, so one of the important way to understand or diagnose the clinically is the diagnostic imaging. So diagnostic imaging is currently the highest and most efficient application of artificial intelligence based and will likely to further expand as imaging modality become advanced and multimodal. So with this, you can see in a pie chart where you can see that diagnostic imaging was one of the important area of our even in ophthalmology or optometry field. So with this particular study, we can able to understand what is the importance of the artificial intelligence. So what is the role of artificial intelligence in optometry? So the question should be raised over here: why artificial intelligence is required when optometrists are doing so many things? So that's another way to understand about the artificial intelligence in other end of the other end of the discussion. So as we said, so why when optometrists required, when machine can screen and do everything, so still there is a lot of requirement will be in between. There is a bridge has to be between the artificial intelligence and optometry. So with this knowledge, what I can tell you about that. So there are during the COVID era, there are so many things was happening because we are not able to understand certain things and all, because this is the area where we can able to promote ourselves for the clinical evaluation. So what are the application of artificial intelligence? So there are several artificial applications will be there. You can see that corneal topography, dry eye diagnosis, smart intraocular lenses, glaucoma diagnosis, fundus topography or fundus photography, or optical coherence topography, or contact lens fitting assessment, binocular vision assessment. All these things can be done in the form of artificial intelligence. But due to the time constraints, I'm going to just touch a certain part of the models. I'm not going to talk all the models because it will take longer time to you to understand. I'm explaining this each model. It will be a very difficult task for me. So let me understand how artificial intelligence working. You can see in this particular picture, you can see that you have an input over here in the form of a fundus image. Here as an optometrist, we enter certain features in the computer, and the machine try to classify that and we'll get as an output. So that's what the difference between the normal machine learning. And when we're talking about the deep learning in the form of artificial intelligence, you have an input over here. Depending upon the artificial intelligence, it extracts the features and classify the feature, and that's what we get the output as our whatever this one. So you can see this particular graph where you can see that you have x-axis as amount of the data, and y-axis you have a performance. You can see that both classic machine learning and deep learning, you can see that artificial intelligence has a major role in our practice. So you can see that, so even though optometrists are there, even though they're doing the evaluating the patients with the help of the instrument, but still there is a lack in the diagnosing the clinical conditions. So that is the reason. So artificial intelligence plays an important role where you can able to diagnose, you can classify them accordingly. So this is about how the artificial intelligence working model. So I'm going to talk certain models you to understand how that is artificial intelligence working in optometric field. So one of the model to predict the refractive error. So there is a study which is done by Vadirajan, deep learning for predicting refractive error from the retinal fundus image, which is published in the 2018. What he has done that he has taken the fundus image, and with the help of the artificial intelligence, okay, he extracted this feature, and as in the form of output, he has classified them as a spherical component and cylindrical component and spherocylindrical component. That's what he has done that. So with this model, we can understand that fundus image from the input of a deep neural network consisting of 3 residual blocks and alteration layer to learn the most predictive eye feature and to fully connected layer. So that's what we can predict what is the refractive error which is that particular patient has got. So this is the one of the models. So I already discussed one model now. So we'll go ahead with another model. So when we want to diagnose a dry eye, it's the most sophisticated way to diagnose clinically. It is most sophisticated diseases to diagnose this one. So we have a lot of algorithm will be there to diagnose this one. So there are different tests will also there. So you can see that there's multi type of tests are available to diagnose the clinical condition. With the help of the artificial intelligence, where we can furtherly evaluate this thing, and we can able to diagnose the dry eye condition. So this is how we can this is the way you can approach over that. So you can see that DES2 algorithm approach, it will overcomplicate yourself to diagnose the clinical condition. So when you do certain alteration in your test methodology, it will oversimplification will happen. With the help of the artificial intelligence, where you can able to diagnose the clinical condition in accurate manner. So with this 3 models which I was able to explain you, there are multi way to explain about other model also. So that's what we can able to diagnose the clinical condition about the dry eye. So in near future, the artificial intelligence will play an important or very helpful role in the many points in certain in the chain of prevention, diagnosis, and treatment of ophthalmic diseases. The term theme in eye care team will become even more important than because than the ever become artificial intelligence will allow for an unpredictable level of appropriate delegation to team members with a subsequent level of the training and supervision of the optometric field. With this, I conclude myself. Okay, so technology won't replace teacher, or even optometrist, but teacher or optometrist who use technology will probably replace teacher who do not use the technology. Thank you. Any questions you can ask me?
Thank you, Professor Ramchandra. It was indeed a wonderful session, and it has surely thrown light on how artificial intelligence predicts refractive errors and how it helps us diagnose clinical conditions. Thank you so much for your presentation. Let's move forward with this, and we will have an audience poll right now. There will be some questions that will be shown up on your screen. After this audience poll, we will move forward for a panel discussion with our speakers for this session. So the audience poll is up right now. You all can read the questions and answer them. So our first question is, it's difficult to measure PD in an isocornea. True or false? Select the best possible answer that you think is right. Our next question is, even 1 millimeter error in centration of progressive lenses, patient will be still comfortable. True or false? Our third set of question is, Norway calibration tool is used for calibrating pupillometer. True or false? And the last question for today is, the first FDA approved AI based instrument to detect diabetic retinopathy is IDX-DR. True or false? So I hope our audience has answered this question. Let's move forward with our panel discussion here. So we will be taking some questions that our audience has highlighted here. So our audience would like to know, Mr. Ramchandra, how would artificial intelligence be applicable on contact lens fitting? So if you can highlight some aspects of contact lens fitting with artificial intelligence, it will be helpful for our audience.
Definitely. So it is a very good question. As I told you, it has a wide variety of artificial plays an important role. So I will share my experience. I have invented one device to measure the Shermas with the help of the Shermas and pH. I invented this particular instrument, and we have done a study on this to understand how pH and Shermas value can be measured. So when we're doing a study, so what we have understand that, so when we giving this study to record the value of pH value, okay, there were two examiners. Both examiners doesn't know how don't know anything about this particular test, and they have graded. When we analyze that particular test, okay, so it was giving a lot of surprise to us. Both examiners not able to judge proper value of the pH value. So this is how the things will happen. Even in the simple way, we are able to understand that. So when I put this in artificial, we have made an algorithm to record this pH with the help of the programming. Okay, so we have developed a program and to measure this pH value and Shermas value. So we have then planned that way, and we have done a study on that. We have come to know a lot of things from the this particular aspect. So this is how one simple example. Even when we are talking about the contact lens, so where especially soft contact lens doesn't make much a difference when you can practice very easily, where we can evaluate it easily, especially in the cases of RGP or special contact lenses. You take the picture. Even in the topography system, we have some called as a fit assessment. You, before ordering the contact lens, the instrument will try to analyze certain parameters in the topography system. So this artificial intelligence will tell you so whether this lens is going to fit or how that difference is, that all the things can be able to judge with respect to that particular patient. So this is how the things we can change a lot of things in the artificial intelligence.
Good to know that. It's good to know that different contact lens measurement aspects can be used through artificial intelligence technology. Good. We have another question from Mr. Murtaza. So our audience would like to know, how do you measure pupillary distances in squinted eyes or pediatrics who have squints? So would you like to answer this and clear our audience doubts?
So generally, when you measure PD, basically, for measuring PD, you have this PD device. When you are using this for kids, again, you need to see whether the kids are cooperative when you are using these devices. there is a knob available in your PD meter which can actually close one eye at a time. So it is always important that you close one eye when you are trying to record the PD for any customer at any age who has squint. For kids, at times it becomes important that you do this without the PD meter, because you just show them some interesting thing, and then you can just try taking the PD marking on the frame that they are using. So basically, it is always important that when you are marking or measuring PD, if they are cooperative kids, it is fine to do it with the PD meter. If not, then just the frame which is selected for the kids, you can make them wear that, close one eye, show object of interest, and then start taking the mark. Make sure that you are exactly in the straight line. You should be in the same line as the kid is, to avoid the parallax error.
So basically, monocular PDs should be taken for squinted
Exactly.
patients. This is what
Yes.
is the conclusion out of this
Correct.
discussion. Good. Thank you, our speakers. Thank you. Thanks to both of you to help us understand whatever topics you all have taken. Let's move forward with the session, and I hand over it to our host to continue with the next session. Thank you so much. Over to you, host.
Thanks, Sana, and all the panelists. Now we'll move forward to our session number 2. The posterior segment of each eye is composed of 130 million photoreceptor cells. Each one of these cells composed of 100 trillion atoms. Do you know that more than all the stars in the Milky Way of a galaxy? Let's move on to our second session, the rear view or posterior chamber outlook. I'd like to call upon Optom Ujjwal Kumar Roy from Moorfield Eye Hospital to moderate this session. We are open to questions at the end of the session, so audience, keep ready your question. Over to you, sir.
Good afternoon all, and happy World Sight Day. So for this session, our first speaker is joining us from Australia. Is optometrist Mr. Soumya Mukherjee. He has completed his master's from University of Melbourne, and currently working as a clinical tutor over there. So today he'll be presenting us on population variability of temporal raphe in myopia. Mic is yours, Mr. Soumya.
Good evening, everyone. Greetings from cold and rainy Melbourne today. And thank you, OPTOVERSE team, for inviting me to give this talk. My topic for today is population variability of temporal raphe in myopia, as you have seen. So what is, give me 1 second, I'll just share my screen. So what is temporal raphe? Temporal raphe is a line which bifurcates the retina into two halves, and it was first identified by Wallace in 1836, Michaelis in 1842, and many others. Ballantyne in 1947 described the anatomical structure as a space that makes the two hemispheres of the retina, otherwise known as temporal raphe. As you can see from the picture over here,
Mr. Soumya,
sorry?
Mr. Soumya, sorry to interrupt. Can you please sit a little far away from the camera? Then the picture will be much better.
Yeah, because of the fact I think I'm working on Mac and it doesn't, the thing doesn't work.
Okay.
Something has happened. Okay. Yeah. So
it's,
as you
it's
can,
fine, no?
yeah. Can you? All right. So as you can see from the picture, when we talk about temporal raphe or about the perimetric parameters, we refer to a symmetric measurement of visual fields. Thus, glaucoma hemifield test plays an important role in glaucoma evaluation in today's world. So this picture is a schematic diagram of a temporal raphe. That's the fovea, that's the peripapillary nerve fiber bundles, and obviously that's the disc. Why temporal raphe is important in myopia? For reasons poorly understood, myopia increases the risk of glaucoma. It is possible that progressive axial length may cause some biomechanical stress, resulting in thinning of peripapillary nerve fiber, and these factors could in turn indicate susceptibility of other glaucomatous stresses. So myopic eyes differs in shape from non-myopic eyes, which can potentially change the interpretation of clinical tests in context to glaucoma management. And therefore, it is important to understand how retinal tissue changes with myopia. So if you can see the schematic diagram of here, it's the fovea, that's the disc. And maybe 1 second. And that's the raphe, which goes from the fovea to the temporal part of the retina. And that's the fovea to raphe angle. The fovea, raphe, and the disc angle is the larger one, which you can see over here. In all these landmarks will help us understand how the raphe orientation in a general myopic retina works. So if you see this image, it was taken by Chauhan BC et al. In 2014. You can see the en-face image of the OCT. Temporal raphe is clearly visible in this en-face image taken by the SD OCT. There's other two images, A and B, from the same group, and it clearly shows the orientation difference in different subjects of the temporal raphe. Now, as we go to diagnosing how the orientation of raphe, temporal raphe is, we surely have a question in mind: can we really measure temporal raphe? So when we talk about temporal raphe, give me 1 second. It's not working well. So when we talk about temporal raphe, we talk about measuring the temporal raphe. So in this study, we recruited 83 individuals, of which we took the 80 subjects, and 3 of them were excluded because of poor quality of image. So we took also the axial length and the vitreous chamber depth. We measured through A-scan ultrasonography, and all of the SD OCTs were performed in one eye of the subjects because it was a very tedious job and we couldn't do both of the eyes for the time constraint. In the right-hand side, we see a spectralis OCT image taken by my dear friend Kwan, who was very angry, having sat there for nearly 3 hours for the image. And the left-hand side is the en-face image taken from his eyes. You can actually see the temporal raphe structure quite visible in that image. Analyzing the retinal image was a tedious job. Image was taken in the sequence shown in this picture. So the right, we had to have a reference point of the disc, and we took some low resolution image in the center in orientation with the disc, and the 3 images were the high resolution image. The last one was very difficult to take because it was extremely temporal to the retina. The fixation was difficult. So we end up doing the 2 high resolution images, which is 1 and 2. So here is in a nutshell, we see the way we took the image. So if you see here is the disc, which we offered as a reference point, and then we took the low resolution image to where the tilt on the base of the tilting of the fovea to disc angle. The other 2 are the high resolution image, as you can see from here. In this table, you will see how we have taken and proceeded towards taking the temporal raphe. all of the last images were high resolution images, and the last two were scanned 261 frames, sections in frames, so that we can have a very good quality image, and so that we can also see the different Raphé gaps and orientation of the images. Now, the next thing we needed to do was to grade the images, because as you know, the taking of this kind of high resolution image was a kind of a tedious job. And then we do have the reflective artifacts coming into our way. So 4 expert graders, including me, if you call me an expert in that, having done so many OCTs by then, the grading was done keeping in mind that the reflective artifacts are and avoiding them while marking the images. So the first image shows you the grade 0, which is quite a good temporal Raphé structure. The second one is a kind of a dismay because of the fact there are certain, but still we can have a look at the temporal Raphé gap and the nerve endings. And the third one, we had to discard them because of severe artificial artifacts and reflective defects. Now, what we found from the study, it was a very interesting finding, and what we set out to find the correlation between the landmarks and the temporal Raphé structure. We found a very weak correlation between the fovea to disc and the fovea to Raphé angle for different axial lengths. So axial length was the parameter for us to identify the high myope patients, including we also had to do the vitreous chamber depth, because it was also a kind of a better biomarker to know the higher myopic patients in general. Now, the temporal Raphé positioning is related to the axial length of the eye, which we set out to discover was a dismay to us. We found that there's a very weak correlation, or rather no correlation between them. The Raphé optic nerve, optic disc angle changes with the axial length of the eye, which there is no correlation for that matter between the fovea to Raphé angle and in high axial length or high myopic patient in general. As you can see that the correlation was very weak between both the foraf and the axial length, and similarly we could find the same weak correlation in the vitreous chamber depth with the foraf angles as well. The position of the optic nerve head relative to the fovea depends on the axial length. It's also a very discovery for us that there is no correlation between the fovea disc Raphé angle and axial length too. So what's the major takeaway from this study? So temporal Raphé structure provides an insight in diagnosing diseases like glaucoma. It has been found that structural changes in the temporal Raphé occurs due to disease like glaucoma, such as enlarged Raphé gap, and it's therefore relevant to understand its dynamic and anatomical knowledge. Considering varied size of eyeballs, it also widens our view on how we perceive Raphé position and trajectory in high myopes. We also came to know that Raphé correlation seems to less important in diagnosing diseases like glaucoma. Even though we know that Raphé angle increases in its size in the degenerative diseases like glaucoma with progression, it becomes more and more difficult to see the Raphé orientation. Future pathway of this study was quite an insightful thing, which we always contemplated to do. And First and foremost, we actually do not know the etiology of the temporal raphe as a whole. So raphe trajectory in hyperopic participants would be a great future path to follow. And it would be worth to know about the raphe gap in stretched eyes, because that's a very important part of the retina which we haven't discovered as much. We know that the raphe gap increases in myopia, in glaucoma. What we do not know is the raphe gap in stretched eyes like high myopes. At the end, we do recommend you to go and have a look at this paper, which we have published in 2019 in IOVS, which holds a more detailed presentation, what I have just put on tip of an iceberg through this presentation. And if you have any queries, do write to me to this email address, mukherjee.s@gmail.edu.au. And thank you, and a very good night.
Thank you, Mr. Mukherjee, for your wonderful presentation.
Thank
so
you.
Now I'd like to call upon our next speaker, who's Dr. Manish Singh. He's predominantly worked in the field of glaucoma as a senior consultant, and currently holds the post of Executive Director in Netralayam Super Speciality Eye Care Center, Kolkata, India. So he'll be joining us from Kolkata, and today he'll present us on OCT basic interpretation and fallacies. Over to you, Dr. Singh. The mic is yours.
Hello, am I audible?
Yes, sir. Loud and clear.
Thank you so much. So thank you for having me in this OPTOVERSE. It's really a pleasure to be part of it. And it's nice to meet so many old colleagues. I was just listening to some more very interesting presentation. Also, especially thanks to Swarna Kamal. So I'll be sharing a bit about the role of OCT in glaucoma, a bit about the interpretation and the fallacies. So when Swarna Kamal approached me to share a topic, so I thought OCT will be a good topic, because why OCT is so important in glaucoma. And if you see now, as a diagnostic modality, OCT has become the most important imaging tool for glaucoma. 10-15 years back, when we were doing our training in glaucoma, we had multiple options. We had the HRT, the GDX, the OCT, and that time HRT was regarded as one of the gold standards, especially for disc evaluation. But over the next 10 to 15 years, OCT is the one which survived. The reason is, one, because it's evolved over time. There were software evolutions, they had much better database. And HRT and GDX were very specific for glaucoma, but OCT was used a lot by our retina colleagues. For retina, I think it has almost become indispensable now. So OCT has become a very good tool for glaucoma, also because of its good availability. Now, what we actually see in OCT, one, mainly the retinal nerve fiber layer around the optic disc. We also have a look at the optic nerve head and the ganglion cell complex. But primarily, something which is most commonly seen is the parapapillary nerve fiber layer thickness, and we try to correlate with the normative database to see whether this is normal, borderline, or thin. And that way, OCT will give you a red color for thin, a borderline yellow, and a green, which means normal. So it gives you an idea whether the parapapillary nerve fiber layer is thin, normal, or abnormal. It won't tell you whether it's glaucoma or not. It will just tell you about the thickness of the RMFL. Now, what are the important indications of OCT in glaucoma? One, definitely ocular hypertension. You can see over time how the patient's disc is changing, whether there are early changes developing or not. In my practice, pre-perimetric glaucoma is extremely important. We'll come to it. We'll share some cases of pre-perimetric glaucoma where you can diagnose glaucoma before perimetry changes can be seen. Also, to document findings to support your clinical finding. In hypertonic maculopathy, OCT macula can be good and useful to see early cystic changes in the macula, and also in certain patients who have problem in hands-eye coordination, a very old patient, not able to fixate properly, or not able to perform perimetry. These patients definitely OCT can be an alternative. Let us take some clinical examples to understand these points. One is pre-perimetric glaucoma. So this is the patient who comes to our OPD. If you see the disc, definitely there is some inferior thinning you can see, and there is a, you can see the wedge-shaped RNFL defect can be seen, but the perimetry is normal. So if the perimetry is normal, but the clinically looks glaucomatous, these are the patient which we call as pre-perimetric glaucoma. In these cases, OCT can be helpful. If the OCT finding, for example, in this case, you can see the inferior thinning seen in OCT correlates with the finding what you had on clinical evaluation. So if the OCT finding matches your disc finding, it gives you an extra evidence to treat these patients. But very important, it should match. Just any red area on OCT is of no value unless it clinically correlates. So for example, in this case, you have inferior thinning, but on OCT, you can see inferior is more of a borderline, superior is thin, but clinically, if you see the disc, there is no superior thinning. So there is a mismatch. If there is a mismatch, then you should not go by the OCT. It should be more of a clinical evaluation, and based on other parameters, you should decide whether to treat or not. Also, certain cases to exclude glaucoma, like this particular patient already diagnosed as a glaucoma, as a suspect, comes to you for opinion. You have done a perimetry, perfectly normal. If you see the disc, it's a large disc, very suspicious. Superior room looks to be suspicious, but the RNFL is overall okay. You have a gut feeling that this is not glaucoma, but you're not very sure. You have done a OCT. OCT is showing all green area. It sort of gives you an extra evidence to exclude glaucoma. So these type of patient, OCT definitely is helpful to rule out glaucoma. So one, in pre-perimetric glaucoma, and second, to rule out glaucoma, OCT can be really a big help. Now coming to interpretation, there are multiple machines available in OCT, and every machine printout is different. They are not clinically correlated. So if a patient is having an RNFL thickness of say 18 in one machine, if you do it in another machine, it can be different. So you can't directly correlate two different machines. So what is important, whatever machine you are having, you should go into detail of the printout, try to understand how the machine works, what is the normative database, what is the signal strength required for the machine. It will help you better interpret these reports. So this is a Cirrus machine, and the one on the right side is Spectralis or the Heidelberg machine. So there are some important points which is applicable for all these. For example, 3 key points I'll say you should see before you go to these clock hours and RNFL quadrant. Because what happened initially when we are seeing OCT, the first thing which we see is the red and the green areas. We think, okay, this patient has got red area, so there is a thinning, there is glaucoma. Don't jump into that. First, see the signal strength. For example, in this case, you can see the signal strength is normal. So in a Cirrus machine, 6 and above is normal. Then you see whether the RNFL thickness map is correct or not, whether there is any disc margin blurring or not, whether the images are clear or not, so whether there is any motion artifact. Also look for centration in the RNFL deviation map. So signal strength, motion artifacts, centration, and segmentation you should see first. Then you should go to the quadrant, TSNIT graph, and the clock hours. So this should be the approach. Again, signal strength, different machine have different signal strength. Currently, we are having an TopCon where the signal strength above 45 is regarded as acceptable. In Spectralis, it is more than 50. So you have to know the signal strength of your particular machine. I'll again share a few clinical examples to make it more practical. Like this is a patient who was suspected as glaucoma and OCT was done. You can see right eye, superior thinning, left eye, inferior thinning. So just looking by the OCT, looks to be definitely there is thinning, could be a glaucoma. But again, very important clinical correlation. If you see the disc, there is a temporal slope in right eye, left eye, again, there is temporal slope, but there is no obvious thinning as such, which is matching. So if you match the two eyes, right eye, there is a superior thinning on OCT, but the disc superior looks to be fairly okay. There is no clinical correlation. Rather, inferior is looking more suspicious. Same in the other eye also, superior looking slightly thinned out, but in the OCT, it is more of inferior thinning. So there is no clinical correlation, but I've told you before you go to this quadrant, you have to see 3 things: the signal strength, the centration. The signal strength definitely is much lower for a Zeiss machine, which should be 6 and above. Same thing we repeated with another machine. We found the signal strength has improved. And if you see the quadrants, they are mostly green and yellow. So if the signal strength is poor, you can have a fallacious result. Personally, I believe if I have a patient with OCT report where the signal strength is very poor, I'll prefer not to diagnose based on that report. So artifacts are fairly common and we have to actively look for that. Dr. Asrani has shown that even in the most advanced spectral domain machines, you can have as high as 40% patients with artifact, which can give you confuse you and can create a false diagnosis of glaucoma. There are certain conditions which affect the signal strength. For example, cataract, corneal opacity, vitritis, severe dry eye, vitreous hemorrhage. So in these patients, you understand the light is not able to reach your retina. So patient is having a hazy image. When the image is hazy, the image processing by the machine is defective. It will give you a fallacious result. Machine will not be able to delineate the layers of the retina. And we know there are 10 layers of the retina. So if you can't delineate the layers properly, machine will not be able to tell you what is the correct RNFL thickness. So in these type of cases, personally, I believe you should not use OCT for diagnosing. I used to go as a visiting consultant to Jamshedpur, which is another town in eastern part of India. So this was a machine which was purchased by them. So just a new machine, almost 50 to 60 lakh rupees. And the patient was a disc suspect. When they did a OCT, you can see there was a gross thinning of RNFL in both the eyes. You can see here all red areas. But clinically, it was more of a suspect, not such a severe form of glaucoma. But again, as I told you, 3 things you should see. One, the signal strength looks to be fine. But if you see the RNFL thickness map, there are black areas, means there are certain area machine is not able to see the image. Then the disc is totally fuzzy. You can see the disc margin is not clear. So this means the patient was moving his eyes and there were motion artifacts. So this particular report should be discarded. We took the patient back and we repeated the test. Another point you can see here, the TSNIT graph, you can see it is touching the baseline. A very practical point I tell you, a rule of thumb, RNFL thickness will never go below 40 micron in any machine. Even if you have most advanced glaucoma, there is total thinning of RNFL, some amount of soft tissue is always there, what we call as the floor effect. So if you see a patient with the RNFL thickness going less than 40, this means there is some problem in image acquisition. So in this case, the segmentation was not proper because of motion artifact, and that is why you can see a 20 and 0 micron thickness can be seen. So this report should be discarded. We repeated the OCT and you can see this is much better. You can see the disc here, disc margins are clear, the TSNIT graph is fine. And in this case, definitely there is thinning because the patient had some glaucoma, but it is not as bad as shown in the previous. So you can see the difference here. First disc image and second, you see these were the motion artifacts which we're seeing. And you can see the marked improvement in the RNFL clock hours. So again, the point I was going to highlight, sometimes when we purchase a very costly machine, a 50 lakh or 1 crore machine, we think this is the best machine, the best technology. Whatever report I'll get will be perfect. That is not the case. You have to understand your clinical evaluation, your interpretation of report is more important. We cannot blindly go by any of the machine, however costly it is. So segmentation error is another important thing. As I was telling you, machine has to delineate the layers. So suppose there is a epiretinal membrane or there is a macular edema. So RNFL thickness will be increased. So machine will not be able to tell you the correct RNFL thickness. So there will be a segmentation error. Also in myopic patient, we see there is often chororetinal atrophy. Because of that, also you can have a problem in delineation. Most machine will have a database between -5 to +5 diopter. So if you have a patient which is very high myopia, more than 5 diopter, say 8 or 10 diopter, these cases, these patients using an OCT for diagnosis of glaucoma can be very tricky. Again, related to segmentation error, you can see if suppose there is a high myopia, or suppose there is a cystoid macular edema, or disc edema, epiretinal membrane, or uveitis. These cases, for example, this case which I have shown, there is a macular edema, so the thickness has increased. So if you see the TSNIT graph, the graph is going almost into the white area. So it is an abnormally thick RNFL, which is not true. Because of the CME, because of macular edema, the machine is not able to tell you what is the correct RNFL thickness. So the point what I want to highlight, if I have a patient with a diabetic macular edema or a ERM with glaucoma, I will not use OCT for diagnosing glaucoma because that result will definitely be fallacious. Floor effect I've already discussed. Because of the residual glial tissue, the thickness will not go below 50, never below 40 micron. So whenever you're seeing less than this, definitely there is some artifact in the machine. Nowadays, we'll be using a lot of macular scan also. This is mainly as a supplement to RNFL thickness. The reason is the macula contains almost 50% of the retinal ganglion cells in just 2% area. So it has a very high concentration of retinal ganglion cells. So it can be used to see early thinning of RNFL, early thinning of the retinal ganglion cells. And here, because of thickness, the concentration of cells is very high. The floor effect is seen much later compared to what we see in RNFL. But in the current use, I'll say that if you're using OCT for diagnosing glaucoma, the first thing you should see the RNFL. Second thing should be the macular scan. Before I finish, I'll just touch two important things. What is the red disease and the white and the green disease? The red disease basically is condition where OCT by mistake indicates that there is something abnormal. For example, in this case, a myopic patient, you can see there's a peripapillary atrophy and OCT is showing that there is a thinning and which is touching the baseline also. This is thinning is not because of glaucoma, because of peripapillary atrophy, because of chororetinal atrophy. There is thinning of retina and OCT is falsely showing something abnormal. There's another patient, he's an ophthalmologist. He was diagnosed as glaucoma elsewhere. When we saw the patient, large disc, you can see large disc with large cupping. Typically what we see in physiological cupping, patient had a spectralis done. Definitely there was inferior thinning in right eye and superior inferior thinning in left eye. It confused us because clinically it was very much like a physiological cupping with normal pressure. But if we see the report, see this is again a 1 crore machine, which is a lot of money in India. You can see here, there is definitely decentration in the left eye and slightly in the right eye also, but it's definitely in the left eye. So these machines have auto-centration, but even in these machines, you can have some decentration. We repeated the test with proper centration and you can see the report was normal. So again, I was telling you, before you go to the clock hour, you have to see these 3-4 points like centration, signal strength. So this test also shows that these machines can give you a fallacious result. Green disease again is a condition when the OCT will show everything is green, everything is normal, but actually the eye is having glaucoma. So this is a patient where you can see the left eye disc is normal, right eye definitely there is a disc hemorrhage and very early thinning, but the OCT is normal. In this case, what happens? There is a thinning of nerve, but OCT gives you an average. You can see this clock hour. This is an average of that clock hour. So in the average, what is happening? Although there is early thinning, but the RNFL thickness is still within the normative database. So OCT is showing that it is normal. When the disease will further progress, then there will be early changes in the OCT. So sometime OCT may show everything normal even when there is a glaucoma, what we call as the green disease. Another patient, you can see this was this suspect on OCT. The clock hours were perfectly normal. That day we were also having a TopCon machine. We did a TopCon. There was some early thinning in the right eye inferiorly, which was not picked by the spectralis. But when we went back to the spectralis, what we found that although the clock hours were normal, but in TSNIT graph, definitely at one point it was touching into the red areas. And this was perfectly matching with the TopCon. So before you go to the clock hour, you should see the TSNIT graph because it will give you a thickness in all the zones. What happens in clock hour, it gives you average, but TSNIT graph will give you thickness in all the zones along the circle. So before you see the clock hour, you should see the TSNIT graph also. And if you see any dip into the red area, that can be clinically significant. Last case, this is a patient who was again diagnosed as glaucoma. When we saw the patient, the pressures were normal. He was a fairly young patient with normal central cornea thickness. Advanced field loss in both the eyes. So this type of field loss we see in terminal stage of glaucoma, the last stage of glaucoma. Those cases, disc will have total cupping. But if you see that OCT, definitely there is thinning in both the eyes, but some areas you still have green zones. But OCT is showing glaucoma. The perimetry is showing advanced field loss. But if you see the disc on the right eye is around 0.9, but there is a lot of pallor, and left eye is around 0.6 with lot of pallor. So whenever you have so much of pallor and so little cupping, you have to think that probably there is something more. This was a case of methyl alcohol poisoning, which was mimicking as glaucoma. The point again I like to highlight, a patient with methyl alcohol poisoning, traumatic optic neuropathy, ischemic optic neuropathy will have problem in the optic nerve, will have some atrophy of the RNFL thickness. These patients on OCT will show you a picture typical like glaucoma, but it is your clinical evaluation where you will be able to differentiate it. This is a patient where the discs were perfectly healthy. Again, patient was suspected as glaucoma based on OCT done 2 years back. You can see the age is just 5 years. In 5 years, most machines don't have the normative database. So don't use OCT for these patients. This patient OCT was done. There was thinning. Patient was treated for glaucoma. When the patient came to us, we just did a simple perimetry. It was normal. And if you see the disc also, perfectly healthy disc, the pressures were normal. In young age, you don't have normal tension glaucoma. So OCT can be fallacious if you're using in less than 18 years of age. So to conclude, there are a lot of artifacts. See the report properly. Look every segment of the report. Remember, there can be machine-to-machine variation. OCT is a great tool for diagnosing glaucoma, for helping in seeing RNFL thickness and disc parameter. But whether the patient is having glaucoma is a clinical diagnosis. It is for us as a clinician to decide. So I'll just conclude saying the machine can be useful, but the man behind the machine is more important. Thank you so much.
Thank you, Dr. Singh. This was indeed a very informative session. Hope this will help our fellow people to understand OCT better. Now, I would like to call our next speaker, who's optometrist Dr. Vasant Muthuswamy. He is currently working as a optometry and vision science research, innovation and commercialization in University of Melbourne after completion of his PhD from there. Today he'll be talking on a novel method to assess visual field in moderate and advanced glaucoma. The mic is yours, Dr. Vasant.
Thanks, Ujjwal, for the introduction, and thank you, OPTOVERSE, for inviting me for this talk. So I'm going to talk about novel methods, a new method we developed in Australia recently to assess visual fields in moderate and advanced glaucoma. So as we all know, static automated perimetry is commonly used diagnostic technique for diagnosing and monitoring glaucoma and other various ocular and neurological conditions with visual field loss. And for example, when someone performs an automated visual field testing, you get a visual field map like this. This is an example 24-2 visual field report of a patient with glaucoma. You can see here that this visual field map produces various ranges of threshold values. When threshold value is approximately close to 34 or maybe about 30, depending on the age, is considered normal. When the threshold values goes down, if it reaches 0, it's perimetrically blind, or the other region you have an relatively abnormal defects. So why visual fields? So visual fields is really, so when you have the visual field reports, usually clinicians, they follow patients for every 2 years or every year or twice a year to monitor change on visual field threshold values, that is vision loss over the years. And it really helps clinicians in deciding appropriate treatment strategies along with various other diagnostic techniques. So clinical static automated perimetry has several issues. One of the common one is the poor precision, that is high test-retest variability in damaged visual fields. Here we can see the threshold values. These are in the normal visual field area for this patient. If you test this visual field once, and if you test the visual field again in the same day or in a different day, or maybe after 6 months or a year, if the threshold values are normal or close to normal, if you look at the left figure here, within the green box, when you test once and when you test twice, the threshold values will be almost similar or maybe close to the previously tested values. But when you look at the damaged areas, here you can, if you test once or maybe test twice or thrice, for example, if an actual true threshold value is around 10 decibel in the damaged area, you could get threshold value between 10 decibel or maybe less than 5 decibel to 20 decibel. This is the high variability. So when you have a high variability of visual field thresholds, clinicians can't decide whether it is a true visual field change over the time or whether it is due to variability, even though you have various statistical measures to compensate for this variability, mainly for the progression assessment. So recent studies have shown that with this highly variable thresholds, we can't extract any clinically meaningful information. So the other issue with clinical perimetry is the number of test locations tested. So to keep test duration, that is approximately around 5 to 9 minutes, the perimetry companies have decided to test only 52 locations of the central visual field. So when you have these abnormal threshold values and you don't have clinically meaningful information for deciding on treatment strategies, the option is to test more locations. That is placing test locations between each of these threshold already tested test locations. So, but the problem is when you keep adding test locations, it increases the test time. So when it increases the test time, you get mostly unreliable results. So we have seen lots and lots of improvements over the years. For example, if you look at the common improvement in common development in the perimetry in the last 30 years, that is test speed. Previously, we were using full threshold test procedures, which approximately took 13 to 18 minutes. And recently, a few companies have, one or two companies have introduced faster thresholding procedures, which you can do a perimetry test for glaucoma patients in 3 to 6 minutes. Even though test speed has considerably improved over the years, its precision in estimating threshold values remains the same, or sometimes it even goes worse. So you have to test the visual field a few times to get a better reliable visual field reports. And to compensate for this precision, studies have also recommended for more frequent monitoring of visual field tests. That is, instead of going for 2 visual field tests in a year, some studies have recommended for 3 to 6 visual fields in a year or 2. And there are new forms of tests have been introduced recently. Those are portable perimeters based on tablet-based tablets and the computer tablets, and virtual reality-based perimeters to increase the frequency of visual field testing. And people have also tried using robot assistants to give voice instructions during the perimetry testing. And these improvements are based on assumptions about patients without asking them. So what we did, we asked patients in Australia about their preferences for perimetric developments, and we gave them options such as whether we asked the options include whether they prefer similar test times as currently used perimetric procedures with an increase in level of information about their visual field, and the longer test times but greatly increased information about their visual field, and tests that they could do regularly at home to monitor their own visual fields, and the shorter test times with a similar level of available information, and tests with automated voice instructions such as robots or speakers, and without human interaction, and tests that are much quicker but provides less information about their visual field. So we asked them to rank their preference in by their choice. So what they think that is important for new perimetric developments, and here is the result. So most people in our study cohort, they preferred similar test time. They ranked similar test time, but with an increase in level of information about their visual field, or longer test time, but greatly increased information about their visual field. And as I said before, we can't increase the test time than currently used, because increasing the test time can result in fatigue, tiredness, you get unreliable results. So we published this paper in ophthalmology glaucoma. If you're interested, you can go ahead and read it online, or if you would like to have a conversation regarding this paper, I'm happy to discuss in future. And the other highlights in the study included patients were willing for more frequent follow-ups, contrary to current assumptions that patients don't like doing visual fields, and there is a dropout in follow because they hate doing visual fields. On average, the study cohort in Australia, they preferred 3 or more visits in a year, and they were also willing to do 2 visual field tests per eye on average in a single visit. And so and there are lots of expectations from patients, mainly related to communication. They expect improved communication during or before and after visual field testing by perimetrists, as well as they expect detailed feedback and more interactions with clinicians about their results related to visual fields and other clinical parameters. And we hypothesis that when clinicians and patient interaction is improved, this may also improve the clinical compliances for patients. And so we came to the next question. So when patients prefer increased information, is it possible to increase number of test locations without increasing the test time? So what we did was we developed a new perimetric approach called the Australian Reduced Range Extended Spatial Test. So in this procedure, we perform the same similar thresholding as commonly used in like CETA standard, or maybe in OPTOVERSE, where you have dynamic strategy or other faster procedures. So what how this procedure works is it normally thresholds as in the commonly used procedures. And when a threshold values is in abnormal region, for example, if a threshold value is less than 17 decibel, where you have a high test variability and you get no clinically meaningful information, so we just, instead of thresholding, we just check whether the particular location is blind or within the between 0 decibel or 17 decibel. And if it is blind, we flag them as a red, or if it is between 0 decibel and 17 decibel, we keep them as yellow. And we save some time in that. So by saving some time without thresholding those abnormal locations, we try to automatically choose test locations in the edges of the scotoma, that is close to the borders of the defects. We try to place points. So what happens is, so when a patient comes back for a new visual field test after 6 months or 3 months or 4 months or maybe a year, this perimetric approach keeps increasing number of test locations over the time, with an aim to gain more information for clinical management. So the specification of ARREST, this particular approach, is, as I said, it tests more location without increasing test duration. And it automatically decides where to place these test locations without any human interaction or human error. And it does not waste test time in this by unnecessarily testing these highly variable locations. This is frustrating for patients as well, because when they don't see lights, they have to look into the bowl for a few minutes without seeing any light, and they lose interest. And when you get the report, sometimes you get unreliable report, and this is what makes them angry, and sometimes they don't want to continue doing visual fields, because when they have progressive diseases like glaucoma, they have to undergo visual field testing throughout their lifetime. And for progression analysis, you would expect that, okay, so how this is going to help for assessing visual field progressions, because we've been using a standard test grid like 24-2 or 30-2 or 10-2. So how this is going to help? So we have also simulated this real glaucoma cases for few visits, and then we developed a new approaches for progression analysis as well, which I'm not going to discuss in this talk. But our studies have shown that without any modifications to current strategies, our progression analysis method for arrest works. And this particular arrest approach is independent of type of visual field defect. And this is not only specific for glaucoma or specific patterns of visual field loss. This can be customized to different defects with visual field loss. For example, in stroke, you can customize this arrest approach. And you can also incorporate this particular approach in any perimetric algorithm. For example, if you want to incorporate this particular arrest approach in CETA, you can use this particular approach in CETA. And if you want to use it in octopus procedures, you can use it in octopus procedures or any other clinically available perimetric algorithms without needing for a new normative database collection. And I would like to reiterate that this arrest approach is not a new algorithm. This is an approach to test more locations. So this is easy without much expense. You can incorporate these particular procedures in any clinical algorithms. So here's an example. We have followed two patients after a year when they had their first arrest visit. So if you look at the middle panel, arrest approach have added almost like 4 to 6 locations in this first patient, the top figure. And when they came back in after 1 year, 3 months, you can see that arrest have added a few more locations. These locations, if you look at these locations, most of them were almost close to near normal threshold. And these thresholds could really be used for assessing visual field change over time. And as I've already discussed about progression, and we could use any mean deviation progression as well. And you can also use point by point progression as commonly used in clinical procedures. You can integrate those approaches in with arrest perimetric algorithm. And yeah, thank you, OPTOVERSE, for the invitation again. And thank you everyone who is listening to my talk. And if you'd like to connect with me, you can use LinkedIn to connect. And if you have any questions or interested in visual field research, feel free to reach out to me. Thank you.
Thank you, Dr. Vasan, for this wonderful presentation. And for this session, I would like to request our next speaker, Dr. Satya Kakade, who's a well-renowned vitreoretinal surgeon in Abu Dhabi, and currently working with Burj Al Medical City, Abu Dhabi, and has a vast of 16 years of experience as a retinal surgeon. Today, he will be talking on hypertensive eye diseases. So the podium is yours, Dr. Satya.
Yeah. Yeah, good evening, my dear friends. At the outset, I would like to thank the team from OPTOVERSE for giving me an opportunity. Is my slides visible to you?
Yes,
Are
Doctor.
the slides visible? Yeah.
Yes, yes.
All right. Yeah. So after an overdose of diagnostic, as a clinician, I would be talking on a very important topic, that is hypertensive eye diseases. And the reason why I chose this particular topic is in most of the presentations and the conferences, you would be speaking, you would be hearing more on diabetic eye diseases. So I just thought that here it would be an opportunity to discuss on hypertensive eye disease, which is a growing concern among the general population. So with this, what is the importance of hypertension is, it is a profound disease, and most of the times it is asymptomatic. And the worst of it is it involves multiple organs. So there is a multi-system effect. And the eye is not spared of the effects of elevated blood pressure. And certainly, as you are aware, the retina gives us an opportunity to examine the blood vessels in vivo live. So with this, we can actually know what is happening with the blood vessels, and more so in diseases like hypertension. So hypertensive retinopathy is also a risk indicator for systemic morbidity and mortality. And this explains why hypertensive retinopathy is of prime importance. So coming to the effects of hypertension in the body, we know that when it affects the central nervous system, there is a huge impact in the form of stroke. In the eyes, there can be loss of vision, which we are going to discuss. And in the heart, it can be in the form of heart failures and heart attacks. You can have hypertensive problems in the kidney in the form of renal failures, as well as sexual dysfunction and other problems associated with this. So having said this, most of the times what happens is the elevated blood pressure has a key role both as effect by itself as well as on the pathogenesis of diabetic retinopathy. And hence, control of blood pressure has been shown to prevent progression of diabetic retinopathy and prevent blindness as a sequelae to it. Several retinal diseases such as retinal vascular occlusions, retinal arterial emboli, macroaneurysms, as well as ischemic optic neuropathy and age-related macular degeneration has its bearing with hypertension. And now coming to the manifestations per se, hypertensive retinopathy is nothing but a spectrum of retinal vascular signs that typically includes retinal arteriolar narrowing, AV crossing changes, the retinal hemorrhages, microaneurysms, and in severe cases, it can involve the optic nerve head in the form of optic disc edema as well as macular edema. So these signs develop due to acute as well as a chronic elevation of blood pressure, and the initial response is either a diffuse or a localized vasospasm and a consequent narrowing, because of which it can be in the form of generalized arteriolar narrowing or focal arteriolar narrowing. Now coming to the arteriolar narrowing, it is one of the defining signs of hypertensive retinopathy, and it is an autoregulatory response to control the amount of blood which is being received by the retinal capillary bed. It is also commonly seen in early phases of hypertensive disease before the onset of sclerosis. Also, the blood pressure remains chronically elevated, then it causes changes in the surrounding venules, and this is called as the arteriovenous leaking sign, that is the AVN in short. And in advanced stages, as I was just discussing, there can be exudative changes. As you can see in this photograph, on the left, you can see early hypertensive changes in the form of retinal hemorrhages. However, with advancement of the disease, you can have corneal spots, you can have hard exudates with the appearance of macular edema. So in order to brief it, you can have the manifestations either in the form of acute hypertension or in the form of chronic hypertension. In acute hypertension, it is usually a vasospasmic episode with increased vascular tone. And in chronic hypertension, it can be in the form of intimal thickening as well as medial wall hyperplasia. And clinically speaking, there can be either in the form of copper wiring or silver wiring of the arterioles. In severe hypertension, there can be exudation and nerve fiber layer ischemia, both in the form of corneal spots as well as retinal hemorrhages. The worst part of it is the accelerated hypertension, wherein which can be associated with increase in intracranial pressure, fibrinoid necrosis, as well as the choroidal arterioles. Now, all this while I was discussing about what happens in the retina, equally important is what happens in the choroid. A chronic elevated blood pressure can cause necrotic changes as well as sclerotic changes in the choroid, which can be in the form of Stiger's freak as well as the Elschnick spots. So the retinal microvascular signs of hypertension can also be seen in other systemic diseases like diabetic retinopathy, radiation retinopathy, anemic or leukemic retinopathy, trauma, HIV, as well as in other infections. And appropriate investigations may be necessary in order to differentiate hypertensive retinopathy with its differential diagnosis. So what does the fundus picture actually mean? So when there is a generalized retinal arterial narrowing with AV crossing changes, it can be a sign of chronic hypertension. So what does it mean? When a person is having hypertension for a prolonged amount of time, it can manifest as generalized arteriolar narrowing. And in contrast, if there is any focal arteriolar narrowing with retinal hemorrhages or microaneurysms and corneal spots, it just says that it is a recent episode. Also, there is an association between the blood pressure and retinal microvascular signs with older individuals, in which you can have more of sclerotic changes in the blood vessels. I will not be going into the greater emphasis on the correlation between hypertensive retinopathy and stroke, but nevertheless, it is very evident that most of the patients who have prolonged hypertension can have stroke with associated cerebral atrophy as well as other risk factors. And also the type of stroke can be in the form of lacunar strokes, or it can be in the form of non-lacunar thrombotic or cardioembolic strokes. Again, there is a huge association between hypertension and heart disease, which can be in the form of congestive heart failure, or it can be in the form of increase in the coronary artery calcium scores. Also, the retinal arteriolar narrowing can be associated with decreased myocardial blood flow, and there is also a correlation between hypertensive changes and the internal carotid intimal medial thickness. So certainly it is not only in the brain as well as in the heart, it can also manifest in other places. And as widely been discussed, the most accepted classification is the Kate-Wagner and Barker classification of hypertensive retinopathy. In grade 1, there is a mild generalized retinal arteriolar narrowing. So when you just see fundus pictures of generalized arteriolar narrowing, it generally means that it is a mild form of hypertensive retinopathy. Moving up the ladder, in grade 2 hypertensive retinopathy, there can be focal arteriolar narrowing with AV crossing changes. In grade 3, there can be flame-shaped hemorrhages, as well as hard exudates and cottonwool spots. And in malignant retinopathy, it can be in the form of optic disc, edema, as well as exudative changes. The newer classification is in the form of mild, moderate, and malignant, which has a association between the systemic features as well as the hypertensive retinopathy changes. Also, it has a huge impact on the management of diabetes and the progression of diabetic retinopathy. And it has been seen that the renin-angiotensin system controlling drugs have a better impact in the control of hypertension and the associated hypertensive retinopathy. Now, what are the other diseases which can be associated with hypertension? It can be in the form of retinal arteriolar occlusions, or it can be in the form of retinal venous occlusions, which can either be a central retinal vein occlusion, or it can be a temporal retinal vein, or one of the segments, the tributary retinal vein occlusions. Also, the branch retinal vein occlusions can be very commonly seen, and it can be also seen as a subsequent event wherein which you can have recurrent episodes of vein occlusion unless and until the hypertension has been under control. The retinal arteriolar emboli as well as retinal microaneurysms are also one of the commonly seen features of hypertension, and the kind of plaques, whether it is calcium, a cholesterol plaque, or a platelet plaque, can also have a huge impact on the future course of the disease. The carotid artery and the heart are the source of emboli most of the time, and a thorough cardiac evaluation may be essential. The retinal vascular signs such as AVN, the arteriolar wall opacification, and the vein occlusions are documented to correlate with the presence of retinal emboli, and it can be seen that persons with hypertension at baselines are shown to have 2.5 times likely episodes of embolism. Also, the retinal arteriolar macroaneurysms RAM as what has been constantly seen in older individuals with hypertension. These are nothing but the saccular dilation of the retinal arterioles, which can sometimes burst open to lead into ruptured arteriolar macroaneurysms. And if it is very close to the macula, it can cause macular edema, which can be amenable to treatment by lasers. The visual recovery typically occurs spontaneously in such patients unless and until it is involving the macula. And finally, one of the most important other manifestations of hypertension is the ischemic optic neuropathy, which is usually seen in the anterior segment of the optic nerve, wherein which it is called as anterior ischemic optic neuropathy, which has to be differentiated from other optic nerve head changes like papilledema or optic neuritis. There are two kinds of ischemic optic neuropathy, which can be in the form of anterior ischemic, the arthritic and the non-arthritic type. The arthritic type is usually associated with inflammation, and the non-arthritic type is usually associated with hypertension. So to conclude, the diverse development of hypertensive organ damage and its correlation with changes in the retinal microvasculature gives us an opportunity to have periodic checkup of the fundus, and when there are early changes, we can make corrective measures in order to prevent end organ damage. So I just thought that it was important for us to again reiterate on the importance of examining the fundus, especially in patients who are having hypertension, so that we can prevent a catastrophe. So thank you for your patient listening. If there are any questions, I'm ready to take.
Thank you, Dr. Satya, for this wonderful presentation. And thank you all speakers. So now we will be going for the panel discussion in a while. But prior to that, there will be a pop-up poll for the audience. So once you get the pop-ups, yes, so you can answer, try to be as quick possible. So it'll be like for autosomal dominant optic neuropathy, which type of color blindness mostly seen? Red green color deficiency, blue yellow color deficiency, achromatopsia, or none of the above. Inferoquadranopia or pie on the floor caused by. There are 4 options, you can choose your best. And which of the following set of tests would be least urgently indicated for patient presenting with IOP of OD22 OS46? And the 4th question is, in CRAO, like central retinal artery occlusion, a cherry red spot is due to whether it's hemorrhage at macula, increased choroidal perfusion, increase in retinal perfusion at macula, or contrast between the pale retina and the reddish choroid. Okay, so now we are moving for the panel discussion for this. I have a couple of questions. First is for Mr. Soumya Mukherjee. Like, is temporal raphe visible in pathological myopia? And what program is used in OCT to measure the temporal raphe?
So the temporal raphe is actually, it's not visible. It has to be a very high resolution image. It has to be taken with more than 161 frame per second. And that's why it took a very long time for us to have a cohort of individual to get an assessment, because it was tried many a times before, but at very lower population estimation. So we did an 83 patients to have a understanding of the population as a whole. And what was your second question? Sorry.
Like, what program is used in OCT to measure the temporal raphe? If there is any particular
no, there's no particular program, but there is an ART which you have to select in order to get a high resolution image. It is a horizontal and vertical. We tested both of them, but the horizontal one is the preferred type of imaging frame that has to be selected in order to get a higher visibility in terms of, because if you don't, then there are very high what you call reflections, because we all tested the normal individuals with a less age, like less than 35 years of age. And because we have to have an understanding of the structure of the temporal raphe as a whole, so it was very difficult for us to get a clear image. So we tried many times, many methods were used, but with the vertical high resolution at ART 261 or more can give you a better visibility.
Okay, thank you for your answer, Mr. Soumya. Now we have another question for Dr. Manish. Like, how would you describe the thinning of optic disc by looking at a fundus photo?
I think Dr. Manish is not available. You can carry forward with the other question.
If any other speakers would like to answer to that, or
can you please? What was the question?
The question was like, how would you describe the thinning of optic disc looking at a fundus photo?
The thinning of the optic disc, I mean, unless and until you have a stereo photograph, it would be difficult. But as such, the thinning of the optic rib can definitely be seen based on the cup.
Thank you for the answer, doctor. So there is another question, like if there is any age limit for performing OCT, any lower age limit or upper age limit for OCT scan to be done.
So,
The
I
question was
mean, this
not
question,
directed.
the question was directed towards, I think, one of the glaucoma specialists. But
Yes,
yeah, having
unfortunately, we don't have one. I have another question, which is for Dr. Vasant probably. Like, is the arrest algorithm that you mentioned, is it available with Humphrey or other visual field machines available in the market currently?
RSS is still in development stage. It's almost done. So we are validating the procedure in a different population, but it's at the moment it's not available with any commercial perimetric procedures. And even if it starts, if even it's available, it won't be with Humphrey, at least for the moment. So we're just it's in a preliminary research test, proof of concept stage. So it will take years to come. It will be there in few years time, but not now.
Okay. Thank you for your answers. And just one more question that I have. How important is OCT for the peripheral retinal tear, or like to differentiate the the full thickness tear or pseudo hole kind of?
All right. So in fact, the peripheral OCT, this as a diagnostic modality is not widely available. I mean, it is only a lucky few people who can actually capture the peripheral retinal degeneration on the OCT. But having said that, I don't think that should be one of the determining factors for the treatment. I'm sure clinically we are able to differentiate between retinoschisis as well as a complete retinal hole. So having said that, that shouldn't really deter.
Thank you for the answer and explanation, doctor. And I would like to conclude here the session. For the time constraints, I'll not be able to take other questions for today. For all other questions, we'll try to answer later on maybe. And thank you all the speakers for your wonderful time and the presentations. Hand
Thank
over
you.
to the host.
Thank you.
Thanks, Ujjwal, and all the panelists. The fastest moving muscle in the human body is orbicularis oculi, the muscle that helps to close the eyelids. Do you know how many times a normal person blinks in one day? It is more than 11,500 times. I would like to call Optum Tapashvi Joshi from Rivoli for moderating our next session, the Ocular Alliance. Dear attendees, use this opportunity to clear your doubts and send in your queries in the chat box. Over to you, Ms. Tapashvi.
Thank you so much. Good evening and a very happy World Sight Day to all. Let me introduce our next speaker for today, Dr. Jamil Rizwana. She is a clinical diplomat in binocular vision, pediatric and perception and pediatric optometry, currently working with Rivoli Group UAE as a head of the Rivoli Vision Academy. She is going to share her experience and knowledge on handling asthenopic symptoms in primary eye care clinic. Over to you, Dr. Rizwana.
Thank you, Tapashvi, for the introduction. Happy World Sight Day to all of you. So just tell me if you are able to see my screen. Yeah, is it clear? And my audio is clear, video
yes,
is
we can.
Yeah? Okay.
Yes, we can.
Okay. So first of all, big congratulations to this organizing team that put up a brilliant show. Nice compilation of topics, and of course wishing you all a very, very happy World Sight Day. I'm really proud to be an optometrist. And before I start my session, I would just like to ask a couple of questions. You just can type in the chat box while I would continue to speak. In your own clinical practice, how many number of patients you actually see with self-reported eye strain or asthenopic symptoms? And Mr. Bala just said, you know, like we blink more than 11,000 times a day. And now all of us staring at the screen, we know like we really forget to blink. And then we end up with all sorts of asthenopic symptoms. So how many patients do you get to see in your own practice? Just think about it. and how do you manage them? What tests do you do? What sort of advice you give? And as you keep just thinking about all of this, I'm going to just move into my presentation, which is, I usually, people who listen to my talks must have seen this quote of, a famous quote that I invariably use in every talk of mine, which is from The Fine Arts of Prescribing Glasses Without Making a Spectacle of Yourself by Benjamin Milder and Melvin Rubin. So the quote goes like this: by now you all know it's a fact, there are machines that can refract, that's progress and it must be faced, but you will never be replaced. There are some things machines won't do and complaints still come back to you. And especially in this world of artificial intelligence, machine learning, augmented reality, robotic intelligences, remote testing, and all sort of sophisticated tools that are available right out there, that really looks like as if it's going to remove the human workforce, especially in healthcare. We should all remember one thing, that when it comes to problems, it's definitely the human interface that can sort out the problems with the cognitive realms that we have. And so with that, I think I'm going to start with a couple of cases that I got to interact with our optometrist at Rivoli Vision. So as you see here, this is a case, of course, an autorefractor printout that you would see here of the same patient, apparently. But as you just see visibly, you just see 3 different readings, and then you just see the fluctuating myopia that's going on. And definitely those of us who use autorefractors day in and day out get to see such things. But definitely this is a large deviation, as you would see here. But more than just looking at these numbers as just numbers, as you see here, every number, every average that you get is an average of at least 3 readings, right? And of course, these machines also take an average of multiple readings even before it gives you a reading, depending upon the resolution of the instrument that you use in your practice. But what is really key in here is that, yes, you do see a huge jump, okay? But you also see a change in the pupillary diameter here, okay? So something is going on. There's some fluctuation, accommodation is overacting, there's something that's going on. But the message that I want to convey here is that generally, how many of us take more than just one autorefractor reading? I mean, we just click, tuck, 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 we print out, and then we start our subjective acceptance with just one output. But at least when you are handling with somebody who is giving you symptoms of asthenopia and fluctuating vision, and then you see a jump in from their existing prescription, or all of a sudden you see a newer onset or the first time onset of myopia, then I think it's important to sort of keep your eyes and mind open, and then inquisitively look at what's really going on. That's the first message. Now, this is that of a younger patient, actually. This customer was about 17 years old. And then comes the next one. This one is about 38 years old. And this patient, as you see, we generally think, okay, somebody is about 35, entered into the pre-presbyopic world, and maybe accommodation is done. But even yesterday, we got a patient that was 38, and we saw a very, very similar sort of, fluctuation. Whereas you see here, you just see something like -1 at one point of time, and all of a sudden moving into plano and plus. And again, all of these fluctuations happening more in one eye compared to the other eye. And so it's not that, accommodation is sort of done at a certain age. No. Anybody who strains the visual system to a certain extent ends up with spasms and fluctuations at any age for that matter. And so it's really important not just to, ward off this whole concept of asthenopia and accommodation issues beyond a certain age. Don't do that, okay? So today I will be in the next 10 minutes sort of give you a glimpse of why it's really important to consider integrating binocular vision into your primary eye care practice. Don't just look at it as a specialty and don't think you need a full-fledged orthoptic clinic or a vision therapy clinic to be able to practice. And how this COVID-19 changed this whole, the onset and the prevalence of these problems, because everybody talks about myopia, But as someone who considers BV as very close to my heart, I think it's really important for me to tell you that it was not just myopia that sort of went through a big boom, but also asthenopia and binocular vision anomalies. And also to give you a very sort of a conceptual framework, and then use some cases. So as you look at these cartoons, you see that onto your left you have Mr. Cyclops, who has this one single cyclopean third eye, and that's all he has. Of course, he has just one eye. He doesn't have a third eye, just one eye. And if you see such a patient in your practice, all you need to do is to just give one glass that provides the best vision. Or if you end up seeing you know, a creature like an octopus, you know that any insects, okay, or even octopus here for that matter, have multiple eyes, and each of these eyes operates independently of each other. So there is no point, or there is no concern for you to think about how do I put both these, how do I really care about binocular vision? No, you just have to provide multiple spectacles so that each eye operates independently and has the best possible vision. But apparently we are dealing with human beings, which are the most evolved species, with frontally placed eyes, and as the species evolved in the whole origin, in the, you know, in the evolution spectrum, we did observe the fact that the eyes came closer and closer, and then as human beings, it has the highest cognitive capabilities, with more evolved neural networks, that not just helps us to fixate well, as you see here, but also helps us to bring both eyes together, converge on a particular object, so that despite having two eyes, you continue to see an object as single because of the finest oculomotor coordination. And also you are able to follow objects very smoothly, and also be able to make rapid refixation eye movements. So we should just stop propagating vision as just, you know, a matter of 20/20 or 6/6, but rather as something more, which is the process of fixating, converging, accommodating, making sense of what you see. So vision is the process of deriving meaning from what you see rather than just being able to see clearly. And that is where this whole concept of binocular vision comes into existence. And as part of my doctoral research work, when I, you know, estimated the prevalence of binocular vision anomalies among school children, what I found is that even at that time, this was in 2014 to 17, even at that time, the prevalence of binocular vision anomalies has seen a huge jump compared to the data that was, you know, that came out from the Western world almost 2-3 decades back. So during the same time when we were researching, different papers came out from different parts of the globe, okay, from South Korea, from Africa, from Australia, and all of these papers also pointed out to the fact that this is pre-COVID world, pointed out to the fact that binocular vision anomalies are sort of like undergoing a rampant increase. And there are two important problems that you need to keep in your mind. The first problem being convergence insufficiency, which is the inability to converge, or you know, or poorer conversions present, and that's like 16%. So what does this number tell you? If you're going to see 100 patients in your clinic, 16 of them are going to have convergence insufficiency, and about 11 of them are going to have accommodative infacility. And these are numbers from the 7 to 17 years age category. And of course, as when the visual demands increase in the workspace, as you see here, the famous word digital eye strain that replaced the word computer vision syndrome came into existence. We do see that convergence issues and accommodation issues can also precipitate or exaggerate any symptoms of digital eye strain. So it's not just that you look at digital eye strain as a matter of just, you know, infrequent blinking or dryness or any of or uncorrected refractive errors, but also look at it from the perspective of accommodation and convergence anomalies that could potentially exacerbate the symptoms of digital eye strain. This is a an interesting paper that came during the COVID-19 times from Spain. So during the 25 days of confinement during the COVID-19 period, the authors looked at what is the impact of this isolation on physical activity and also convergence insufficiency. And what they saw is the cumulative screen times almost increased by 200 hours during the 25 days of home confinement. And all of us can resonate with that, right? I mean, we started depending more and more on gadgets and laptops and digital devices for not just, work purposes, but also the whole world changed, I think, after the COVID-19 pandemic. And this trend hasn't actually changed, and it's only increasing apparently because of the increased dependency and the whole paradigm shift that the lifestyles have seen after the COVID-19 pandemic was set. So in this particular study, the increase in convergence insufficiency in these individuals that had an increased number of screen hours was 100%. So apparently, even when you do not have a problem, but if you have a vulnerable binocular vision system, you end up with the convergence insufficiency. Now, how do I put this to practice? Okay. And this is a conceptual framework that I sort of used in my in the binocular vision book that I recently published, where yes, the base of the whole optometric assessment is comprehensive assessment of the eye and visual system, where you have to correct for refractive errors. But after you do that, it's important that you look at binocular vision and then other specialized testings. And unless you put all of this together, you're not going to get a clear understanding of how the visual system is functioning. And so today I'm going to just focus on the bottom two aspects of the testing. So the first case that I just want to share is that of a 34-year-old female who presented to us with complaints of eye strain. And she was just telling us that she couldn't see the near text very clearly. And as someone, you look at the age, not really presbyopic, and then the auto-refraction values give plus 0.5, vision is 6.6, distance visual acuity is fine, but near vision, she is reading with stress. But she is not able to accept any plus on monocular acceptance. So how do you really manage these cases? Generally, some of us end up giving near addition, some of us end up even going ahead with progressive glasses, but there are ways that we can manage. The very first test that I'm going to pull out from the optometric textbook that you all must have read in your second year or third year is what we call as the Borish delay testing. So what you basically do is that first you just show a near text to this patient, ask them to hold it at 40 centimeters and start adding plus lenses in 0.25 diopter steps. You could do this in the phoropter, or I would recommend doing this test outside the phoropter using a trial frame. The whole idea is to look at the maximum plus that's required for someone to relax their accommodation at 40 centimeters. Now, after you do this, then you redirect the patient's focus to the distance visual acuity chart, and you do all of this binocularly. Then you start defogging. So whatever value that you got with the test, with the negative relative accommodation test, with this patient we got plus 2.5. You start defogging for distance binocularly in 0.25 diopter steps. Okay. So first you add plus in 0.25 diopter steps until the patient reports blur at near. Then for distance, you defog in 0.25 diopter steps, and you do it really patiently. And then you look at what is the amount of plus that's required for the patient to be able to read the 6.6 or even 6.5 line clearly, comfortably. And that's what is required for you to close the case or to solve the asthenopia problems in such scenarios. So in case if you are like, do not want to even spend that much time, if you have a retinoscope, then put up what I call the MEM retinoscopy cards that you see here. Ask the patient to read those letters on the card at 40 centimeters, and you look at how much plus you get and use that as a starting point to look at how much plus I should push for distance. If you are somebody who uses phoropter day in and day out, then you must have seen this target in the near card in the phoropter, which we call as the fused cross cylinder procedure. So what you do is put the fused cross cylinder procedure at fused cross cylinder test at 40 centimeters. Ask the patient which lines are more sharper, vertical or horizontal. If they say vertical is more clearer, accommodation is good, decent. But in these cases where plus lenses are, latent hyperopia is present, they usually say horizontal lines are more clearer. Then you put plus until both the vertical and the horizontal lines become equally sharper, and that's the amount of plus that you need for this particular patient. And you can go ahead and prescribe it as a single vision glasses that they can use all time. Now, whenever you see a larger plus with these procedures, think about latent hyperopia, overcorrected myopia, or if the patient does not want to wear glasses full time, then you can think about lenses, what we call as anti-fatigue lenses or anti-eye stress lenses, where you can prescribe lower additions if there is visual fatigue present at near distance. The most important test that I would recommend in addition to the Borish delayed is doing a cover test outside the phoropter. So this is a patient that you see here, which is really important for the next case, where as you see, this is a patient when you just, when without the prisms, when you see that the patient has, just look at the eyes. Okay, just look at the eyes. The eyes are moving from inside to outside. Okay, so doing a cover test outside the phoropter will really help, will provide you with insights if this patient is over converging or under converging. So if you see a ESO, the patient is really exerting too much accommodation. If you see an exo, this patient is not accommodating as much as they should. And if you're using a phoropter, then you can use what we call as the muscle imbalance measure card. At one shot, you can really find the amount of near phoria that is present. So for people who need more information, I will explain to this at the end. So the next case that I want to talk about is that of a younger patient, 16-year-old male. These are cases that invariably, I bet you will see 1 or 2 patients every week if you are on to a really hardcore refractive practice. So this is a child that came to us with the new glasses prescribed 3 months before. The new glasses read -3 and the old prescription was -1.5. So he'd gone to a nearby optical shop where he was prescribed with the newer prescription. Visual acuity was good immediately, but later he started to experience eye strain. And when we refracted again, auto-refracted through different values, the near phoria, as I showed before, when you do a cover test, in such cases, if you do with an existing prescription of such an overcorrected prescription, you will start to see esophoria coming in, because this patient had to now exert more accommodation than what is required with an overcorrected minus prescription. The best practice in such cases, generally in all cases, is to do what all of us know, binocular balancing. So in binocular balancing, as you know, after you do your monocular subjective acceptance, you put plus lenses in both eyes. Generally, you use +0.5 or +0.75. You redirect the patient's attention to a distance chart. You can alternately occlude the eye. So generally, when you put a plus lens in both the eyes, then you see that the visual acuity chart becomes blurred. You can put a vertical prism, 2 or 3 prism base down in front of one eye, so that they see 2 visual acuity charts. They are able to compare the clarity of vision in the right and the left eye. If you've really done a proper monocular subjective acceptance and defogging, you expect both the targets to be equally clearer. But if they say one is more clearer over the other, then you need to add plus lenses to the eye that sees things more clearly. And then after you make both equally blurred, okay, then you start defogging. You can also do the same procedure with duochrome, but all of this is done binocularly, okay? The whole idea of binocular balancing is to balance the stimulus to accommodation in both the eyes. In that way, you ensure that you've not overcorrected the patient. And especially this is so very important in your first time myopic prescriptions, when you see a larger jump in myopia, and then, and like as you saw in this previous case, where all of a sudden you see autorefractor giving you a larger value and the patient is also accepting a larger myopic value, then it's important that you ensure that the patient is not over accommodating. So definitely make use of procedures like that of Borish delayed. And if you want to read more, read these papers, which is a pretty much extensive version of the Borish delayed procedure. Okay, so I'm not going to get into the detail of this procedure. If you want to get into a comprehensive orthoptic binocular vision practice, then definitely these are all the procedures that I would recommend. But the ones that I have put it highlighted in red, which is the phoria, the near points of convergence, and the near point of accommodation. These are three tests that I would recommend that you do not miss for every patient. And if you just incorporate these three procedures in your primary eye care practice by using this conceptual framework, which is do proper history taking, ask for what exactly these asthenotic symptoms are all about, when does it get precipitated, do your refraction right, do your basic procedures, phoria, near points right, do proper fogging, fused cross cylinder procedure. If required, refer the patient to an ophthalmologist for a cyclorefraction, and then you start recommending your visual hygiene 2020 rule, look at the requirement for vision therapy and prisms and all of it. Okay, so to just summarize whatever that I just spoke, even if your patient can read the finest letters on the chart, it does not ensure that they have a very efficient visual system, because vision is not just about 2020. Vision is more than that, and it's all about integrating binocular vision, which is aspects of accommodation, convergence, and your oculomotor movements. And doing simple procedures definitely can help you provide much more comfortable and single and clear binocular vision to your patients. And if you want to read more, you can read the what I would call the Bible for Binocular Vision by Mitchell Scheinman, Clinical Management, or the one that I wrote, which is Keep It Single and Simple, Binocular Vision Testing Made Easy. So it's all about making those small baby steps, and I would be happy to take up questions during the panel, and happy integrating binocular vision into practice. And you can reach out to me on forums like LinkedIn, Facebook, YouTube, and Insta. That's all.
Thank you so much, Dr. Rizwana, for sharing your experience. It was indeed a very helpful session. We shall definitely get back to you during our panel discussion. Moving on, let me introduce our next speaker, Mohammad Oliullah Abdul. He is a co-founder and director for Binox, a vision therapy software, and one of the pioneers for vision therapy research for amblyopia and anti-suppressions. He's going to share with us his experience on the topic of amblyopia management, advanced technology. Over to you, Mr. Oli.
Thank you, Tapasvi, for the introduction. First of all, wish you happy World Optometry Day, and it's amazing to share the stage with all of you, and especially with Dr. Rizwana on the same forum, and talking about binocular vision outcomes. Though it's a little different than the one that she presented, it's more about amblyopia and its newer modalities or advancement in management. During my presentation, if you have any queries, please drop into the chat box so that we can take up the questions during panel discussion. So today's topic to demonstrate or to give more insight about a little bit about amyloidogenic defects in the visual system, because that holds the key of the management that we do. And what are the available newer modalities we have at this point of time so that you can manage? Though there are numerous technologies emerging up, but I'll give options which are available. So I'll try to get into more of overview rather than get into deep into the research part of it. So as definition is a quick review, we know that it is mostly unilateral, but sometimes it is bilateral reduction in the base-corrected visual acuity, which is not attributed to any other visual pathway defects or posterior visual pathway. And the prevalence is quite huge, 2 to 4% of the population, and more so till now we used to think of it's more of amblyopia related to kids, and we never thought of adult amblyopes who are suffering. So it is overall is a huge population which are affected with this binocular vision problem. And it is most commonly unilateral, as I mentioned, but you can prevent all these visual loss which are there due to amblyopia. If you look at the neurophysiology, as I mentioned, that this holds the key of the treatment. So you know that the ocular structures are usually normal. Optic nerve pathway is also normal. But what actually happens in the binocular pathway, which are starting from lateral genucleate body and the primary visual cortex. So if you look at the next slide, it would give you more information that the primary issues are happening at the 4th order neurons and 5th order neurons to manage in a way that we want to look the amblyopia. So first and foremost, we have to correct the cause of it. So if somebody having anisometropia or any refractive error, that needs to be fully corrected. We do have tendency of undercorrection, but if the focusing of the image is not happening properly onto the retina, then the purpose of treating amblyopia gets defeated. So first, a proper refractive correction needs to be there in place before even we think about any kind of treatment. Even sometimes just prescribing right pair of glasses can resolve the amblyopia. Second, again, any kind of deviation that needs to be managed. Now, this is again a little controversial thought in terms of way we manage. So if somebody is looking at a monocular approach, yes, doing the correction of the strabismus at the later stage makes sense. But if you're looking any binocular approach, for that, you need to manage the strabismus prior to doing the binocular involvement of amblyopia management. The very simple reason of correction prior doing it is when you keep both the eyes open and there is a manifest deviation at any given point of time, you will not able to stimulate the fovea of both the eyes simultaneously. Hence, the correction of strabismus, whether you are giving a prism or you give a stick-on prisms or a surgical strabismus correction, which is utmost important for any binocular approach. Again, if you have any stimulus deprivation, source of stimulus getting obstructed, whether it's a congenital cataract, ptosis, any other corneal opacities, that needs to be corrected for amblyopia management. So once we get into the part of treating the visual reduction of the visual acuity, then comes the most commonly practiced one, which is penalization or patching. Then why do we need a different approach? So if you look at this face of the child, that says it all, that, okay, there are so many limitations that are there adhered to the penalization or even patching therapy. Let's summarize those quickly. First and foremost is the compliance. So even though if try to get the best out of it, the compliance becomes poorer and poorer when the child grows. And it is reported to reduce by less than 50% time when the child is more than 5 years. And in adults, it's impractical to patch the good eye, being the work profession or work environment or demand of the visual acuity from the better eye that is in place. Next, the residual. Even if you overcome the compliance issue, then the outcome is limited to a certain level, and it is being observed again. Residual amblyopia 2 lines or more, it is usually be there, even though if you do 6 hours full-time patching for the pediatric patient. And next, the time it takes to improve is very slow. The highest reported is 4.8 line is 4 months, but mostly it is a line for every 3 months that gets reported in the literature. Adult amblyopia, we know that people do try penalization or patching, but the outcome is very, very limited. It might improve by a line or so, but the moment you stop the patching, it recurs. So recurrence is another issue with the traditional mode. And all this point of time, we never thought of what happens to the patient's binocularity, as Dr. Rajasthana just mentioned. It's not about just reaching to 20/20 or 6/6, it's beyond that. And those are the points we never looked at in a traditional mode of treatment. And thus, the emerging concept of amblyopia management is considered to be binocular in nature, and you treat both the eyes together. Now, there are digital therapeutics coming up, but before the digital therapeutics came, it seems to be appeared from a very well-known concept of creating a MFVF environment, which is monocular fixation in binocular field. Just to elaborate what it happens. So if you can create an environment where you have a specific task for one eye under an environment which is binocular in nature, so your the process of the visual information happens in the primary visual cortex in the binocular way, and that results in very good outcome for any kind of vision therapy. So this was very basic concept to create, and based on this, there are multiple technologies are emerging with some variation in contrast. Somebody takes care of the frequencies, somebody takes care of the spatial frequencies. So many things can be altered and create this environment to tackle the amblyopia. Let's see a couple of them available in today's time. So this is one you can do at home. Just to give a red and green filter to the patient and give them a like sketch pen or red and green color and ask them to draw. The only thing you need to remember in the environment of white background, so the same color will strike it off. So if you are particularly taking care of any particular eye, make sure the felt tip pen is to be of opposite color to the filter which is put into the amblyopic eye, so that the patient can use the information from the amblyopic eye more. This chart is quite known to all of us, and you can increase the difficulty or create the environment of MFVF just introducing a red filter on top of it and use the red green glasses and creates a perfect environment for MFVF once again. And these are modified. Now, based on the same concept, you can see these Android games are available called Studio Blocks, Regi Blocks, or Duo Vision, and you can play them. And these are all based on similar principle. So there is no huge innovation into it, but you can see how a basic concept of MFVF is getting incorporated into the digital therapeutics so that more compliance is attained from the patient and you get a better outcome. That is Lazy Eye Snake. Couple of few more games I'll take example. In Apple, you can get Lazy Eye Bubble Shooter, you can get Lazy Eye Breaker, and Jump and Fly. So there are numerous of these opportunities or different games are available to try on. Having said that, now when you have these games, you do not have direct control over how patient is doing, how they are doing, or the customization of the target as per the need of the patient, which is lacking. So the outcome is limited only because of the proper customization as per the patient need. Now, the way in the binocular approach, we can greatly control, I think many of us know this, as the Bangalter filter, you can actually control the amount of contrast of the dominant eye or use the different graded filter, reduce the visual acuity to the level that you wish to do and attain the binocular environment. And this is one of the greatest tools that you can directly control how much patient should see from the dominant eye in terms of reducing the contrast. Now, this is again one of the innovative tools which is there available with us. We can utilize them and help the patient managing in a binocular way to get better results. Let's see what happens to digital therapeutics now. So there is a concept called OccluPad, and they have just replaced the patching in the digital format. So what would it do is it will just replace the compliance level of what you do a physical patch. Now it wipes out the better eye visual acuity completely. As you see, is a Polaroid glasses being used. So the filter is a Polaroid screen they use on the iPad, and one of the eye, which is the dominant eye, strikes off completely. So patient do not see any target, practically do not seen by from that particular eye, only a white screen scene. And from the other eye, patient is seeing the target. Now, this is a great, again, a monocular approach, but converted into digital therapeutics. Now, as the compliance improves, the outcome is very similar what the patching therapy does. Now, moving forward, this is another option available in today's time, named as Luminopia. So they are more of a partial patching method. So if you look at this target, it's typically giving a binocular image. The summation is happening because there is certain part is blurred in the dominant eye, so that the amblyopic eye can see a better quality image and brain can integrate together. And this results is again nice way, and because it is a video content which are available and can be utilized. So there is no limitation of the content. There are more than 500 contents they have converted into this principle, and child can just watch. This is just like watching a video game for them to work with. Then we have Vivid Vision. That's very similar concept. They converted it into a virtual reality model. They use the very similar approach of what the program does. and also gives you effect of binocular approach and give you the visual acuity. I might have certain animation or video to show in this particular regards. So as you see in this case, in a virtual reality, it separates the very similar image being projected into two eyes in a different way. And the amblyopic eye, it like tends to get a different kind of images when the adjustment is happening. So, and at the point of time when patient performs, they yield a better visual acuity because it's done under binocular environment. The advantage is being here, again, the compliance goes up, patient or the child plays the activities and it yields the result. But only major limitation can come across if somebody already having a dense separation, it may not work. Very similar, we have something concept called cure site. Again, as a mix of the concept of previous technologies. As you see, very similar technologies are coming up in a different concept. So again, they have a lot of content, like whether you watch a Netflix or a Cartoon Network, anything, but on their particular specialized device, which based on eye tracker. And they use this dissociative goggles, red, blue, or red, green you can use. And the content is being dissociated in a manner that the particular the focus of the target, which is from the dominant eye, they blurs that image in that particular zone, and then it pushes the amblyopic eye to see. And this, as you see from the dominant eye, this portion is blurred. So it is forcing the amblyopic eye to see the target and watching it's like a movies kind of thing. So again, the compliance goes up, acuity improves, major limitation stands still with a dense separation patient or a patient who has denser amblyopia. Then somebody tried to mix it up and use combination of both monocular and binocular approach. So there are publications there that it can be used as the adjunct therapy, or it can be combined as a monocular and binocular therapies. To our experience, we say that if you combine two opposite mechanisms in a monocular and binocular pathway, then the results can be suboptimal. In this particular program, they tried to combine two technologies or two pathways together and tried to get some results, hence results in very poor outcome. So if you see over here is the activities which are available, it is monocular, and at the some point of time, it becomes binocular as well. So there is a specific device with control of the environment. It gives you results in a binocular approach. Now, this is a very interesting concept to get into a binocular treatment. Now, use of Gabor patches by Revital Vision is one of them. So what it does actually, it uses very specific spatial frequencies, then arrangement of the Gabor patches, the level of contrast, orientation, task order, then context, exposure duration. These all are very critical to stimulate a very specific part of the primary visual cortex. And it usually improves the efficiency of the binocular neurons, and it increases the CSF function, the contrast sensitivity function. And as we know, if you can improve the contrast sensitivity function, it may result in improvement in the visual acuity. So it's more predominantly to improve the contrast function of the eyes, and that results in improvement the visual acuity to extent. And this is a great tool again for adult amblyops who has amblyopia and also limitation in their or a reduced contrast sensitivity for them. Then we also have a program Binox, which is again a dioptic based principle where we try to adjust. We try to overcome some limitation which are there with the earlier technologies, or many technologies try to use the concept of either blurring the image or giving a partial occlusion, or taking care only the perceptual part of it, which is there in the earlier technology just now explained. So we combined a complete binocular pathway with the perceptual learning to improve the visual acuity. So in this, if you see how things are working, so in a normal condition, when there is a separation present, the brain do not see the image from the amblyopic eye. Now, what we do in Binox, we reduce the contrast of that particular dominant eye, and then brain starts suddenly seeing from the amblyopic eye. And why do it happen? Is because the inhibitory interaction in the visual cortex that goes down when you can reduce the contrast. now is about the contrast part. Now, what happens to the resolution activity? So we start with certain activities which are based on the patient baseline visual acuity. And as the visual functions improves for the patient, like contrast, resolution, the perception of vision, and then the games become more difficult by reducing its size, speed, other spatial and temporal frequencies. So it's a combination of binocular treatment along with the perceptual learning. And at the end, it has a program to improve patient fusion and stereopsis. So overall, as a treatment protocol, as you see, the advancements are happening in the landscape of amblyopia. So it is moving from a monocular approach to a binocular one and more of into digital therapeutics. The reason being, with the digital therapeutics and binocular approach, the compliance become very good. And that is the key factor for improvement. And usually the improvement is very fast. You can gain 3 to 6 lines on average from different protocol or different technologies. You can gain this kind of visual acuity improvement. It can distort the binocular vision, effective in older age group. Few of the programs effective, like Revital Vision you saw, Binox, you know that these are the program who can help only even in adults. And we do not see recurrence once you attain the BSB. So once somebody is already developed stereopsis, a very unlikely brain is going to suppress again and one of the eye and gets into the amblyopic state. So this is the key holding factor of improvement that we get into a treatment. Now, what could be a potential limitation on the newer digital therapeutics is you need to correct the strabismus first. As I mentioned, that if you have a manifest deviation, that correction require before the binocular digital therapeutic enrollment. In case of microstrabismus, it has very, very limited role. So if you have a microstrabismus, you do not, actually the density of suppression for the small area is so strong for a microstrabismic patient that you rarely get an opportunity to break the suppression of that small scotoma. And poor visual acuity gain in presence of eccentric fixation. Now, this is directly related to the density of the photoreceptors, which are cones. As we move away from the fovea, the density as well as the size of the cones are less and less. So the away we are from the fovea, less the outcome. So overall, this is how the treatment is evolving. It's time to embed the right kind of protocol for a right patient so that you can get a better visual outcome. Thank you, OPTOVERSE, for giving me this opportunity to share newer invention and modern advancement in the digital therapeutics for amblyopia. Thank you.
Thank you so much for sharing your experience, Oli. It was really helpful to understand some recent advancement technology in amblyopia. Now, before we get over to the panel discussion, requesting you all to answer a few questions, which will be shortly seen on your screen. Okay, the site for Virgin system control is located in there's only one option, which is supposed to be selected. Second, adult levels of stereo acuity using Titmus stereo test achieved by. Third question, eccentric fixation can be detected by. The fourth question will be the average amplitude of accommodation as per Hofstadter's formula for a 25-year-old will be. Okay, thank you so much for the wonderful session, Dr. Rizwana and Oli. Due to time constraint, we would be taking a very few questions as of now. So first question will be for you, Mr. Oli. How to monitor patient adherence progress for home-based vision therapy?
Thanks for the question. I think, so it's very interesting when you treat amblyopia from home. So the monitoring of the patient, how they're doing the session, whether they're rightly following the protocol or not is key factor, again, to give you a better outcome. So with advancement into the digital therapeutics, you can really control what patient is doing from home. whether they are deviating from the given protocol or not, from the tool or the backend control system that you get with the any kind of newer digital therapeutics like Binox or maybe Vivid Vision. So you can control them, and that is definitely gives you a better tool to yield a better result.
Okay, thank you so much, Mr. Oli. For you, Dr. Rizwana, what can be the solution which can we offer for the patient suffering from accommodative insufficiency in our primary eye care practice?
Okay, so the first thing is to diagnose accommodative insufficiency, because in the poll you asked about the Hofstadter formula, so people should know what is the expected average amplitude of accommodation for a given age, and first diagnose accommodative insufficiency. Second thing is management is plus lenses. To combat accommodation, it's always plus lenses. But whether you want to push plus for distance or you want to prescribe it in the near addition form depends on some of the tests that we just discussed. In case if there is no significant refractive error, I mean there is no latent hyperopia, they are like purely emmetropes, but still they have accommodation insufficiency. So even if they are belonging to a younger age group, you can always go with nearer additions. You can prescribe those nearer additions in the form of progressive lenses, then start vision therapy. So once you provide near the minimum plus that's required for them to be able to manage their near vision, then you start vision therapy, improve their accommodation amplitudes and facility, and slowly wean them off from the near addition. So that is the treatment protocol for younger patients with accommodation insufficiency. Of course, when you cross 35 or 37, you don't call it accommodation insufficiency. You start calling it pre-presbyopia and presbyopia.
Thank you so much for the answer. It was really helpful. We would take last question for this particular session, and it will be for Mr. Oli. How different would be analogs versus digital vision therapy for amblyopia?
Interesting question. So analog model, as you remember, the presentation was taking through the entire digital therapeutics started from or based from analog models. So whether you take care of the creation of MFVF concept, which I've showed with the pair of analog glasses, with whether it's a red filter or a blue filter or a green filter used. So those are the base of starting of your digital therapeutics. So only major difference happens in a digital therapeutics is how the patient is doing. So the control over the compliance as well as the parameters that you can customize in digital therapeutics. And that stands out in terms of the outcome. If a patient is sincere enough and doing rightly, analog model gives a very similar results what a digital therapeutics can give. So it's more of compliance and the customization of program, which is added feature in a digital therapeutics.
Thank you so much for the answer, Mr. Oli. It was really great having you people over here and giving some knowledge and sharing us your insights. Over to you, Mr. Host.
Thank you, Ms. Tapasri and all the panelists. It was a wonderful session, I would say. As we all know, cornea is avascular and needs oxygen for its metabolism. Do you know how much oxygen cornea requires? Cornea requires about 5 microliter per millimeter square of cornea per hour. This value varies with individuals from 3 to 10 microliter oxygen per millimeter square. So let's proceed for our session number 4, the front dome. Let me call upon Mohammad Shuhail from Zayed Military Hospital to moderate this session. A reminder to attendees regarding panel discussion, type your question then and there. Over to you, Shuhail.
Good evening and thank you all. Our next speaker is Optom Payal Khatak. Optom Payal is she's graduated from University of West Bengal. She is currently practicing as head of optometry, Shankara Nethralaya, Kolkata. She has more than a decade of clinical experience. She'll be speaking on corneal ectasia and pentagam advance. Welcome, Optom Payal. Over to you. It's fine.
Thank you for the nice introduction. Good evening, everyone. Hope you all are doing fine. Today, I will be speaking about the corneal ectasia and how to see its quantitative measurement with the help of pentagam. I'll be speaking about the various cases. So as you all know that corneal ectasia is a non-vascular disorder with which the protrusion of the cornea occurs with the thinning and associated with blurring of vision and distorted images. The common kind of corneal ectasias are keratoconus, keratoglobus, sclerosed marginal degeneration, teres marginal degeneration, postlassic ectasia. So we all see these things in a normal detection, but we need to measure this in a quantitative way. So pentacam is one of the instrument which gives us a very quantitative analysis of different kind of corneal ectasia. So I first move on to my first case, where a 21 years female came to our clinic with a complaint of blurring of vision, and otherwise there was no as such major complaints, only there was a frequent change of cylindrical power she has noted. And when we did a retinoscopy, we have observed there is a scissoring in reflection is noted, and we could see what is the outcome of the best corrected visual acuity. The vision has improved to around 6 parts and around 6.9, but the clarity of visual acuity was not there for the patient, and the patient was advised to go for a pentacam to rule out any kind of disorder. So when we had done the pentacam, the first in the right eye, we could see it was the keratometry was almost normal, and we could see around elevation of around +10, which is showing in the back vertex. And when you have moved on to the map, which the Billings-Ambrosio enhanced ectasia map, we are seeing that there is a suspect in both front and back vertex, though there was no as such elevation noted. And in the left eye, the elevation was noted in both front and back, and it was detected as a keratoconus of KC stage 1 for the right eye. But for what is the right eye? There was no as such elevation, only the elevation was it was a suspected. So we and in the Billings-Ambrosio, the suspect we could see. So we can say that it is a right eye is a formiform keratoconus. With this two kind of maps, we could keep the patient on a judgment, and we have reviewed the patients for a few months, and after a year we have seen that this right eye has also moved on to a KC1 stage. So this pentacam has given us an idea about the right eye is a suspected keratoconus. So I moved on to my next case, where a 49 years old female visited the clinic with a dimness of vision since childhood. As such, the patient has been diagnosed as a cataract. No such other things was been noted. And when we have did the retinoscopy, we have seen that there was no as such cylindrical power noted for both the eyes. But the vision in the left eye was quite less compared to the right eye, where the vision has improved to 6.9. There was no improvement with pinhole. And when we did a slit lamp, we have seen there is a thinning in the posterior corneal thinning was noted, but that was not that significant, which we can see through the slit lamp. And early posterior capsular opacification was there. The cataract was not that much, and there is a nebular haze for the patient in both the eyes. Again, for quantitative analysis of the cornea, we have done a pentacam, and we have seen for the right eye, there was no as such elevation noted. We can see the maps, it was quite normal. There was no such elevation noted. The keratometric values were also normal, and the Pachy value is also fine. But when we are analyzing the left eye, we could see that there is one keratometric value is a very steep K, when the elevations as noted as there was a quite good amount of elevation both in the front and back surface, and the Pachy value was quite low with the thinnest Pachy of around 331 micron, and the Bellin-Sem ratio chart shows that the detected of keratoconus in both the front and back surface. We could, and when we watch the Pachy progression map, we could see there is a deeping at 4 mm zone, and then again there is an upshoot. And the main thing is when we have seen the Schimflag image, we could see that as because of these elevations are there, we could make out that the ectasia was quite prominent, and it was also detecting a case keratoconus of stage 3. The TKC was showing case 3, but we could make out from it was not a normal keratoconus, and we could see the Schimflag image how beautifully it has shown there was a posterior thinning. So we can make out how Pentacam is helping us to detect the details of the corneal ectasia, where the thinning has been noted, where elevation is taking place, and how much the ectasia has moved on. So when I'm moving on to my third case, a 27 years male visited our clinic with a complaint of distorted of image with a blurring of vision and shadowing of images, and he was wearing only a minimum cylindrical value in the right eye, which is around -1. We have done the retinoscopy. There was the eye reflex was quite clear, and sorry, when we have done the base corrected visual acuity, we have seen there is a change in the right eye with the cylindrical value has come around to 3.5, and the vision has improved to 6.6. In the left eye also the vision was quite good. It is 6.6 only, and the near vision was also very good. But after all these things, the patient was not that happy because still he feels that the shadowing of images is there. And he has also a history of recurrent redness for a long time. So keeping all these things in mind, he has also been asked to go for a Pentacam analysis. And when we have done the Pentacam analysis, we could see the right eye. You can see that a good amount of elevation is noted both in the front and back. In the front, you could see around 25 to 27 within 4 mm zone, and it is coming around 14 like that in the back vertex. And see the map where you can see there is a superior thinning is noted. When we have seen the Bellin-Sem ratio map, you see there's a superior suspension is there. And for the left eye also, as such, there was not that much of elevation noted. Bellin-Sem ratio was not showing any kind of suspension or detection. But when we have analyzed the relative pachymetry map for both the eyes, we have seen that there is a good amount of thinning in the superior portion. So all these kind of maps are giving us a qualitative analysis of where and how much the corneal ectasia is there, and it was a clear suspected case of tense marginal degeneration. So my next case is a 31 years male who has come to our clinic with a history of LASIK done around 5 years back. In one eye, his vision was quite good, but he was complaining at quite gradual decrease in vision in his left eye, and the best corrected visual acuity, we cannot see that there was any changes if we have corrected with any kind of refractive error. And it is up to 6 CF at 15 centimeter, and the near vision was also very poor. So as the case was a post-LASIK, so it was automatically we have to refer the patient for a Pentacam analysis to see the corneal things. And when it's slit lamp, that flap of the flap was clearly visible. And in the left eye, we could see a pressure rings with some horizontal striae. And when the patient has undergone pentacam evaluation, in the right eye as such, it was only in the front and back. We could see in the 4 mm zone, there was it was a borderline elevations, we can say, but as such, there was everything was within normal limits. What we see in mostly in the cases of corneal, post-corneal surgery patients. But when we have done this left eye, we all can see how much the elevated the cornea has become. It is showing around 34 and more than that when we are seeing the maps individually in the back vertex, and in the front vertex it has comes around more than 20, 21, which is quite a good amount of elevation. And you see the keratometric value of this patient, such a steep cornea for a post-LASIK patients, and the Pachy value is very less. And there is this is the Belling's for the right eye, Belling's ratio map. So it is normal for the right eye. We could see there is a detection, and the keratoconus screening, it was showing a KC of 2 to 3 stage. So it is a case of a post-LASIK ectasia. And this is how the pentagram has taken beautifully a shim flag image. You can see how the thinning and cornea. So moving on to a fifth case. Moving on to the fifth case, it is a 45 years male has visited a clinic with the same complaint of a dimness of vision. He was been detected as cataract, and he has mainly come for a cataract surgery. But at this 45 years of age, when we have studied the patient vision has improved only 624 with a high amount of cylindrical value, which the patient has never used any glasses. And when we have seen the slit lamp evaluation was done, there was this inferior thinning was noted, and there was a cataract of around nuclear sclerosis of grade 2, but which was not as such matching with the vision loss of the patient. And because of the peripheral thinning, the patient has been advised to go for a pentacam analysis again. And we have did the same thing for the patient. We have seen butterfly like pattern can be seen over here, and we can see within the 4 mm zone the elevation is also noted. But the very interesting unique thing when we see these cases, if how to differentiate between a keratoconus or with some other ectasia, you can see the K reading of the patient. One of the axis is very flat for this patient, and the other axis is very steep. It is the same way for the left eye. You can see how the colors has changed. It has become more warmer. It is showing that it is more ectatic in nature. And again, see the unique thing, the K reading. It is very flat, very flat in the one axis and very steep in the other axis. We can see a crab-like structure or a butterfly-like structure pattern. And the relative pachymetry is showing an inferior thinning. Belling's ratio for the right eye, there was not such much of suspicion, but in the left eye you could see the inferior thinning with an upshoot after 6 mm. And the shim flag image, we can clearly see how much thinning is there in the left eye. So it is a clear case of pellucid marginal degeneration. And one more thing, when we are studying this kind of elevation maps, I will be going back. So this is in this maps we'll be seeing in the pellucid marginal degeneration or any other kind of generation, which differs from the keratoconus, is we'll be say in keratoconus, in a specific typical keratoconus, we'll be seeing the stiffening and the thinning and elevation, everything taking a place in the same place only. Where it will be the thinning, the stiffening will be also in the same position. But in the other kind of ectasia, we'll see where the stiffening is there, the maps are not moving in that direction. It will never coincide. And it is a clear case of a pellucid marginal degeneration. So with all these cases, we could see how quantitatively and in detail the pentacam can analyze the various ectatic condition of the eye, and it also helps us to see the progression of the disease and helps us in various and the treatment, and it also helps us in detecting the whether the patient wants to go for a CXL surgery or anything like that. So thank you. Thank you.
Thank you, Optum Pal, for this wonderful and informative session. Our next speaker.
Thank you.
Our next speaker is Dr. Aditi Kosh Dastidar. Dr. Aditi is a senior consultant ophthalmic surgeon in the Cornea and Ocular Surface Department, Synergy Eye Care, India. She is also a visiting consultant of Netralayam and Trinatralayam. She was worked with one of the prestigious eye institute, Shankar Netralaya, as a consultant corneal surgeon. She'll be speaking on corneal transplant in complex situations. Welcome, Dr. Aditi.
Thank you so much for the kind introduction.
Yours,
yeah, I'll just share my screen. A very happy World Sight Day to each and everyone.
Thank you, ma'am.
Thank you so much for having me with you all. It's a wonderful program. Are my slides visible? Are the slides visible? Hello. I hope the slides are visible. Can someone just tell?
Yes, ma'am. It's visible.
Oh,
it's visible. Go
thank
ahead,
you
please.
so much. Okay, so I'll be speaking about corneal transplant in complex situations, battling the Pandora's box. So corneal transplant is an ever-evolving art. And yes, the patient demand has increased. The technicalities have improved. So now we are beyond PK now. But it still is a challenge in many complex cases. And PK does become the plan B, the fallback option, or the savior option in such complex cases. So the main aim for any surgeon is how to give the optimum result in such complex cases. So PK is still a savior, yes. So I'll be speaking about few complex cases. So we already know that PK, we were always taught the indications being optical, tectonic, and therapeutic. So I'll be taking a few cases from all of these complex situations and deal the Pandora's box. So maybe we are not able to give 20/20 vision to these patients, but why not give a 20 happy and the best optimum result in such cases? So the first case scenario is PK in keratoconus. So now you'll say, why PK in keratoconus now that we know DALK is there? But there are few conditions that we might have to switch to PK from DALK or from the primary sitting only, we might plan a PK. So what all will be the indications? So advanced keratoconus, status post or resolved height drops. So this is a very big indication. A CL non-tolerant, non-compliant patient. So now what are the challenges faced? The optical decentration of the host, horizontal torsion during the surgery, and the vertical tilt of the host and donor. So now why this acute height drops? Keratoconus is a very good case for planning a DALK. But these acute height drops, we cannot. Even once we have managed it with a conservative treatment, sometimes what happens is when we are even dissecting the plane, there might be these DM tears which give away and there's a double bubble formation and we have to switch to PK. So many of the times when we know there are multiple tears, even after resolution, we know that it might give up. So in such cases, we do plan a penetrating keratoplasty. So intraoperative pearls are an optimal graft size selection. It does not have to be too large or small. The trephination has to be accurate. Cardinal sutures, especially the second suture that we put at 180 opposite at 180 degree is very important. So this avoids the tilt. Tension-free graft position is the main aim. It shouldn't be very tight. Suturing technique, it can be an interrupter or a continuous suture. Depends on the surgeon what best results he or she can give with their own hands. And peripheral iodotomy in such cases is very important, and sometimes we do miss out. And post-op medical management and imaging. So now this imaging, ASOST is a very big boon, because even in early post-op patients, we can see the the host and the graft, the till, and these anterior and posterior segment, whether they are lying correctly in the position or not, or if there is a positive or negative step formation. That means there's a non-congruency of the two tissues. So now one of the cases, the 24-year-old male presented to us during the COVID phase with acute hydrops managed with conservative treatment. And then, so because you can see the thinning, and I knew there were multiple tears, so we planned for the primary PK only in such case. You can see the ASOCT, the graft and host is well opposed. There are not much of any exaggerated step formation. The patient is CL tolerant, but is not using CL because it's already 6-9 unaided. So now coming to the second one, that is penetrating keratoplasty in chronic chemical injury cases. So these are the cases which come to us with a surface, epithelialized surface, acquired surface, might need surface reconstruction, lid adnexal deformity reconstruction, taking care of the limbal stem cell deficiency or any exposure, and we have to treat that before planning a penetrating keratoplasty. So now the challenges faced are that these chemical injury, the limbus is already compromised, and some of them, they are so well, surface is already covered. We do not know what we are going to deal with, where the imaging comes to our aid. So there's a two school of thought of a sequential versus simultaneous limbal stem cell transplant and penetrating keratoplasty, but a gap of 3 months between the two can be followed. So now preoperative, as I said, it is a very complex case. We have to know what is the underlying corneal status, what is the underlying, whether lens status is okay, how is the optic nerve head, posterior segment, and in such cases we cannot get the keratometry. So in some cases we have to take the K values of the other eye. So now we have to know all these prior to planning our surgery, and we have to keep a backup tissue, because sometimes on table we might find a scleral deficiency as well. IOL has to be at backup, because no matter what, how young the patient of such chemical injury, chronic chemical injury patients are, they might come with a very hard cataract. Why? Because they have been using steroid for a long time, or they might have had some trauma. So intraoperative surprise, we have to be prepared in such cases, and modification and the ease of modification of a surgical plan should be always be on our mind. Post-operatively, these patients do require immunosuppression and additional surgical procedures in the future. So here's a very short video showing such case. Here you can see the limbus is bad. It is a total corneal opacity. So now you see it was a young patient, but he had a total cataract. So now I put an IOL because we had already measured it. We have put the IOL, I put the sutures, I put an amniotic membrane as well as slit bits from the other eye, because the other eye was doing well. So here are the post-op results. Here you can see the amniotic membrane has taken out well, and you can see the slit bits as well. So such patients too, if we do a good proper pre-op plan, we can give good results. Another patient, now here, this patient also required on the same table, the lid reconstruction, so a symbiophonic accession, amniotic membrane transplant, slit. Also you can see the IOL well there. So here is the post-op picture, and similar procedure, just the lid reconstruction was added on the same setting as well. Now coming to large diameter keratoplasty. So these are done when the patient is planned for a second PK. That is, the patient has already gone a large therapeutic transplant, perforation because of infection, or a tectonic one for perforation, or in ectasia cases, as Payal ma'am very nicely, she elicited all the cases for PMDA, advanced keratoconus, or refractive. For post-radial keratomy cases, very bad ones, post-hydrop, or very irregular astigmatism. So now the advantage is that in such, because the diameter is large, so we excise the inciting pathology. Now, it also helps in reducing post-op astigmatism. gives a good tectonic stability, and it's a single stage. The procedure gives us limbal transplant as well. But the biggest challenge faced are chances of high graft failure because of the proximity to the limbal vasculature, and glaucoma development. Why? Because we are passing the sutures through the trabecular meshwork. So in such patients, we might need a very early glaucoma intervention as well. So here's a video. Here we could see that the graft was doing well, but the IOP, so this IOP checkup is very important. A very clear graft in early post-op periods should not stop you from taking your intraocular pressure. So if you see, we did an AGV through the pre-existing graft and put a few more sutures, and the patient is doing well, where we can see the AGV tube and a good graft. So this glaucoma management should be on our mind as well. Now, coming to tectonic cases in acute chemical injury. So we know that tectonic, the anatomic integrity is the main aim. Problem is the hostile microenvironment and surface in such cases. We have to provide a vascular pedicle in such scleral ischemic, thin, and even melted cases. So now what are the pearls? Preoperative, we have to have corneal tissue, scleral tissue, amniotic membrane. So backup of tissue and the support of eye bank is very important. We have to follow the principle of chemical injury, no matter what we are doing PK or not. We have to debulk the necrotic tissue. We have to provide a vascular pedicle through tenonplasty, assess the graft size preoperatively, and be ready for during operation, a scleral thinning or melt as well. So post-op medical management and additional surgical procedure, the patient has to be counseled very well. Now, I'm showing a surgery video. So here you can see the iris prolapse is already there. So it's a corneal perforation and a pre-scleral melt case. So I've used the graft itself on the scleral and the corneal perforation, followed by using tenon pedicle from 360 degree and conjunctival remnant conjunctiva and amniotic membrane in such cases. So here are the post-op pictures. So this patient came to us post-chemical injury in such condition. We could see this a scleral ischemia, more than 3 clock hours scleral ischemia. And this is in the first post-op period when we could see that the graft is edematous, but it's taking in out well. The scleral ischemia is gone. There is no scleral melt, and amniotic membrane is well integrated. Now the patient post-op follow 1 year has a PANUS, but has a vision of 6/9. So definitely might need a PANUS excision only if the patient is concerned regarding the cosmesis. As of now, the vision is doing well. So now visual outcome post-therapeutic cases. So now the main aim is infection control, not visual rehabilitation. First, we have to restore the glow. So indication we do in such cases when the cornea is involved, or there is an obscuration of the visualization for a VR, that is a vitreoretina procedure. Challenges faced is the extent of location. How much is involved, we are not able to assess because of the emergency of the cases and the adjacent sclera involved. So now in such cases, what comes to our aid is this temporary keratoprosthesis or K-Pro, which we, after excising the infected cornea, we put it over the area so that the vitreoretinal surgeon can do the vitrectomy, IOB, lensectomy, and then we put a graft. So in a way, we are removing the involved cornea, we are not deteriorating the cornea with additional procedure during the primary procedure. So giving the graft a survival, a shot at survival. So microbiological analysis and backup tissues must in such cases. Flaring a scleral fixation ring is very important. Peritomy done to see whether any scleral involvement is there or not. Landis temporary keratoprosthesis is a very helpful tool for us cornea surgeons, and micro and HP, both are very important. So primary graft survival might not be that well, but still it gives a very good visualization during the surgery, and it prevents a hindrance caused by a graft edema. So now here's a video. So here you can see it is a patient of endo with a corneal involvement and vitreous. So now what we can do. So here you can see the vitreoretinal person has already put the ports. I'm removing the infected cornea, and now I'll be putting a keratoprosthesis, a temporary Landis keratoprosthesis. After this, you can see the vitreous exudate and the lens involvement. After this, the vitreal surgeon will do the surgery, followed by I'll put the good graft over there. So here an ectatic graft has been put because the central cornea was looking good. but the scleral area was looking tendon. So here we have used the graft ectatically. Thus, the central cornea remains preserved of the patient as well. And here you can see, so this is not a graft failure. This is the iris pigments have been removed during the wash and during the exudate pulling and vitrectomy. And a follow-up of 2 years, the kid is seeing 6/9 with a very good contact lens. So having a contact lens trial and a very good contact lens trained clinic and optometrist is very important and aids in our work as well. So the take-home message will be aim for the best possible outcome, tailor-made approach. Every case is different, so we have to deal it differently. Patient counseling in all cases is very important. Intra-op surprises, we have to be prepared. We have to be very comfortable modifying our surgery during such surprises. And PK, no matter what, old is gold, is a savior in such complex situations. These are my references. I would like to thank my parent institute, Shankar Nethralaya, my excellent teachers, team of colleagues, optometrist department, Ms. Payal, Ms. Monica, Ms. Momita, and my fellows, and Dr. Mona Bhargava, and my present team of Netralayam, Synergy Eye Care, and Trinitralaya. Thank you so much.
Thank you, Dr. Aditi. It was a very informative and wonderful session. Thank you for
so
sharing your experience.
Thank you.
Thank you. Our next speaker is Dr. Amna Almazmi. Dr. Amna is a consultant ophthalmologist and in cornea and iris segment in Zayed Military Hospital. She has completed her ophthalmic residency from Sheikh Khalifa Medical City. And she also has multiple clinical fellowships in cornea, one from University of Montreal and another from University of Nottingham. She has also completed her clinical research training from prestigious Harvard Medical School. She'll be speaking on post-keratoplasty astigmatism management. Welcome, Dr. Amna. Over to you.
Good evening, everybody. Thank you, Suhaid, for this kind invitation and the kind introduction as well. And on behalf of EASO, I actually would like to thank everybody for their attendance, their contribution, the fact that we are collaborating across the world in order to spread the knowledge that we have earned. How can I share my screen, Suhaid?
One second, ma'am.
Ma'am, you can see the green color share screen. So just click this one. Choose the first option from the top left.
Sorry for this technical issue. It has to do with my computer blocking me to share my screen. I should have run a test drive as Kamal had instructed me earlier, so I apologize for this glitch. Okay, Kamal, I will send my email to you, my presentation to you. It seems that I have to quit Zoom before joining in again.
Yes, sure, ma'am. Then you can send me the presentation. In the meantime, we can go for the Dr. Ahmed presentation, and then you can join after that. Is it okay?
Of course, certainly.
Good evening, ma'am. It could be very quick. You need to just allow it from system preference. And once you allow it, quit the Zoom and rejoin. It will be very fast.
Okay,
I'm sure you're using a MacBook. That's why it's additional security measure.
Okay, I'll just log out. I'll come back again.
Right. It's going to be very quick.
Dr. Ahmed. No.
Yeah, Dr. Amna will be joining us after this session. Our next speaker is Dr. Ahmed Al-Saadi. Dr. Ahmed is a senior corneal consultant. He's specializing in cornea and iris segment. He's one of the leading cornea and anterior segment surgeons in the region. He has successfully performed hundreds of complex anterior segment and refractive surgeries. Dr. Ahmed will be speaking about corneal aberration and its application. Unfortunately, Dr. Ahmed will be joining us after a couple of minutes. So we have, he sent us a pre-recorded video, so we'll be playing that one. Hopefully he'll be joining us for our panel discussion. Over to the host.
There is no audio playing in the background.
Kamal, I can start if you want. I think I'm up and it's up and running.
Yes, ma'am. Then you can start, ma'am.
And thank you for whoever gave me that heads up. It actually worked. So thank you again for having me. And I apologize for this glitch. Obviously, we know that post-operative astigmatism may contribute significantly to the poor visual outcome in an otherwise much successful keratoplasty procedure. So in order to give you a heads up of what I'm going to talk about today, I know it's very late in the evening, especially with the time differences between us and in the other continent and the other countries. I'm going to discuss about astigmatism in brief and different approaches where we can address the astigmatism, in addition to the advantages and disadvantages with each approach. We know that the vision, we know what aberration is, and astigmatism is an optical aberration. And we know that there is no such thing as a perfect image. So as light passes through the optical system, it's always subjected to distortions. And we know that aberrations could be of low order aberration or higher order aberration. And that's the next talk where Dr. Al-Saadi will talk in depth and clarify whatever questions anybody has. We also know that the circle of least confusion, where on the other hand, it's actually the circle of most confusion. And it happens when two rays that are coming perpendicular to a plane on the optical axis, they have different foci, which results in a blur in one direction that is absent in the other direction. We know that regular astigmatism could be classified as with the rule or against the rule or oblique. And this simplifies when we want to discuss things amongst ophthalmologists or between optometrists, because they come from different backgrounds and sometimes they use a positive cylinder or a negative cylinder in order to correct it. So what factors influence the amount of astigmatism following a transplant? So there are multiple factors, and I've kind of summarized what I thought were important. We know the stage of the keratoconus, the trephination, whether it was eccentric or not, the graft size and donor, and whether there is a recipient mismatch, the corneal thickness mismatch at donor-recipient interface, the way suturing technique is, and the timing of suture removal. And suturing technique is very important. This is something I also tell I tell the residents who come and rotate with us, that the way the bites, the torque, the tension you apply, all matters eventually. So, sorry. This is just a diagrammatic presentation or a slit lamp image to show what kind of sutures that could be done in a patient's eye. There is a continuous suture, the image you see on the left. It could be a mix of continuous and interrupted. It could also be both double continuous. So it's variable, and it all depends on the training you've had during your fellowships. So that's the important part, vision rehabilitation. We know that when you want to address astigmatism, there are different measures in doing it. You can be conservative or you can be invasive. We tend to start with contact lenses, and then there is corneal-based refractive surgery, and there is lens-based refractive surgery. However, in order to choose the type of management that is most convenient, you need refractive stability. You need 3 to 4 months to elapse after the sutures had been removed, and obviously the stability is confirmed through refraction and topography. To speak about each one briefly, I know that the majority of the audience today are optometrists, and they have different expertise in fitting people with contact lenses, and it's a skill that it is very important to maintain, especially when you practice with a cornea service. We know the different kinds that exist, as you can see in the flow charts in front of you, and the ones that are coming up frequently are the corneal, the rigid gas permeable, and the scleral contact lenses. However, with contact lenses, we know that they can induce peripheral corneal vascularization. There's also risk of infection, risk of rejection, and also the usage. So how well trained is the person in fitting the contact lens and in wearing it as well when we talk about the patient. So if we move on to talk about the corneal-based refractive surgery, we know that there is, it could be divided into 2 main categories. We have the astigmatic keratotomy and the excimer laser. If we mainly mention about the astigmatic keratotomy, we know that it has multiple nomogram, depending on what is your normal approach, whether it is manual using a diamond knife or using the femtosecond. And currently the norm is leaning towards using the femtosecond because of the reproducibility of the results with it. However, it can be unpredictable. And normally when astigmatic keratotomy are performed, they are mainly performed as pairs. And there are mainly several important considerations that need to be accounted for, and that is the location of the graft-host junction, as you don't want to place the docking and perform the incision at sites where the graft-host junction is to avoid graft dehiscence. And occasionally you may need to use augmentation with compression sutures. Okay. If we look into the literature tells us that in order the amount of astigmatism that can be corrected can be up to 15 diopters of astigmatism. However, that depends on 3 main important factors, as you can see highlighted within the table in front of you. You have the optical zone diameter, so how far it is from the pupil, the incision depth, and this is mainly related to the corneal thickness, the corneal thickness that you are doing the procedure on, and the angular arc, so the degrees of how big you want your incisions to be created. The second corneal-based refractive surgery are the excimer laser, and that includes both the PRK and the femtosecond LASIK. However, the planning is normally done according to the refractive error, the best corrected visual acuity, and the degree of higher order aberration, because you may need to have a stepwise approach if you had irregular astigmatism that where you may need to do trans PRK initially before proceeding to correction of the refractive error. However, as reported in literature, there is always risks of haze, regression, rejection and occasionally wound dehiscence when it's performed with the LASIK surgery. Moving on to lens-based refractive surgery. Okay, we have different lenses that could be used, whether it was phakic or basically removing the lenticular changes that can exist. The advantages of it can be done in a stepwise approach where if significant higher order aberration exists, it can be addressed. It also corrects regular symmetrical astigmatism, and it's effective and predictable. However, it can be problematic if the graft fails, and if you are to treat higher amount of cylinder, the chances of rotation can go up to 40%. And obviously, there is always risk of causing endothelial cell loss. So if we are to talk about phakic IOLs, we obviously need clear lens and a regular symmetrical astigmatism. The advantages, so why would you use a phakic IOL in post-keratoplasty? The fact that the patient may have anisometropia, so their glasses and they are intolerant to the glasses because of anisometropia, or they're contact lens intolerant. And we know that keratoconic patients, for example, they have higher tendency to be intolerant to it. How about corneal-based procedures? We know that occasionally there is issues with wound healing, the graft survival, and obviously the risks of having haze, as well as the complication ratio with less of the predictability as a result of the treatment given. With phakic IOLs, it is more predictable. It can preserve accommodation since these patients normally are of a younger population. If we talk about the keratoconic group, there is minor manipulation to the graft, and there is no compromise to the structural integrity of the graft. However, we need to pay in mind the direction of the wound construction. Obviously, there is contraindications to placing a phakic IOL to treat the astigmatism. It's ideally avoided in patients who have uveitis, glaucoma, or a mesopic pupil of more than 6 millimeters because of it inducing higher order aberrations. You also need a comprehensive eye exam, as with any other procedure we had talked about earlier. One of the commonly used posterior chamber or sulcus placement IOLs we have are the Collamer lenses. As mentioned previously, the construction of your wound is very important. It definitely needs a bigger wound size, so you need to place a suture following to it. And what is important is measuring the wide to wide. There are different modalities for that. One of them is using the OCT or using a regular caliper in the clinic. Performing an iridotomy, it depends on the model you're using. Newer models already have a central hole that allows aqueous to flow through it and decreases the chances of glaucoma building up. There are also other approaches that can be performed, such as lamellar wedge resection, but that is unpredictable because it depends on how much tissue you want to remove and the tension of suture tension you are applying and the timing of when to remove the suture following the resection. It's controversial, but I had to mention it because it was listed in the literature. That's the use of intracorneal intracorneal ring segments, which is not normally used in patients who are grafted. And the last option, if the astigmatism is so high, is to undergo for a regraft, which we try to avoid with the previous techniques that was mentioned earlier. So prevention obviously is the key, and intraoperatively that could be achieved by the technique of suturing, the size and the centration of the trephination, avoiding override of your tissue, and timely and progressive removal of your sutures. That's for my talk, and I would take this opportunity and this window to invite everybody to Adore which stands for Abu Dhabi Ophthalmology Review, and we yearly talk about a specific topic within ophthalmology. And this year is going to be an intensive 2-day course talking about cornea and refractive surgery.
Thank you, Dr. Amna. It was very informative and wonderful session. Thank you very much, ma'am.
Thank you.
We'll move to our next speaker, Dr. Ahmed Al Saadi. He's just landed, so hopefully he'll be joining us in a couple of minutes, we're expecting. So meantime, we'll be playing a pre-recorded video. So, yes.
Hi, good evening, everybody. I'm Dr. Ahmed Saadi, and it's a pleasure to be amongst you. I'll just would like to take this opportunity to appreciate the organizing committee for inviting me. I'll be talking to you about wavefront aberrometry, a brief overview. I have no financial disclosures, and I would like to acknowledge Dr. Amna Al-Mazmi and Dr. Kashif. I'd like to start by talking about and outlining my talk. I'll define the aberrations, then I'll discuss how do we measure it, and then I'll move to show you how do we present aberrations to the end user, and then I'll speak about how does it affect the vision, and then an overview of the aberrometry's application in ophthalmology, and finally conclude. Wavefront aberrometry is not an easy topic to understand. It's pure physics to start with implication on the eye. But having the crowd here as an optometrist, I'm quite confident that you will enjoy this. So wavefront aberration is basically all the imperfections that the wavelight will suffer during its travel from the tear film into the retina and then back as we measure it. So all the imperfections of the optical system, which is our eye, cause to the light rays to deviate from their desired path is an aberrations. And in brief, this could be a lower order aberrations, which you guys deal with on daily basis. That's myopia, hyperopia, and astigmatism. That's so-called lower order aberrations. Anything that you can correct with glasses, and this makes up to 85 or more of all the ocular aberrations. Then we have what's so-called higher order aberrations, and namely I would like you to concentrate on three things, because these are the aberrations that affect the vision the most, which are spherical aberration, coma, and trefoil later on. So how do we measure aberrations? We measure and generally, if you want to see how does that affect the eye, so the superluminance diode laser will be sent into the cornea, into the patient's cornea through the lens into the retina, and obviously it will not be distorted because it is a laser. Down to the fovea, the reflection from the retina comes out spherical while passing through the vitreous. As the wavefront passes through the lens and the cornea, it becomes retarded or advanced. It depends. Some will go before, some wavelights will go behind, and this will produce that distortion to the wavefront. All of this will be collected, and this is, as you can see, the laser beam went in, back through the lens and through the cornea, distorted wave that will be received on lens slits, and it will give you this pattern, and that will be translated on the video detector, giving you the deviation which we talked about. And here is how Hartmann shock is presented. If you look at the image on the top, that's a perfect eye which does not exist because our optical system is imperfect. And then we have what's so called the aberrated eye, and you can see here. So generally speaking, the aberrations of the eye we presented through polynomials, and polynomials basically are mathematical equations, and one of the most important ways is the Zernike and Fourier. Having said that when we talk about Zernike is a very important common way of presenting it, but Fourier can be the best method when you measure a very aberrated cornea like keratoconus. But for the sake of this talk, I'll cover the Zernike because it's the most commonly used way of presenting it to ophthalmologists. So let's just look at this image, which we look at times, and we don't feel happy looking at it because it's a little bit complicated. But if we want to think about how do we present aberrations, generally we present it in a pyramid. So it's a Zernike pyramid, and that's why it's called pyramid. And you have to think about it as each line from the top to the bottom, 0, 1, 2, 3, 4, 5. So the order is the horizontal. So 0, 1, 2, 3, 4, 5, 6, 7, 8, infinite number. But what matters to us is up to 5. So 5 for ophthalmology is what we care about. Then when we look at the vertical lines, you'll find that the vertical lines is number of meridional cuts, if you like. So if you have one cut, imagine this as a pizza. As long as the pizza is not cut, it's 0. If there is one cut vertically, it will be 1. Or if there are 2 cuts, there will be 2. If there are 3 cuts, it will be 3. So you have to think about the number of cuts, and you can see this is very evident. Here 1, 1, 2 cuts here, so you have 2 cuts here, 3 cuts here. And you can see that it jumps. So usually one is skipped. Every time one is skipped. And anything to the left of the 0 is minus, and anything to the right is plus. How do we write this? So usually we have Zernike, which is Z, and the number below is the order. So it's the horizontal line, and the number on top is the vertical line, if you like. And as we just mentioned, the 0, 1, 2 are the low order aberrations, and anything above that is high order aberrations, and I will go into some details. So we talked about first order, second order. I'll just briefly tell you what does that mean. So in 0 order, it's a piston, and the name comes, yes, from piston that's in the engines. But a very common phenomena is the eclipse, when especially the solar eclipse, because the moon is much smaller than the sun, but still it can block it, and this is because of the effect of the distance. Our ocular vision, or our ocular quality of vision, even if you have it. Second order, we just touched upon it. Anything that you can correct with the glasses, myopia, hyperopia, and astigmatism, and this resembles up to 90%. fourth order. Fourth order, there we have spherical aberrations, and this can be positive or negative. Most importantly, the use of it. We induce high order aberrations, which are positive aberrations, when we do refractive surgery, laser refractive surgery. But when we use this in our favor, we do the extended depth of focus lenses. And this is how we treat some of the eyes, or even when we talk about the Q. This brings me to an important point for you to take, is when we talk about Q value and spherical aberration. So Q value is basically the asphericity of the cornea, how much the cornea is aspheric. And in general, the ideal Q value for a perfect parabola is minus 0.5. In our cornea, it's minus quarter, and it has no unit, and it only measures the anterior corneal surface, while spherical aberration is part of Zernike, and it describes both the anterior and the posterior surface of the cornea, and it's measured in microns, which is the deviation of the light, and it's generally in the human eyes it's a plus 0.27. So please, and this spherical aberration, we change it in order to have extended depth of focus as well. So how does it affect our vision? In brief, the quality parameters are affected by the pupil size, so we have to be careful about the diffraction. And there is another way, which is called modulation transfer function. I think it's beyond the scope of this talk. Here, so what are the application of wavefront aberrometry? Generally, it's the wavefront guided excimer laser that we use in order to correct the surface, especially in irregular corneas and in refractive surgery. Also, when people design intraocular lenses, especially extended depth of focus, in order to have a good quality of vision. And the last one is expanding depth of focus, either by affecting the cornea or the lens. In conclusion, aberrations are cardinal for the quality of vision. Despite the advances, no optimum technology yet, and the limitations are not only because of the technology, but also because of the tear film, pupil, and eyeball is dynamic. Age and most of our surgeries are inducing high order aberrations. Thank you very much for having me, and I will be ready to answer the question with the panel later. Thanks.
Thank you, Dr. Ahmed, for joining us. We all know that it's been a long trip, and thank you for showing a support. And it was a really wonderful session, and it was very informative. Now the forum is open for panel discussion. Stay tuned for a few seconds while the questions appear on the screen, and kindly choose the answers, and shortly we will go to the panel discussion. So the question is DLK ideal surgery for acute eye drops? We have a true false answer. You can choose one of them from there. Then we'll move to the second question. Is visual rehabilitation primary aim of therapeutic penetrating keratoplasty? The third question is modular transfer function, MTF signifies. The answers are there. You can choose one of them. Band-shaped keratopathy is commonly caused by deposition of. You can choose answers. this is end of the session. Thank you all. Thank you all. We really thank you for all the speakers. All informative and wonderful session. Now we will move to another session.
Thank you.
Also, if any questions are there from the audience, so you can put it in the Dropbox. So we'll be asking to the, just mention which speaker. So we'll be asking the questions to them specific accordingly. We have the one question from the audience to Pyle, Optom Pyle. What is the best method to manage posterior ectasia? Optom Pyle.
Best method is we have to see the how much ectatic condition is there. If we can do a correction with the glasses, it is fine. Otherwise, we have to move on to the specialized contact lenses. Can be up to a Boston scleral lenses. After that, it depends on the consultant. They will be doctors will be judging the corneal conditions, and they can move on to the surgical options.
Okay, thank you. And one more question to Dr. Pyle. In the day-to-day practice, we often find it difficult to diagnose these FFKC cases, especially we go for keratorefractive surgery. So which topographer would you prefer to have to diagnose FFKC cases, early keratoconus cases?
Any quantitative things for the cornea, we have to go through the Pentacam is the best advanced technologies we're having. So it will be giving a detailed idea about the FFKC cases. So where any suspicion of keratoconus will be judged, so that we can do a review of this screenings. So I feel that Pentacam is the best option.
Okay.
If I just may comment, thank you very much, Doctor.
Yes, sir.
One important thing for the audience to know: we have different. Are developed. We are going into the OCT based, but before we used to use the Placido disc. So generally speaking, Placido disc can detect the changes earlier, especially in form frost keratoconus. Yet, having said that, some of those Placido discs, they do not have something like the bad KC or Billin-Ambroso or equivalent programs. So currently we are developing this, and form frost keratoconus is a difficult diagnosis at times. That we look at it, it's like a glaucoma suspect. It's still difficult to call. So just keep in mind that the machines are good, but Placido disc sometimes can, the Placido topographer can show you earlier changes, but today the shine fluke images are better than those when you look at them collectively. Thank you.
Thank you, Dr. Ahmed and Dr. Pyle. Next question is to Dr. Aditi. What is your opinion on tectonic keratoplasty, and what will be your goal in such cases? Dr. Aditi, it's for you.
Tectonic keratoplasty. So, right. Thank you for the question. So in tectonic keratoplasty, the aim is globe rehabilitation, globe anatomically restored. Once that is done, so we have to counsel the patient very clearly that this is the primary aim. We are not doing it for visual rehabilitation. So it is going to take up only once we have anatomically corrected the global integrity. So this counseling nowadays to the patient, attendant, medico-legally being safe is very important. So it should be done. Obviously, it is a primary, primary repair is very important. And if you do a good primary repair with a good medical management, sometimes the graft survival is also good. If infective case is not there, especially if fungal etiology is ruled out. So in our institutes, we always send, some micro and histopath analysis to rule out any fungal etiology, so that we can start a steroid on an early basis for a better primary graft survival. So yes, tectonic cases are very important, and they have to be dealt very correctly and at the proper time on emergency basis. Thank you so much.
Thank you, ma'am. Thank you, ma'am. It was informative. We have a couple of more questions also. We'll move to the audience questions again. This is for Dr. Amna. What is your best approach rather than contact lenses for the post-PK corneas with high astigmatism? Ma'am, for you.
So this is a very vague question, and it basically depends on how much the patient can see, what is his best or her best corrected visual acuity, and whether they have certain irregularities on the surface that could be addressed prior to any more invasive approach. So as mentioned earlier, like you'd want to, as Dr. Ahmed had mentioned with the higher order aberrations, if you can address that prior to implanting a lens, maybe that would be that would provide with the patient the clarity that they're looking for. Sometimes it is not the lines that they want, it's just how good can the quality be improved. And following to that, you can see sometimes just by doing regularization of the surface, the patient can be happy with the glasses. You know, it also depends on what's the variation between both eyes, whether they have an isometropia, is it are they tolerating other forms of vision correcting methods, and then you would consider the other approaches, whether they were the astigmatic keratotomy or the phakic IOLs surgery. And if the patient had cataract, then you would consider other modalities to address the vision as well as the toricity. I hope that answers the question.
Yes, ma'am. Thank you. Thank you. It was very informative, ma'am. We have a last question to Dr. Ahmed. This is from, as optometrists, we often find it's hard to manage these symptomatic, especially post-LASIK cases. The patient comes with a starburst and other symptoms. So what is your, how do you manage these clinical cases? If these unhappy patients post-LASIK, maybe like after 1 year, 2 years, maybe sometimes we often find these cases. So what is your perspective on these cases, the management?
Well, I guess the question is for me. Am I right? Right?
Yes, sir.
Because I'm losing the signal. Yeah. So
yes, sir.
The
For you,
important,
Dr. Ahmed. Yes.
First of all, not all positive dysphotopsia are related to high order aberrations only. Definitely high order. Whenever we do any surgery in the eye, we are inducing aberrations. This is a common fact. But what we need to keep in mind, always I approach the patient by reassurance for 6 months. Sometimes it eases off after 6 months because the patient needs to hear the reassurance, number one. Number two, if it was pure spherical aberrations, I look again also for I make sure that the patient is lubrication very well, no blepharitis that I am missing, no meibomian gland dysfunction, and the tear film is very much stable. If there are issues, I address that. If the patient continues to be symptomatic, especially with spherical aberrations, I give them some alpha-GAN, brimonidine, to constrict the pupil at night to minimize this. And if none of these modalities works, after 6 months to a year, I might consider going for removing a spherical aberration, especially if you have a platform, laser refractive suite platform, which addresses specifically the aberrations, the high order aberrations, and I have no financial interest here. For instance, the Schwenda Maris gives you this flexibility to address only certain high order aberrations like spherical or trefoil. You just choose your own. But I don't jump directly. I wait, give the patient time. At times, your epithelium will try to heal the cornea and give them better vision. Sometimes reassurance patients, they can't tolerate this because you cannot be sure if you do more intervention that you will not induce other high order aberrations. So always talk to your patient, gauge it, and address other concerns. Look at times for the lens, because sometimes
the cataract might start or something. And this might give you also false feeling that this patient is having glare or halos but the lens is having a problem. Look at their peripheral membrane if there is any peripheral membrane. So do collective look at everything. Don't assume it's just high order aberrations. I hope this answers the question.
This is crystal clear, Doctor. Thank you very much for this, your clear answers. Thank you for this wonderful sessions. I thank Dr. Ahmad, Dr. Amna, and Dr. Aditi and Dr. Pyle. Thank you very much. It was very informative session, and we all learned a lot from you. And thank you for sharing your expertise and experience with us. Now I'm moving to the host. Thank you once again.
Thank you very much. Thank you for having us. Thank you. Bye-bye.
Thank you.
Thank you.
Thanks, Mr. Sohail and all the panelists. That was a very lovely session. As we all know, people with high myopia have longer eyes and more chances of retinal complications. Do you know the probability for myopic maculopathy in myopes? 1 diopter increase in myopia will lead to 67% of increase in myopic maculopathy. So as an optometrist, it is our duty to control the myopia. Now I call upon Optom Sharath Raj from Medicals International for moderating our next session, myopia and contact lenses. We are open to discussion at the end of the session. Keep your questions ready. Over to you, Mr. Sharath.
Can't hear you, Sharath. Your mic's off. Still can't hear.
Thank you all. Good evening, everyone. Let us welcome Mr. Zakri, currently working as a deputy head of the optometrist at Moorfields Eye Hospital, Dubai. He is an active GOC member, practicing contact lenses and the myopia management for the pediatric cases. He is going to share his experience on myopia management. Hand over to Mr. Zak.
Thanks, Sharath. Let me try to share my screen. Good. Can everyone see my screen okay?
Yeah, we can see.
Okay. Yeah, thank you very much for having me. Just let me reduce that. And we've got quite a lot to get through here with myopia management in the next sort of 10 to 15 minutes. So it will be a very quick whistle-stop tour of what I use in practice and what's available out there. Unfortunately, there's no financial disclosures with this lecture, but let's get on with it. And what we want to do is we want to address the, the big bad guy in the room, myopia, something that's on every practitioner's to-do list or to conquer list. So let's get on with it. Good. So let me start off just by very quickly saying that I don't like the term myopia control. I think it leads parents into a false sense that we actually have the ability to stop children from becoming more myopic or their prescription from increasing. A much better term that we like to use in practice here is myopia management. And as it's been discussed here already, there are many risks associated with myopia. Some of the key problems or some of the key issues have already been highlighted tonight. And with this big bad guy, we've got, for example, myopic maculopathy. Each of the figures highlighted below in yellow is the increase per diopter of myopia. Okay, so retinal detachment increases by 23% risk per diopter. Glaucoma, we know that there's a strong correlation there. And then the last one's the overall chances of an increase in visual impairment from this. Now, these are quite staggering numbers. The next graph, I'm sure most of the practitioners on here have seen. So this is where are we today versus where are we aiming for in 2050. And this is a massive increase with, the commonly stated figures are 50% of people having myopia by 2050, and 10% of that cohort having higher than 5 diopters.
So this is the future.
Thanks, Thanos. So why is it important to delay this onset of myopia? So we know that younger children that present in clinic with myopia, the younger they are, the higher risk they are of becoming a high myope. Now, no level of myopia is safe, okay? So even if a patient is -1, that is still an increase in the predisposition to some of these potentially blinding, sight-threatening conditions. So we really want to reduce that as much as possible. Now, obviously, if we have a patient that's 3 years old and -1, they're definitely going to be at a higher risk than those are 16 or 17 and finishing up their growth cycle, okay? So something just to be aware of, that we need to look at not just the prescription, but the age of these patients as well. Now, the closest I could find to what we have at the minute is what's kind of going on in a few of the Asian countries. And they've summarized basically what are we giving to these children who are myopic. And unsurprisingly, 90% of children are fitted with single vision lenses. And we know that this has very little capabilities of actually reducing the myopia. Now, 8% is in regular soft contact lenses, and only 1 to 3% of these patients are actually using any aspect of myopia management, which I think is probably unsurprising to most people on here. It's something that's been pushed to the fringes. It's something that's potentially a little bit niche. But hopefully today I'll give you some of the options that we have in our arsenal to tackle this. Now, atropine's been around for a long time. It's been used since about the 1970s. And obviously it has the pupil dilating effects, the cycloplegic effects. But when we're looking at it from a myopia standpoint, okay, the evidence is very robust. It's been around for a long time, and it is an excellent myopia management device. With the low dose atropine, vision's still very good, but the issue is, the duration of treatment. Quite often when I'm giving atropine in clinic, I'll say this is something that we will use for the next 2 years every night. So it's still, a very big commitment from the family. It can dilate the pupil in the higher concentrations. And when we look at the LAMP study, so the low concentration atropine for myopia progression, it's quite a mouthful. So I'm glad they summarized it to LAMP. What this showed us is that the 0.01% has the lowest rebound effect. So if we look at the dark out or the blackened out triangles, there is definitely still the white circles, the lower, let me see if I can get it here, the lower line, it doesn't have as great of a myopic progression reduction compared to the stronger concentrations. But once it's stopped at the dotted line, you can clearly see that it has much less of a rebound effect. Now, for those patients that are moderate risk, I would say starting at 0.1% is probably a really good starting point. Okay, and around 80% of the treatment group slowed the myopia to less than half a diopter per year. So this is definitely something that is being backed up at the minute. Some of our more modern options are the DIMS or the HALT, so defocus incorporated multiple segments. And these are the spectacle lenses that we have, or the highly aspheric lens targets. And I'll explain a little bit about what that means. The DIMS is essentially a spectacle lens that has plus 3.5 diopter bubbles on the surface. And what this means is you've got defocus in the periphery, and then a clear area in the section in the middle. We only want this peripheral defocus in the outskirts of the retina. Okay, so that's why obviously we want to make sure the patient can see as clearly as possible through that tunnel of clear. And these little sort of bubbles, or these little magnified segments, are pushed out to the periphery. It's slowed refractive by about 50%. So actually the numbers, and the axial length is slowed by about 60%. Just give you a quick example of what that is. The Halt technology is slightly different. Each of these bubbles is of a different dioptric power, a different dioptric prescription, which then creates that defocus bubble, or that defocus sphere that you can see on the left-hand side of the screen. We've got some review papers of the DIMS and Halt, and again, about 60%, it's slowing both the refraction and the myopic progression. Executive bifocal, we know that doesn't look great, but it is reasonably effective at giving this sort of inferior on the lens or superior on the retina defocus, which does help to reduce the axial growth. Some of the studies that we have here, this is one recently done in 2015, well, quite recent for bifocals. We've got a lot more modern since then, but you know, it's been shown for quite a while that bifocals are useful in this. Now that's probably because it relaxes the accommodation to some point, but also because of this defocus. Progressive lenses, very similar, where the patient's using a +2 add. Study used about 450 patients. This was done in China. And again, reasonable control with the progression, but we have got better options. So the soft lens, like the MiSight, has been used for quite a number of years now. We still haven't got it in the UAE, but hopefully it's coming soon. Soft lenses, you know, there is still a similar type of reduction in axial growth, around about that 30 to 40% mark. But something else that's been on the market for a long time is obviously Ortho-K. Now, I can feel the corneal or the external disease doctors probably getting a little bit riled up by this, but the lenses, if they're fitted correctly, don't sit on the apex of the cornea. This is something that is in the mid-periphery. And you can see here on the histological diagrams that the change in morphology is in the epithelium, okay, with very little impact on the anterior stroma. So this is very much fitting the epithelium. Again, we've got that sort of 30 to 60%, depending on the study, of the effectiveness of this. And Ortho-K lenses, they are very good when they're fitted well. They can be used in combination with atropine, a bit of teamwork. And some things are just better without glasses. Okay, swimming, sports. I had a girl that was into horse riding. She was a jockey in this week, and the Ortho-K lenses are perfect for her. The infection risk in Ortho-K from the studies is lower than that of a Staley silicone hydrogel wearer. Okay, as long as the lenses are well looked after, the infection risks in Ortho-K are quite low. We're just coming on to the last one here. I know that my time's almost up. I think we're at about 14 minutes. Lifestyle. This is something that you should be recommending to every single patient that has myopia, whether they opt for some of these myopia management options or not. Now, both the American Academy of Pediatrics and the Australian Department of Health has said children under 2 should have no screen time. Okay. This excessive screen time reduces language developments and increases childhood obesity. 2 to 5 years old, maximum of 1 hour screen time per day. So this is the preschool children. They're recommending a maximum of 1 hour. And the 15 to 17-year-olds limited to 2 hours of recreational screen time per day. Now, there's probably not many children out there that are being held to these. And as a department here at Moorfields, we routinely recommend 2 hours of recreational screen time, regardless of the age of the child. So anyone below 17 years old, we just say a maximum of 2 hours per day. And this causes the kids to go outside and play with their friends once they have this, this limit set on to the screen time. You can screenshot this if you want. It's the myopic effectivity. against the myopia correction. So we've got here atropine time outdoors, doesn't correct the myopia, but it does have a good effect. And then we've got Ortho-K, multifocal contact lenses, progressive glasses. And this is a really nice summary of what each of the options have. I'm just going to finish up here. I know I'm just a little bit over my time. These are the six options that we have. And with this then, this is how you're going to defeat myopia. And I hope I don't get sued by Marvel for this. Thanks everyone for listening. And if you have any questions, feel free to message me on any of the above. Thanks very much.
Thank you, Mr. Zach, for your wonderful session. Let us welcome our next speaker, Professor Premjit, currently working as an assistant professor, Manipal University, India. He is a fellow of ICAL and BCLA, practicing from last 14 years. He is going to share his experience on advanced RGP and ROSE-K fittings. Hand over to Professor Premjit.
If my voice is clear.
Yes, we can see your screen as well.
Thank you very much. Thank you, everyone. Thank you for joining. I thank organizer for giving me this opportunity. I've been listening to this great session with all the great audience. Well, I'll be talking on advanced RGP and ROSE-K fitting. And I'll just start with few fundamentals and then go with some of the advanced cases. And then I will try to sum up about ROSE-K fitting. I don't want it to offend anyone, but we may touch the basic for a bit, just to in case if few of the audience are not used to with this, but most of you, I'm sure, will be aware of things. One of the things that what I have noticed in my probably this career while practicing contact lenses is this optoms are very used to with all these kind of soft lenses, silicone hydrogel, be it disposables, be it anything. Optometrists are very comfortable, and they are also comfortable practicing high-end contact lenses, whether it is ROSE-K or even sclerals. But we felt that the fundamentals of contact lenses is RGP being less practiced. Probably one of the reason is it takes some chair time. But anyway, with this we will just try to sum up this whole topic. In this talk, I'm going to talk about RGP lenses, and for this presently I'll just try to focus a spherical, multi-curve corneal lenses. Now if you just see these designs of a multi-curve RGP lenses, what happened is from this to this, as we know, this is the total diameter, and this we call as a base curve, followed by we have secondary and tertiary curves. One of the interesting thing is that what we need to understand, the base curve, when you just you extend the base curve, and from the final curve what is there in the actual lenses, the difference is basically the edge lift. So from the cornea, this actually the fluorescent enters here, and we do see this. The thickness from this part is known as edge thickness. While fitting, we will address this. Normally in our practice, we see our contact lenses, we trying to order as the base curve, back vertex power, and total diameter, and often we see this. But then as we can see from this, a typical multi-curve, or here it is a tri-curve lens design, we see there are some peripheral curves which actually manufacture based on their algorithm, they tend to flatten, or while ordering you can change. It depends on lab to lab. This is another way of looking into the edge and looking into the design, and I'm not going to talk much over here. This is a small video of TL lens, and I'm going to just play this video for a while, and then I will come back to the talk.
Hello?
Yes.
Yeah. Okay. You can. Okay, you're playing the video. Okay.
Is it audible?
Can you play it? No.
Is audio is not audible?
No.
All right. I think I have to just. All right. This is the tear which is trapped between the front surface of the cornea and the back surface of the lens. These tears actually correct this corneal astigmatism. Now, why RGP? As you see this, as I started with the talk, the RGP contact lenses, we can fit it into any probably potential refractive error, but often we try to correct because of the tear lens, we try to use them for irregular astigmatism, be it post-PK or even PMD or keratoconus, keratoglobus, any other cases we do, and we get a very good tear exchange and a high decay RGP material. So before we start RGP contact lenses, we tend to, what is recommended that you please start with an effective communication with the patient. You discuss the condition and you present all the possible options to the patient. You do listen to the patient, you explain them the condition, and also you take a chance and you express your, desire to correct and probably what you feel for the best, and let the patient decide what is best for the patient. Not going to touch much here. Pre-fitting, you do all these regular routine optometry examinations and you try to decide the best contact lenses for your patient. This is the case where you see the right eye is the -5.5 is a pure spherical, where the left eye there is a cylinder. And if you try to, this is PGP, when you have given the final prescription, the right eye got the -6 and the left eye there is a cylinder. When you try to correlate with the keratometry value, the right eye being spherical and the left eye, there is a 3 diopter of corneal astigmatism. So you can make out this 3 diopter of corneal astigmatism, what is present here, this 3 diopter of corneal astigmatism, what is present here, it is due to the corneal astigmatism, whereas the right eye is a pure spherical. How do you choose the space cover for contact lenses? Traditionally, you start with the flat K and then you move towards the average K. So here, if you see this example where this is the flat K and this is the steep K, and the average is considered to start with the contact lens, whereas total diameter, HVID minus 2.5, that is considered to be the highest TD can be tried for the patient. But there is a rule of thumb when you try to do this in a clinic and you see the cylinder is quite high, in order to save your chair time, as per the ICL and the recommendations, what you do is you take this flat K, you take this steep K, and then after 1.5 diopter of cylinder, so that means after 1.5 we have remaining 1.5. Per each 0.5 diopter, you steepen by 0.05 from the base curve. So here 3 steps of 0.05. So from the flat curvature 7.5, you steepen by this and you get this 7.35. So it is interesting to see that the flat K being 7.5, if you go by the traditional rule, and if you use the thumb rule, it helps you to take the 7.35 or even average this. The idea is start with the flatter curvature and go by steepen the base curve in order to get the best fit. That is a rule of thumb which usually we apply to do the trial for any toric corneas or keratoconus cases, or even for any of these irregular astigmatism. Before you practice, you must know your trial lenses in the clinic, what is present, and based on that helps you to even try meticulously, helps you to do this trial of contact lens properly. Lens insertions, as you do the lens insertion. Now here is one thing is whether we need to use anesthetic drop or not. Usually I don't prefer to use anesthetic drop until otherwise patient is very sensitive, or if we are doing a trial for an anesthetic, very pediatric patient. The reason is that if you use anesthetic drop, then you don't actually patient don't understand the actual feeling of the contact lenses. Often when you dispense, patient try to deny to take these lenses because they don't get the same comfort as they received during the trial because of anesthetic drop. So usually it is not recommended, but in case if it is a pediatric patient, we may consider putting anesthetic drop. So you need this fluorescent, and you need to apply the fluorescent. When we give a settlement time, which is around 20 minutes to for the patients to lens get settled, and then we do the fit assessment. Fit assessment, we do the dynamic and static, and there's other things that we assess: centration, coverage, stability, movement, and lens lag, and we do see them. And these are the things that we see. I will just play the video without the sound. So you can see here that lens is movement, and the movement is around 2.5 millimeter. Whereas if you see this lens fit, so this lens are riding low, and it's also not covering the pupil properly. Whereas static fit, when you do, it is very important to understand the static fit. You basically check the lens cornea relationship. We tend to check the lens cornea relationship. The best we can be viewed by the rattan amber or yellow filter, and we use fluorescent and cobalt blue. So the static fit, where there is no lead influence, you separate both the lead and you see the pure lens cornea relationship, and you basically check these three things: whether it's a touch or bearing, whether it is alignment or adequate clearance, or it is a pulling. The area that you see is the center, mid periphery, and the periphery. This is a typical example where you see this: there is a central bearing, there is a central pulling, and there is a central clearance. This is a typical flat fit where you see this lens is sitting on the center, and there is probably a clear touch area. As the lens is touching centrally, this you see this at the periphery, there is a huge edge with an edge clearance. This is a typical example of a stiff fit lenses where you see the center part is purely, there is a pulling in the center part, and then the edge is very thin. The same thing is visible over here. The center fluorescent is quite thick, whereas the edge is quite thin. This is kind of an ideal feed where you see this. You can see this fluorescent is distributed. The fluorescent is distributed quite well, and you see the edge is very proper, and you also see there is a good central clearance, and the mid peripheral area is also as per the requirement. Well, when you check this lens age, that you see this edge width, and you also see the clearance, that design part that I was discussing. This lens width is it also reflects based on the design, but then again how the lens is. If the lens is touching center very heavily, then the width would be very high. If the clearance is the difference from this, what you see, that you see the clearance. So what we try to avoid the narrow edge width, and we get a good edge width and a good amount of clearance. Whereas you see this edge width is quite thick and the clearance is also quite high. So we want a lens to with adequate width with adequate clearance. Once you are done with this RGP, you do the over diffraction and you use with the trial lenses, you order the final lenses. That helps you to finalize a RGP lens. Now, if you fit this RGP lens for a keratoconus, the keratoconus, we have this fitting philosophies there. There is apical clearance, and then you have this apical bearing, and you have this 3-point touch. Now, there are these fitting philosophies, have their own merit and demerit in their own places. But then most popularly, we use this 3-point touch or divided support, where we divide the lens weight, we distribute in the 3 different zones. So base, apex, and base. This is how we provide this support to the lens, where what happens is, though there is a touch, but the touch what we expect in the center is the feathery touch, followed by the touch in the both the base side. So we'll see the pictures and we'll try to understand. This is the typical in apical clearance, where they see this central, so much of fluorescence is present. Here, there's an apical bearing. The bearing is quite high. Now here, if we fit this kind of thing, then the chances of there that this cornea can get eroded with the lens surface. This is not a very actual 3-point touch, but if you see this, the touch is here at this first base, and then center base, and the other base. So this is 1, 2, and 3. This is the 3-point touch that we want to the RGP lens to be there. Another interesting case to see the RGP is with the rule astigmatism case, where you if you wanted to correct the corneal astigmatism with RGP, what happened? The lens rock with the steep meridian, and chances of there is lens moves much. Now here, what happened? The lens sits across the flat meridian, and the steeper area shows that there's a vertical dumbbell pulling, and you can observe that, and that you can make out that 90-degree meridian being very steep. The chances is there that lens will move vertically with the blink, and so while prescribing, what is ideal is the upper edge of the lens should not cross the pupil margin. At least there would be 1 millimeter of cover area, and the lens should not even cross the limbal more than 1 millimeter. I think I think I crossed the time. Shall I continue, or I just end this topic here?
You have another 2 minutes. Kindly finish it off as soon as.
Yes, thank you. Now coming to these Rose scale lenses, it is basically invented by Paul Rose from New Zealand, who brought this specially designed RGP lenses to correct for irregular corneas. The main initially the Rose K, it was, so if you see these spherical lenses, what happened? It touches the cone, and then there is a deep pool. In order to minimize that, we had this kind of an specially designed lenses which covers the cone and helps to correct the irregular corneas. There are some challenges with the Rose scale lenses, so that Rose K2 came into market with the aspheric back surface. This aspheric back surface helps to improve the optics so that we can correct the patient properly. These are the different types of Rose scale lenses. For this talk, I would be referring to a regular Rose K2 lenses, and you can see, and probably from this or the company available brochures, you can see all the details, the indications, and the power, their available parameters. Once you fit a Rose scale lenses, once you get the central fit, then you can do these 3 modifications. The fit assessment remains same as RGP. You do these 3 modifications, which are the toric peripheries, asymmetric corneal quadrant specific changes, and toric back and front bitoric lenses. So you'll see them: flexible edge lift. In case if your lens, you are satisfied with the central and mid peripheral fit, but the edge is too steep and you wanted to improve the edge, you can flatten the edge from here, the 0 till +3, or if the edge is too flat, you can steepen the edge from 0 to -1.3. The trial lenses comes with the standard lift of the lenses. This is for the Rose K2. Similarly, lenses for the ICs and the nipple cone also comes in the similar fashion. Now, this flexible edge lift, you can see this lens is fitting quite well, where you get the central touch, you have this 1 touch, 2nd touch, and 3 touch, and the edge is quite good. But here you can see this edge is quite thick. In this case, stiffening in the edge would help this lens, and you can achieve this kind of fit. Where you see this picture, this is taken from their brochure, and this is quite thin, where you need to increase the edge lift or flatten the edge lift. Now coming to this asymmetric corneal technology, basically when you are satisfied with the 3 and 9 o'clock and 12 o'clock positions, but at the inferiorly 6 o'clock positions, when you are not satisfied, what you can actually flatten that area in order to get that, or you can stiffen this area. Look at this, these are the grade. So this is being the lowest grade. This is 0.7 mm, where 3 to where this 5 to 7 o'clock positions you can actually play. Around the 6 o'clock positions you can play, and you can improve the fitting. This is the when this bottom in edge lift is quite high, you may need to go to ACT grade 2, where if it is significantly high, probably in this case you may need to try a next lens. But in this lens, if you wanted to change, then you have to change this ACT grade 3. But by looking at this picture, probably when you do this trial, you may need to try a different lens and to see the fitting again. They do have a toric periphery, where what happened in this case, this 3 to 9 o'clock area you can flatten, and 6 to 12 o'clock area you can steepen in order to improve this fit. Look at this fit, where you see this area is not that you expect to fit. Whereas if you apply the ACT, you can improve this fit so that you get a good edge and central fit. We will just see a few examples. Just this is the last slide. You see this, typically you want a rose scale lens to fit like this. There is a very nice edge with an excellent edge with an edge clearance and central touch. This is a 3-point touch as well as a very good edge. But what happened, actual patient, if you try to get this kind of fit, where you see this, a typical rose scale lens with the 8.7 mm of total dia was tried. But then what happened is that, if you change this parameter to, or in this case, probably once the parameter was changed to a nipple cone, which is basically a smaller diameter rose scale lenses, to 8.3, and since they have reduced the size, what happened? They have stiffened the edge, because edge was already +1, that was lifted. Now from +1, you went to 0. Basically, you have stiffened the edge because you are reducing the total diameter. Chances of this edge would be very thick. And see the result in your screen. It is a quite comprehensive fit, which you can go ahead with this. With this, I end my talk. Thank you very much.
Thank you, Professor Premjit, for your wonderful session. Let us welcome our next speaker, Ms. Irene Sophia, currently working as senior optometrist in Mediclinic City Hospital, Dubai, practicing ortho-K and scleral lenses for more than a decade. She is also fellow of IOMAC, member of the BCLA, ICAL, SLS, ISEV. She is going to share her experience on basics of the scleral lenses. Hand over to Miss Irene.
Yes, hi, good evening, everybody. Let me just share my screen here. First of all, let me thank the Optometrist Forum here for letting me be part of this lovely program. And also, I'd like to thank this 300 plus participants whom I would like to think are still logged in and listening after 4.5 hours of this extensive session. Let me just check here 1 second. Okay. All right, so can you see my screen now?
Yes, we can see your screen.
And my presentation. All right?
Yes.
Just going to minimize this. Okay. All right, so let's start off with the basics of scleral lenses. So the objectives of this talk is going to be the history, the terminology, a little bit of the design and indications and contraindications, and a little bit of the fitting procedure. Okay, I think I'll be a little short of time, so I'll just rush through this. We all know how the concept of contact lenses started after Leonardo da Vinci proposed this theory of using the glass tube with the water to look through that. And then he realized that the vision was clearer. So from then, after like 400 to 500 years later, a lot of theories changed, and then we came up with this lenses which kind of looked similar to the modern day scleral lens, but only that it was made with heavy blown glass, and it used to be very heavy, definitely, and it suffocated the cornea under the glass. And but that was the kind of scleral lens which was first made. And thanks to the World War II, then people found out that PMMA was very compatible with the human body. And then we started using PMMA for contact lenses. And then came the GPs. I'm not sure how many of you are aware, but a corneal lens was kind of an accident when this optician, Kevin Tuohy, when he was kind of cutting out a scleral lens, he accidentally made a smaller lens, and he realized that that worked too. And that's how corneal GPs were working for a long time, until the 1980s, when after a lot of improvement in technology, in the lens materials and manufacturing techniques, the sclerals came back into the market. So that was a quick history there. And when the people started using scleral lenses again, there were a lot of different types, and many researchers and practitioners use different names for these scleral lenses, from semi-sclerals to mini-sclerals. So that was kind of a little confusing. So the Scleral Lens Education Society published an official guide for scleral lens terminology, and they defined the scleral lens as a lens that fitted to hold over the entire cornea, including the limbus, and to land on the conjunctiva overlying the sclera. And that they termed as scleral lens, and whatever be the size, they wanted to name it as a scleral lens with the acronym SL. So let's look at a design of the lens a little bit. Basically, it has three main zones, the optic zone being the central part with the refractive correction. And then comes the transition zone, which kind of connects the optic zone with the landing zone. And this transition is over the cornea and the limbus and just over towards the sclera. And the last part of the scleral lens will be the landing zone, which can be either spherical or toric, and it's kind of we can customize it depending on the fit. And that's the last or the lens edge of the scleral lens. So basic design of a scleral lens is this. It has three major parts. So once we put a scleral lens on the eye, we see that to assess the lens fit, which we will look at later, we're going to fill a scleral lens with a saline and then fit it on the eye, right? And then the space between the lens and the cornea is known as the fluid reservoir. So that's where the saline is. So like how we saw in the previous presentation, the tear film, that's the part which neutralizes optically the corneal irregularities and improves the vision. So the amount of the clearance is a little different from the GP lens and the scleral lens, depending because of the change in diameter. And this clearance is going to vary depending on the diameter again of the lens. So the fluid reservoir usually is indicated in terms of the depth and the location. So it can be like say 300 microns. Generally for an optimum fit, it should be anywhere between 100 to 300 depending on the diameter of the scleral lens used. So we're going to mention it as 300 microns, for example, in the central zone, and 50 microns in depth at the limbal zone. So it's specified with the location also. So why scleral lenses? Basically, it is to improve the comfort, the stability, and the centration of a GP lens. So if the corneal irregularity is high, then if a corneal lens is not fitting, if a corneal GP lens is not fitting well, like how you see in this image, then that's when we need a larger lens, and that's where the scleral lens helps, right? Because cornea being a sensitive tissue, a sensitive layer, and because of the nerve endings, and when the pathology is present, then it's going to be even more sensitive. Hence, the patient will not be comfortable, and hence we need a different option. So that's how scleral lens helps. With the scleral lens, the movement of the lens is minimal, and there's less interaction with the lid, and hence less awareness of the lens on the eye, and that's how it becomes more comfortable. So let's look at the indications and contraindications a little bit. So mainly, research has shown that the scleral lens wear is more for, like 74% it's used for corneal irregularities, and 16% when there are ocular surface diseases, and about 10% also for, like even if it's an uncomplicated refractive error, even for regular refractive errors, scleral lenses are being used. The main purpose being for vision correction, comfort, and to protect the ocular surface. So in terms of vision correction, we're going to use it more in cases of primary ectasia, say for keratoconus, keratoglobus, for PMDs, and also post-surgical secondary ectasias, or even if it's just a very high irregular corneal astigmatism. And also for regular refractive errors when there's high myopia or aphakia. And we also recommend scleral lenses for sport activities like water sports. Then the recommended lens is a scleral lens. And the next purpose being for ocular surface protection, especially when there's a condition of exposure keratopathy or persistent epithelial defects, there's trichiasis or entropion. And even if there's a little bit of moderate dryness, then scleral lenses help a lot in protecting the ocular surface. And in severe conditions like autoimmune conditions such as Sjogren's or ocular cicatricial pemphigoid, or even if there's allergic Stevens-Johnson syndrome, then to protect the surface of the ocular surface, then scleral lenses helps a lot. So contraindications, we have to be a little careful when we fit scleral lenses. We have to, we look at what we're going to test, but generally when there are corneal endothelial abnormalities, then we'll need to avoid fitting scleral lenses if there's glaucoma, and definitely these are not for overnight wear. And even if a patient is having some intolerance to lens wear, then we'll need to avoid that because it's going to take a little more effort than a regular lens. And if there's poor compliance to hygiene or even the wearing schedule, then we're not going to give them scleral lenses. And this is an image of a bleb, which is not a contraindication, but just to indicate glaucoma. And to look a little bit into the fitting, and fitting starts with any regular, like any regular contact lens. We've got to look at the history, the ocular and the medical history of the patient, and if they've used any other contact lenses before. And we'll have to do a comprehensive eye exam before starting the lens fit, so that we know that if there's any other condition which will affect the vision improvement, and what kind of surface irregularities are present, like pterygium or pendicular, or even blebs. And then we need to do some baseline corneal measurements like specular microscopy for scleral lens. I would definitely recommend that before we fit the lens, and our topography and tomographies. So along with these, if we're fortunate, then we can even do the shape of the anterior ocular surface topography, like scleral topography. Okay, example like the eye surface profiler by the eaglet or SMAP 3D. So what are these instruments? These kind of give us a topography of the sclera too, a little more than the cornea. Okay, because to fit a scleral lens, we know that the actual part of the eye where the lens lands is on the conjunctiva overlying the sclera, right? So we need to know the structure of that part. So hence an eye surface profiler will be a very good additive in terms of instrumentation to check the surface of the sclera. So this is how it's going to, just an image. You can see that this is the whole cornea, And we're going to get more information about the surface, even further from the cornea. I think it's around a 20 millimeter overall. And this is an image from the SMAP 3D. So it's going to measure 3 parts and then put it all together and give us more information, just not about the corneal topography, but also the scleral topography. So why this is going to be important is because we know that the corneoscleral junction is not really spherical, right? It can be a tangent and it can be different shapes. So we need to know that to get a good fit, basically. So if we look at fitting, I would prefer a trial set fit because that kind of gives you an immediate picture of how the lens looks and for you to decide if you want to make changes. So we generally use a trial set to fit a scleral lens, and depending on the parameters that we get from our tomography and the scleral profiler, if we have, then we choose the first lens and it's inserted in the eye, and then we check the fit similar to any GP lens. So before inserting, the only difference will be we need to fill it up with saline, and then we insert it. Since it's going to be filled with saline, we can't just stand and insert it. We have to bend down and get parallel to the corneal, the lens, the cup, and then fit it in the eye. And after insertion, if in case there's a bubble, then we need to remove the lens and apply it again. So that image that you see down is insertion bubble. So step 1 is the diameter to decide on which lens to choose. So we have to look at while we choose the diameter of a scleral lens, it's going to be depending on the HPID, the limbus width, and the corneal sagittal height. So all these 3 parameters need to be taken into account, and then we decide the diameter, the total diameter of a scleral lens. And step 2 will be the clearance. We need to check how much of clearance is there in the center, just in the center below the lens, and even in the limbus. And we'll need to look all 360 degrees around. So we'll need to see that there's adequate fluorescein or tear layer between the lens and the cornea. So here in this image, if you see, the green layer is where the saline is between the lens and the cornea, and the green is of course because of the fluorescein. And we generally use fluorescein with white light to assess the fit of a scleral lens. And with practice, probably you even don't need the fluorescein. You can assess it just with the white light. And this fluorescein layer is going to be measured in comparison with another layer, mostly the thickness of the lens, because that's a fixed value, because the corneal thickness might change. So we cannot compare it with the corneal thickness. And we compare it generally with the known thickness of the lens, and we need to get the optimum of clearance there for a good fit. So optimum clearance can be, like I said before, anywhere from 100 microns to 300 microns, depending on which lens you're using and what's the diameter of the lens. And the limbal clearance, again, should be checked separately, because it's very essential that the lens doesn't touch the limbal area. So there should be a minimum of 50 microns at least over the limbus. And the third step in assessing the fit is the landing zone, which is very important because that's where the lens lands on the ocular surface. All over the cornea and the limbus, it's going to vault over, and then it's going to land on the sclera at the landing zone. So the fit of a landing zone is very important, because if it's going to be tight or if it's going to be loose, is going to decide if there's going to be any impingement on the blood vessels causing blanching. So down here in this image, you can see that there is a very tight fit here under this white area. So that means the blood vessels are compressed, and there's no flow of blood vessels there in the conjunctiva. So that's not a good fit. So that's why assessment of the landing zone is very important, so that we get a better fit, which can otherwise cause trouble in the eye. So the step 4 is the lens edge. We have to assess how the lens edge fits. Similar to a corneal GP lens, there should be a little bit of lens edge. There should be a lift, but it should be optimum. Again, like this is an OCT image. We can assess the scleral lens fit even with an OCT. If not, or if we don't have an OCT, we can do it on the slit lamp. So this is just an example to show that, generally with the OCT, there's a 50-50 rule that the edge of the lens should impinge, or the edge should be like 50% outside and 50% just touching the conjunctiva. So that is a good fit. And how you assess this is with the push-in method. So push-in is like you slightly nudge the lower lid, okay, over the or into the sclera. You should not touch the conjunctiva directly with your finger. You just nudge the lower lid slightly, and then you see how much pressure is needed to cause a slight standoff of the lens edge. Okay, so if you're going to gently push, then it's a well-fitting lens. The edge is well fitted, and if you have to push hard to get that standoff, that means it's a tight fit. And if you like very little pressure is needed, then it's a loose fit. So that's how you assess the lens edge fitting. So this is another image by these authors. So they have just given a comparison as to how a lens edge can be a loose fit, like with the first image, or if there's a good alignment at the lens edge. You can see the second image where there's, it's all even. Here they've shown you one quadrant, but of course we've got to check all around 360 degrees. And there's no any pressing on the blood vessels. There's no blanching like how we see here in the second last image. There's quite a bit of impingement there and like total blanching here in the last image. So this is a bad fit. So we need to loosen that fit a bit. And the second image is how a good fit will look for the edge. And the next step is we'll have to assess if we need a asymmetric back surface design. So basically, if the sclera is too toric, if it's not like a similar curvature all around, then the lens is not going to fit or align well. So we need to decide if we have to go for a toric periphery lens. So that is what is an asymmetric back surface design assessment is. And how we apply and remove these lenses, it's definitely different from the GP lens, because here we'll either use a plunger, because we're going to hold the lens and fill it with saline and then apply it on the eye. So either the plunger or you can use your 3 fingers to use it like a tripod and insert the lens. So, and the removal is also with a smaller plunger. For applying the lens on the eye, it's better to, with practice, probably the patient usually gets adapted to the finger method. Initially, you might have to give a plunger, but it's better to avoid these many gadgets or as many as possible so that there's less risk of infection. But till the patient can learn, we can still give a holder to apply the lens. And for removal, like I said, there's a smaller plunger with a smaller diameter where we use to create a suction on the lens, just slightly press it on the lens, not in the center, but slightly below, and then pull it out so that the lens just comes out like how it's shown in the image there. So, and this is something that we have to teach the patient also. Definitely a scleral lens, there's a little more effort in insertion or applying or removing the lens, but that comes with practice. So we need to most of the time patients get a little worried about this longer process, but generally they learn it and then with practice they are okay. So to conclude, the scleral lenses are a very effective method for visual rehabilitation in irregular corneas, and also a therapeutic treatment of ocular surface diseases. They work very well, and they also work for correction of refractive errors in healthy eyes, particularly when other modalities fail. And also, in my opinion, it's also a very excellent skill set for optometrists, so that we can improve the quality of life for people who have, compromised vision because of that. These are my references, and thank you very much.
Thank you, Ms. Irene, for your wonderful session. The forum is open for the panel discussion. Stay tuned for the few seconds while you find the questions on the screen. Kindly select the answers. Meantime, we will shift to the other room for the discussion. Which of this type of therapeutic contact lenses can be used to severe dry eye? Kindly select the right answer below. The main reason to fit the toric back surface RGP in case of astigmatism cornea is, kindly select the answers below. For a patient with -3 with -150 at 180 axis, which is ideal? Kindly answer the questions below. A patient complaining of flare at night, driving with the RGP, -5 diopter power. By examination, noted 2.5 mm of the superior temporal decentration. What will be your choice? First choice. Kindly answer the questions below. Mr. Zach, there is one interesting question from the audience regarding the myopia control. As a beginner, can I jump directly to the ortho-K lenses, or to start with the soft multifocal contact lenses or the progressive lenses first?
That'll depend a lot on your experience. So with the spectacle lenses, Essilor has some really great teaching tools if we're going to start with the spectacles. And that's something that every practice should have access to. There are a few other brands out there. For example, Hoya have their My Smart lenses. But yeah, if you chat to some of the manufacturers that you regularly use, they'll be able to do teaching on that for you. Atropine is something that will not be available in the high street, but it will be available to the hospital practitioners. And with the Ortho-K, we primarily use number 7 for our Ortho-Ks, and they have an Ortho-K basically training session specifically designed with the use of whichever topographer you have in practice. So reach out to the manufacturers for specific training on each of the myopic preventative strategies, and they'll definitely be able to help. There was another one, Shareth, sorry, just in the questions as well, about the age. Don't know if you saw that. It was from Sumaya Thomas. First of all, you've said here, at what age of child can we start the myopia control? First of all, very naughty of you to say myopia control. We're going to try and stick to myopia management going forward. And age of the child, there is no set cutoff. So when I'm talking about contact lenses, it's when the patient's sensible enough to use contact lenses. There's some 17-year-old boys I wouldn't let anywhere near contact lenses. There's some 10-year-old girls that are more than capable of handling Ortho-K lenses. Atropine drops, you can start that very young, 3-4 years old, and the drops don't sting. And it depends on the discussions you have with the parents and what you feel is in the best interest of the child. So there's no age cutoff.
Thank you, Zach, for your answer. We have another interesting question for Professor Premjit from the audience regarding the Rose-K fitting. How many diopters of astigmatism can be neutralized with the Rose-K or the RGP lenses? Also, when we should order toric lenses?
Well, the question is really important. Thing is that when we correct astigmatism with Rose-K or any GP lens, if it is a spherical power, then what happens is the TR lens corrects the astigmatism. And as we know, it's 90% of the astigmatism which TR lens can correct. So even if a PMD or a very high toricity, let's say 9 diopter of astigmatism or 10 diopter of astigmatism is there, then ideally by 9 diopter you should be able to correct. The remaining 1 diopter that you have to manage with spherical equivalent, that is how it is. So that totally depends upon what is the irregularities there and how well you get the fit. But more or less, yes, you can manage 90% of corneal astigmatism with the toric lenses. Now, second part of the question is the when we fit the toric lenses. That is what the question is?
Yes, yes.
Okay. Now, for the Rose-K, the toric lenses are basically to improve the fitting. As you see, this is the one of the modification when you fit a Rose-K lenses, and you don't, because of the nature of the cornea, if the vertical meridian is behaving differently than the horizontal meridian. So by playing both the meridian, you can actually achieve a good fit. It is not to correct the corneoelastic method, it's to improve the fitting.
Thank you, Professor Premji. We have one more question for Ms. Irene regarding the scleral lenses fitting. Can we fit a advanced KC with high drops with the scleral lenses? Give me some tips to keep in mind while approaching such cases.
Okay, yeah, you can fit advanced keratoconus with scleral lens, but I didn't understand why high drops came in. Is it like post high drops? Because yeah, if high drops needs like immediate treatment, and once it's settled, then yes, we can fit scleral lenses. And depending on if there's a scar or no, then your visual improvement is going to depend on that. So it needs treatment first, and then you can do scleral lenses. Yes.
Okay. Thank you all for your wonderful panel discussion. Now we would like to welcome one of our sponsor, Ion Care Medical Equipment, to give the presentation. On behalf of them, Ms. Kavya Tareja going to present. Over to Ms. Kavya.
Hello, good evening, everyone. Hope all are doing good. I would like to share the presentation.
Can you open your camera, please?
Yeah, surely. One second. Hello.
Yes.
Am I audible? Yeah.
Yes.
Yeah. One second. I would like to share the screen with you all. Good evening, everyone. Hope all are doing good. One second. Yeah. This is a presentation of my company. We are UNCare Vision and Equipment Solutions. We started our company in UAE market in 2017. We are a company of, we are the trading company of ophthalmic surgical equipment and contact lenses and implantable phakic contact lenses, vision therapy instruments, low vision devices, and medical equipment based in Dubai, UAE market. Our vision is to, we are very focused on quality care, improving the top line and bottom line performance of eye care centers and hospitals, and improving operations to boost customer satisfaction and overall health. We will continue to grow our niche as a premium eye care solutions. Our best, our main motto is customers satisfaction and trust on our company. Our specialty lenses are corneal RGP, hybrid contact lenses, orthokeratology lenses, easy soft lenses. We do provide vision therapy instrument, including home kit and software. And we do prosthetic eye. We provide low vision devices, surgical instruments, and consumables. Our products are registered with UAE Ministry of Health and Prevention. So ours is very trustworthy company. And for any inquiry or any related to any discussion, if you want to do further, you can drop in the mail to info@uncare.com, or you can contact on the following number, which is mentioned on our presentation. So thank you so much for your time. And have a great evening. Thank you.
Thank you, Ms. Kavya Tareja. Now I'm going to over to the host. Thank you.
Thank you so much. Thank you.
Thank you, Sharat, and all the panelists. Now we'll be going to our last session, but before we set up the panel for the last session, so we'll be having poll questions now. So kindly see the questions and answer. Yeah, I hope everybody can see the questions. The father of modern optometry. So there are options. So you can select what is the right option according to you. Then second, World Optometry Day celebrating on which date? Then the third question, first glass contact lens fitted by Fick and Edward on which year? So you can give your poll. When optometry was first introduced in India? By Gandhi Eye Hospital, Aligarh. So if you know the right answer, click on the answer. Okay, thank you. By this, we end our poll and we go forward to our sessions.
Now we have come to the last session of the day. An interesting session too. Yes, it's about optometry journey. I'll call upon Optom Neeraj Dabra. He is professional with 27 years of multi-industry, multi-location, multi-function experience in business development, training, operation, product marketing. Managed multiple optical businesses with functional expertise in developing new markets, product launch, and customer skill development. Currently heading Astra DM Optical Division. Over to you, sir.
Thank you, Swarna. I would now, being the moderator of this session, want to introduce the other panelists in the group here. I would first like to introduce Ms. Daisy Valbuena Teduran. She is having 19 years of experience in the field of optometry. Currently is based out of Abu Dhabi. She did her optometry from Philippines and has practiced in UAE as well as in Bahrain. She has the elected president of Integrated Philippine Association of Optometry, UAE chapter. This organization primarily looks at Filipino optometrists and helps them in attaining knowledge through conferences, seminars, and workshops. She's also a member of Bahrainian Council of Abu Dhabi, as well as member of Philippine Professional Organization, UAE. So welcome, Ms. Daisy. Other panelist is Mick Hillary. He has clinical optometry background with Doctor of Optometry from University of Benin, Nigeria, and has more than 10 years of practice experience. He moved to Abu Dhabi in 2015 and evolved into including behavioral optometry and public health research along with clinical optometry. Enrolled into Master of Public Health from University of Roehampton, London. In 2021, he completed a professional development certificate program at University of Washington. And that's not all. He has been improving on his educational journey. And in 2022, recently, he completed a course from UK College of Optometry, which was a professional certification in low vision from Cardiff University. And currently, he's preparing for his interdisciplinary PhD research in the area of intersection of global eye health and global mental health. So welcome, Mr. McCleary. And over to another gentleman here, Mr. Othman Boshnak. He is an optometrist who graduated from Jordan in 2000, has more than 15 years of experience in the retail segment, more than 7 years of experience in professional services at Essilor Middle East. And currently he is part of the Essilor team handling international as well as Middle East markets, including African countries for Essilor instruments. So welcome to the panelists. I would start with the question since the subject is the optometry journey. So please, the panelists are requested to take us through their professional journey from their country where they started their optometry journey and how it was when they ended up being in United Arab Emirates, which is UAE. So please, if you could have the lady on the panel first, that's Ms. Daisy, to give us and take us through her experience.
Good evening, everyone. Thank you for having me. Well, first, let me just introduce to you the Philippine optometries. What's Philippine optometry is all about. The optometry course was increased from 4 to 6 years. The first batch of optometrists who graduated from the 6-year curriculum in 2004 were authorized by law to use diagnostic pharmaceutical agents, or the DPAs, in their practice. A special pharmacology course was likewise offered in different optometry institutions to give practitioners who graduated from the 4-year course the privilege to use DPAs. To be a registered optometrist in the Philippines, one must pass the licensure examination and be registered in Professional Regulation Commission. Prior to that criteria for application of licensure examination, he must be a Filipino citizen of good moral character. He should obtain the degree Doctor of Optometry granted by schools accredited or recognized by the Philippine government, particularly the Commission on Higher Education. The program of Doctor of Optometry is 6 years. First 2 years with general education subjects are being taught, must be passed, and be progressed to a 3rd, 4th, and 5th year, while major optometry subjects and clinical subjects are being taught. The final will be the internship. The sub-technical panel for optometry education was likewise organized by the Commission on Higher Education to oversee the development of the optometry curriculum and tasked to evaluate and maintain the standards of optometry education in the Philippines. Once completed or passed, then they will graduate as Doctor of Optometry. But of course, to take the board examination after the review. So there.
Sure. Over to Mr. McCleary.
Hi, hello everyone. Good evening. Oh, can you hear me?
Yes, you're audible, Mr. McCleary.
All right then. So I'm joining in from Benin City, Edo State, Nigeria. Right. So it's 6:20 p.m. here. So we are 3 hours behind the United Arab Emirates. Yeah. So before I touched on my own personal journey in optometry from Nigeria to the UAE, and of course back to Nigeria, I'd like to quickly take us through the optometry profile or progression in Nigeria. Over the years, just like it is in the Philippines, Nigeria optometry training has moved from a bachelor's degree, 4 years program, to a Doctor of Optometry, 6 years clinical training with a compulsory graduate internship in an approved hospitals. So currently we have about 7 fully accredited universities in Nigeria offering the program of Doctor of Optometry, and about 5 more are under the approval process or accreditation process. And so you can get into the optometry program through 2 routes. You can go in from the direct entry route, which gives the student access to start from the 2nd year, because the individual have done a first degree in a biological science related course. And then the other stream is to start from the 1st year, writing the post-university matriculation exam to begin at 1st year. And so the program is structured. The first 3 years is the preclinical year. And the 3rd year, the student is supposed to take an exam that would qualify them to progress to the clinical phase, beginning from the 4th year. So from the 4th year up to the 6th year, the students would have done quite a number of courses in let's say in psychology, in computer science, in pharmacology, in biochemistry, and of course in ocular courses like in ocular pathology and the likes. Then from the 50 and 60 years strictly clinicals, where the student goes for clinic rotations, and then they have hands-on opportunity to see patients under strict supervision. Then upon graduation, there is the induction ceremony, which is conducted by the regulatory body of Nigeria. It's called the Optometrist and Dispensing Optician Registration Board. So they regulate both the optometry and the optician profession. So the board, they also are the one that are responsible for accreditation of the institution. So then the student, after the internship, takes a final exam, and case presentation is submitted to the board council for final assessment before full registration is granted to the individual for the license, for the annual licensure to continue. So, and after the internship year, the individual could work either in the hospital based as an hospital-based optometrist, or in the private sector. Either you can also work in industries like in HMOs or the insurance companies. You could work with multinational NGOs, and the list just goes on and on, because the training was really grounded. So an optometrist can find himself in different industry. But again, given the resource limited region we are from, we always find ourselves seeking greener pastures. And so that was also my case after about 3 years of practice experience in Nigeria. I was looking to migrate to Canada, but that was taking a bit of time. And so I looked at the UAE, and at the time I found a Nigerian who was working in Yatim Optician in the administrative department as the head of professional affairs. So he at the time would come to Nigeria to recruit optometrists into the UAE. And so one of the times I applied and took the assessment, and I passed. And so that's how I came into the UAE. So maybe I should stop there for now. I can progress later.
Sure. Thank you, Mr. McCleary. Over to Mr. Othman.
Thank you, Niraj, and good evening to all my friends and colleagues. I'm really very happy to attend this webinar. It was really very informative, especially for me, because I not in a practice, let's say, for more than 7-8 years. And it's refreshed a lot. Just a few weeks ago, I was with a group of optometry in the cafe, and one of my colleagues asked me if the time back 20-25 years ago, do you study optometry? And my answer, or what you, if not what you're going to study, my answer, I will study one thing only, optometry. Even anyone who advised me, my daughter is going to graduate from high school, what do you think? I say immediately, optometry. The reason behind that, it's our field, it's unlimited. It's expanding. Every day we have a lot of things new. Just a few years ago, no one from us hearing about myopia management. Today, most of the optometry talking about it, and it's going to be our futures of the future of the optometry, especially World Health Organizations announced that 50% of the population will become myopic soon, which is 2050. So yes, optometry. I'm as Mr. Niraj introduced me. I'm graduated from Jordan from 2000. And that time Jordan only the country in the Middle East graduated optometry. And then many countries in the region start also developing the optometry, university, college, and even the regulations. After that, today, or for example, today we have 4 college and university for optometry in Jordan, 3 in Lebanon, 1 in Oman, and 2 in KSA. The majority of them graduated Bachelor of Optometry, except KSA, where the only country in the Middle East graduating Doctor of Optometry. During 20 years experience in the Middle East, there is a huge development, let's say, in optometry field in terms of professional education. As I mentioned now, 20 years ago, we started in the entire Middle East in 1 university. Now we have more than 7 or 8 university. In terms of regulations, the optometry become stronger and stronger in all the fields. My experience, my journey, it was as an optometry in retail business. So during this discussions, I will focus more on not a clinical experience, on the retail experience, because here where I can really add value to the audience. So
thank you, Mr. Othman and the panelists. Just to give you a background of, since I did my optometry from India, at that time, optometry courses had varying durations, but yes, now as we speak, optometry is fairly standard 4-year courses for bachelors. There are a lot of options available to optometrists, whether they want to graduate and do masters, even research options are available. When I graduated, very few optometrists were looking at a professional career in the industry. And now I see a lot of them being very open to, they are part of professional services of various organizations, they are into research, they are they are in academia. So yes, and it is becoming a regulated profession also. So there is a lot of standardization which is coming in, and optometrists have a bright future. So that's why more and more youngsters, when they graduate or from their schools, they want to become an optometrist and adopt this as a profession. So panelists, thank you for sharing your views. But another question is, when you moved on to UAE from your respective countries, what differences did you observe from the way optometry was practiced back home to what it was in UAE? Any of the panelists can answer this. Begin with.
Okay, let me start. Okay, yeah. So given my clinical training and background, or practice background in Nigeria, moving to the UAE, I felt like our scope became narrowed, really narrowed in scope, especially because we were in the retail optical sector and not in the hospital. Yeah, because a few of the Nigerian I met had managed to move from the retail sector to the hospital. And so those ones, even though their scope is still a bit limited, but they had more access to instrumentation and interpretation of results because they're working with the ophthalmologist now directly. But in the optical retail sector where we were, well, we just noticed that you have, first of all, you have a very limited time to deal with your patient. So you don't have all the time to engage with your patient in a more clinical setting that you're used to back home. And then like I said, scope is reduced. You just focus on refraction and then dispensing of contact lens or fitting of contact lens and dispensing of spectacle lenses. So scope was reduced. And I struggled with that a lot because at some point I would have this friction with the sales team saying I'm taking too much time with patients, because I come from a background where we take time with patients, educate them, we do a lot of things. So, but after a while, I got to adjust into that, spending less time with patients, but at least quality time, given our background. Then I also realized that, well, in the UAE, because there are no optometry school, I quickly noticed that there were no locals who were optometrists at the time. I don't know about now. At the time, there are no locals who are optometrists. And what that means is that optometry will get really, really, really little attention from the health sector. Yeah, so these are what I noticed. And while I was not really happy with that, I felt my other skills would become rusty. So I took up my master's immediately to keep me studying. So I did my master's in, of course, public health. Then in my thesis, I did my study in color vision deficiency in Alain, because I was in Alain at the time. So I looked at color vision deficiency amongst the male drivers in Alain. And that was my thesis I submitted for my MPH. And yeah, so, and because I wasn't satisfied, I saw myself moving from practice into academic. So I became more and more focused in developing my career path in academics, which I still am till this moment.
That's very nice, Mr. McCleary. Good to hear from you, your views. Over to Ms. Daisy, Mr. Uthman.
Yeah. For me, I think clinical setting is the same since I started working in an optical shop. So for me, there's really nothing change or whatsoever. It's the same. It's just like from the Philippines to here, my practice is the same. It is just like that. One more thing, aside from the practicing in an optical field, optical facility, is we Filipino optometrists here, we are with the organization, which is the Integrated Philippine Association of Optometrists, which is the only organization accredited by the Professional Regulation Commission in the Philippines. So this organization is focusing mainly on. Oh, by the way, it was a CPD provider. The EPAO was accredited by the PRC as a CPD provider, or the Continuing Professional Development, and has embarked on continuing education programs since then in compliance with the Code of Ethics for Optometrists. So the mission is to help Filipino optometrists gain global recognition in their practice for our fellow men by providing quality service, adhering to standards and ethical practices for our colleagues, by fostering an environmental collaboration, mutual respect, and sharing of expertise and skills for the betterment of the profession that we are engaged in. So, the organization has survived the test of time, and while it has adapted to changes for several decades, emphasis from sight to vision, from spectacle peddling to refraction, to brain injury rehabilitation. Optometry in the Philippines has indeed evolved to what it is today through sound leadership, good governance, transparency, regulation, and education. And all these accomplishments, the Integrated Philippine Association of Optometrists has been in the forefront of active change and evolution to make Philippine optometry what it is today. For almost 45 years, the organization members have remained faithful to its vision and identity as a true representative organization of the optometrists. So by the optometrists and for the optometrists.
Thank you, Ms. Daisy. Thank you, Ms. Daisy. Mr. Othman, your views.
From my side, because I came from the same region, from Middle East, to be honest, I'm not seen or feel a big difference between what I was practice in my home country and in GCC, because we are always sharing a lot of cultures. So I not feel a big difference, except that's here in, let's say, in UAE or in almost Gulf countries, we don't have like a strong association or a legal association to influence the Ministry of Health for example, empower more the optometrist or sometimes changing some rules. So here everything coming from up, which is from Ministry of Health, while in our country we have our own association and the society. Through that society, we can, or we have a power with the limit power, but at least we have some power to make a change in the regulation of the optometry in that country. And we success a lot there to get a lot of benefits for optometry, while here, yes, in UAE, by the way, it's well regulated comparing to others country in the Middle East, but there is always room to improve. And as optometry, we don't have that society to influence the regulatory borders to change some regulation to empower optometry.
Thank you. In fact, just to add to what Mr. McCleary said, currently, yes, UAE doesn't have a school of optometry. And in fact, one of our participants have also mentioned the same. Also, while I understand, possibly when you have a clinical background and you move into dispensing and optics, one might find that, it might have restricted, as possibly was the view which Mr. McCleary shared. What also happens in the process is that, your other skills get developed, which possibly would have not got the kind of due attention they deserved, especially the dispensing skills, the optics part, which you would have really found taking precedence when you were practicing in UAE.
Very well.
Yeah, and in fact, even things like, engagement and understanding customers, these are the skills, the softer skills tend to be taught more than only the clinical skills. So it's kind of makes you, if I look at that way, a well-rounded professional in some way. And in the interest of time, this is my final question to all of you. What would be your piece of advice for the new optometrists who are either just come to UAE or want to practice in UAE? What would you advise them?
If we start with me, because I have a retail experience for all my life, so I can advise any optometrist want to come to UAE and join any, let's say, not a clinical, retail business. And maybe here I'm going to add more what you mentioned, Mr. Niraj. That's to success in retail, you need to complete the customer satisfaction circle. When I say complete the satisfaction circle, one point is the improve the skill of optometry to get a good and proper refraction. This is the first point to success in the retail. Yes, I totally agree with Mr. Hillary that we have a lot of limitation because in retail, we not do a full optometry. Actually, I can call name us in retail like a refractionist more than fully optometry. So I totally agree with you. But as I mentioned by Niraj, there is a lot of skills you need to development in order to grow and to success in retail business. One of the most and the key success there is the dispensing skills. So for any of my new colleagues going to come to UAE and working in retail business, please work hard to improve your dispensing skills. Without dispensing skills, you are not going to complete the circle and to fully satisfy your customers. The third, and which is not least important than others, is the try to involve more and more in business. Yes, retail, you need to have a business mindset, and it's very important to satisfy your customers, not only for you to grow, also to satisfy your customer. Selecting the right frame, selecting the right collection, the way, as you say, the selling skills, the engagement skills, managing the store itself. All these skills is really important for the optometry to success and grow in the retail business. And I can say one point here. Without business mindset in retail business, you will not grow.
Thank you, Mr. Othman. In the interest of time, my humble request to other panelists would be that if they can be brief and give us their views on the subject.
Yeah. I agree with Mr. Othman. It's a totally, this is our core. Our core as an optometrist in retail market is develop, or the mindset of the retail is different from the clinical or hospital setup. So our core is to be focused in our refraction, because that is our main core as optometrists, the refraction and the dispensing and the troubleshooting. It's all there. So I definitely agree with Mr. Othman. This is what we are, where we are right now in the setup of the retail. I'm talking on the retail side because I'm actually working on the retail ever since. So yeah, I can say that troubleshooting is definitely one thing to focus, and the refraction. Yeah, selling is second, but focus on your refraction. That's all. Thank you.
Sure, thank you.
Okay, I'll say, I can say this too. Yeah, I think I agree, totally agree with what you other panelists have said. Given that in the UAE, the optometrists have about 95% chance of working in the retail sector than in the hospital sector. So if I have any colleague coming in, so I tell them to prepare their mindsets towards soft skills that they could use to grow in the optical retail sector. Like my other colleague has highlighted, it has to be patient-centered. And so once it is patient-centered, it will help you to, because there's a popular saying that goes this way, that a satisfied customer is your best advertiser. So in the bit of growing the business, or meeting financial targets, you have to put your patient in the center, make sure that they are satisfied so that they can make more visits and referrals to you. And that way you meet the financial target of the organization. So yes, it's more about And making it patient-centered means you have to understand, customer relationship, and then customer management and all of that. So it will be more of managerial skills coupled with your technical optometry skills, which is different than when you're in the hospital settings. You're mostly to thrive in clinical environment. But now in the optical sector, you'll be a manager of patients, and also you come to soft skills in sales and general management too.
Thank you, Mr. McCleary. Thank you for to the panel for their sharing their valuable views with us. Over to Mr. Swarna Kamal for the closing comments.
Thanks, Mr. Neeraj, and all the panelists for sharing your experience in the journey of optometry.
It was a wonderful discussion, which we hope will be useful to many who are planning to start their career in their respective country. We hope this webinar created an opportunity for young optometrists to meet pioneers of the field from all over the world. Now, I'd like to call upon Dr. Amna Almazmi from ESO to speak a few words.
Hi, everybody again. I think this had been an amazing opportunity for us in ESO and the optometrists who are practicing here in the Emirates, as well as in other parts, to come together. I think I believe that the organizing committee had done an amazing work behind the scene to do all this collaboration, because it does not come out of free. It's the time and the energy, the enthusiasm that everybody had put into this amazing work. I speak even from understanding how conferences are run. It's not an easy task. It's not like attending as a member of the audience, but as the effort is just amazing. The energy that you brought up, the time that other people had took to share the place with us here as well, I think is showing us all that we are capable of spreading the knowledge that we have earned throughout the years. This is something that we know we can give constantly, and it gives us happiness in return. So I absolutely salute every one of you for the amazing work that you had demonstrated. And obviously, I take this opportunity to remind you all of the amazing conferences that are happening here in the Emirates, especially ADOR. It's happening early in the year on the 20th of January. And following to that, we have the Emirates Society of Ophthalmology, where people from all over the world, they get to come, and we hope to meet you guys in person. Now that COVID restrictions are being lifted, it's time for us to have that one-on-one and face interactions. It makes the value of our community even stronger. Us as ophthalmologists, we cannot thank you guys enough. You make our daily work a heaven. And keep doing what you do best. And thank you very much. And I really hope to have more opportunities to collaborate with every single one of you again. Thank you. Really, thank you.
Thank you, ma'am. Thank you for your support. And thank you for your time.
Always a pleasure. Always a pleasure. Come on.
Now I'll call upon Ms. Sana for giving vote of thanks. Thank you all for all the participants, and happy World Sight Day to everyone. Over to you, Sana.
Good evening, everyone. As we come to the end of our session today, I would like to take this opportunity to thank our speakers who have spent their time in helping us improve our knowledge. They have shared their experiences and enlightened us with the trends of practices in eye care. I would also like to take this opportunity and thank Dr. Omnia Hammam from ESO to help us getting CME accreditation points for this session. I would also like to thank our sponsors, Ion Care, and Atomic Drugstore, and all our organizers who have worked behind the scenes to get this event a success. Also, to get your CME points, we will be sharing a feedback form on your registered email address. Kindly fill in that feedback form to avail your CME points, and your certificates will be on your email. Also, we would like to announce that we will soon be having offline session and continue to have online sessions like this. Stay tuned with us while we sign off for now until next time we meet again for our next webinar. Happy World Sight Day to all. See you all again. Goodbye until we meet again.